I'd like to get us started. So I declare open this hearing of the Community Affairs Legislation Committee into the 2025-26 Supplementary Budget Estimates. I begin by acknowledging the traditional custodians of the land in which we meet today and pay my respects to their elders past and present. I extend that respect to all Aboriginal and Torres Strait Islander people here today. The committee has fixed Friday the 28th of November 2025 as the date of return for answers to questions taken on notice. The committee would appreciate if senators could provide any written questions on notice to the Secretariat by Thursday the 16th of October 2025. The committee's proceedings today will begin with the Department of Health, Disability and Ageing, Whole of Portfolio and Corporate Matters. The committee will be conducting today's hearing in person and via teleconference. Under Standing Order 26 of the committee, must take all evidence in public session, and this includes answers to questions on notice. I remind all witnesses that in giving evidence to the committee that they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such action may be treated by the Senate as a contempt. It is also a contempt to give false or misleading evidence. The Senate has endorsed the following test of relevance of questions at Senate estimates hearings. Any questions going to the operations or financial positions of the departments and agencies which are seeking funds in estimates are relevant questions for the purposes of Senate estimate hearings. I remind all officers that the Senate has resolved that there are no areas in connection with the expenditure of public funds where any person has a discretion to withhold details or explanations from the Parliament or its committees unless the Parliament has expressly provided otherwise. The Senate has resolved also that any officer of any department of the Commonwealth shall not be asked to give opinions on matters of policy and shall be given reasonable opportunity to refer questions asked to the officer and superior officers or to a minister. This resolution does not preclude questions asking for explanations of policies or factual questions about when and how policies were adopted. Witnesses are reminded of the Senate's order specifying the process by which a claim of public interest immunity should be raised. I incorporate the public interest immunity statement into Hansard. I remind senators of their obligations under the Behaviour Code for Australian parliamentarians to treat witnesses with dignity, courtesy, fairness and overall respect. An officer called to answer a question for the first time should state their full name and the capacity in which they appear. I remind committee members and witnesses who are appearing via video conference and who are not speaking to mute their microphones. Live captions have been enabled for the duration of today's hearing. The feed will be displayed on selected video conferencing monitors to the witnesses at the witness bench, at the back of the room and in the waiting room. We ask witnesses to please inform the Secretariat if at any time during the hearing you are experiencing any issues, and they will endeavour to troubleshoot them as quickly as possible. I now welcome Senator the Honourable Malarndirri McCarthy, Minister for Indigenous Australians, representing the Minister for Health, Disability and Ageing. Minister, do you wish to make an opening statement?
Thank you, Chair. I too would like to acknowledge the traditional owners for this country and pay my respects to elders past, present and emerging, and also thank the committee in advance in terms of closing the gap outcomes. It is critical that whilst we look at health across the board for all Australians, I am very pleased to see that closing the gap health outcomes will also be in this section, and acknowledge history being made today with you as Chair, an Indigenous woman from Western Australia. Congratulations.
Thank you. Thank you, Minister. I now welcome the Secretary of the Department of Health, Disability and Ageing, Mr Blair Conley, PSM. Mr Conley, do you wish to make an opening statement?
No, thank you, Chair.
I now call officers of the Department Health, Disability and Ageing in relation to the whole of portfolio and corporate matters, and I will start with Senator Ruston.
Thank you. And thank you for the information you've provided. Although it's always very difficult when you get it the morning of. We had actually asked for that on Tuesday, so unfortunately it will take me a while to be able to prosecute some of the information you provided, but thank you. Just in the interest of understanding, I have a question in relation to a constituent of mine who's given me permission to discuss his case publicly, but it relates to a DSOA. He has a DSOA entitlement, and it also relates to an ACAT assessment that he believes has been wrongly put in place. So I'm just interested to understand, because it sort of crosses over between the Department of Health and health in terms of his DSOA, as opposed to ACAT for ageing or aged care. Just wondering, where would you be suggesting that I ask the questions?
Look, I think obviously we are always cautious about talking about an individual.
Well, he has given me his permission. He's watching at the moment, and he wants it to be.
Well, he hasn't given. Sorry.
I will provide that to you. And I can ask him if he would write to you and give you permission as well.
Well, I think that would be the first step we'd have to take. We'd have to have written permission from that person, and even then, I think we need to be cautious, because talking about an individual in this forum is very difficult, because we might have part of the information provided in this session, but there might be a lot of other information, and there may not necessarily be consent to the release of all that information. But I think the appropriate time to raise that would be in the first instance in the aged care segment, which is later today.
I mean, I'll get him to send you a message to say that it's okay to actually speak about him. But in the absence of that, I'm more than happy to talk about the process that has occurred, and to seek your understanding as to why this particular issue has continually failed to be remedied, despite the fact that the Ombudsman said that he was in the right and the department was in the wrong. So would that be outcome 1 or outcome 2?
No, it's outcome 3.
3. So aged care?
Aged care, yes.
Okay, so DSOA comes under aged care.
So DSOA.
I don't know what it is.
Sorry.
Disability support.
Oh, disability support. So
Outcome 4.
That's actually outcome 4. So what I suggest is we start, if there's an ACAT assessment involved, we start in outcome 3, which is aged care.
Yep.
Outcome 4 is actually coming before the committee tomorrow.
Yep.
But if we can at least understand the aged care dimension to it through ACAT in outcome 3.
Okay.
And if you can, if they can provide that consent and we know the circumstances, then we may be able to be more helpful. But I do stress that we are very cautious about talking about individual cases.
Yep, no, that's absolutely fine. But, this has been going on for some time. This man is likely to die before you resolve this case. So I don't think, given that he and I have tried every course of action to try and get this remedied, that I will allow you to make the judgment as to what you choose, clearly. Okay, so corporate. Just quickly checking, since the election, have you got a number in terms of the changes of ASL in the department?
Good morning, Senator. Rachel Balmano, Chief Operating Officer. So the current headcount of the department as of 31st of August is 7,478.
Sorry, 7,000?
478.
And is that an increase since the election in any way?
Yes, that is an increase since the end of June figure.
Okay, and how much is the increase?
348.
348?
Since 30 June.
Okay, can you give us, what about the 30th? Have you got the numbers since May?
No, I don't have that in front of me.
Okay, would it be possible for you to give us an update from May, and also a brief outline about the main areas that the additional staff have been appointed into?
Yep.
So how many people have been, disability staff have been relocated into the Department of Health and Aged Care?
And I should note that headcount increase includes the staff from disability and the reduction due to the staff from sport leaving the portfolio.
Okay, so if you can maybe just give us a bit of an in and out map,
yes,
that would be great. Have any agencies moved out of Health, Disability and Ageing Department since the election? So sport?
Yes, so sport, the part of the department that looks after sport, and the National Sports Tribunal and the other sort of sports agencies.
And that's been mogged to communications?
Yeah. Infrastructure.
Infrastructure.
Infrastructure is the first word.
Yeah, sorry. Yeah.
So that includes all the sport agencies, so Australian Sports Commission, Australian Sports Foundation, the Tribunal, and I think I might have missed one.
I feel like there's one more.
Yeah. But there were the 4 agencies that were sport related.
Yeah, okay. And was there a rationale provided around that mogging, apart from just that the minister happened to be going there?
Oh, well, I think the rationale, I mean, when sport was in the health portfolio, it was probably focusing as much on the link to preventative health and activity. It is true, though, that there's a lot of infrastructure projects associated with sport, both at the local level, for example, the Play Our Way program, which followed on from the Matildas, but also the lead up to 2032 Olympics and the Green and Gold Decade. So it's kind of one of those classic ones where there are arguments for it to be in health and there are arguments for it to be in infrastructure.
Okay, but my question is, was there a rationale?
That was the rationale.
Yeah, but in a written sense, in terms of a briefing document that actually explained why we have deprioritised sport for participation in a health context for building some change rooms.
Well, I'm not sure. I mean, certainly my conversations with the team that left is we're not deprioritising that. We're going to keep links. It's always the case when you have machinery of government changes. You can't co-locate everything in one department, and therefore you need to coordinate across government to make sure that those links are maintained on an ongoing basis. Yeah,
okay. Have any ASLs gone to any other departments apart from the mogging of the sport portfolio?
No, Senator.
No.
Okay, all right, thank you. So do you have a key priority list in terms of what you want to achieve in health in this parliamentary term?
Senator, I think, well, there's two
Actually, to that end, have we got an annual report yet?
No, Senator, we haven't finalised our annual report yet.
When are you supposed to have it finalised by?
By the end of October.
End of October. So that will be done?
Yes, Senator.
Senator, the way I'd answer that question is, it depends. I mean, our priorities, department government, but we provided an incoming government brief to the government, as is standard across the public service. That incoming government brief was FOI'd. A substantial proportion of that incoming government brief was released. Under that incoming government brief, it pointed to 5 key pillars of activity over the next term and beyond of government priority. The first was strengthening Medicare, so trying to deliver accessible and affordable Medicare.
So can I ask you, so in terms of what that as a strengthening Medicare as a headline, what does success look like for strengthening Medicare in the departments, like in terms of your KPIs or what you're trying to deliver? We'll come back to it, but that was one of 5, and there was also some other which we hadn't put in the pillars but are in fact kind of ongoing activities. So, for example, and I am going to come back to your question, I'm not trying to avoid it, but the 5 things didn't include, for example, the cross-cutting ongoing work on aged care, and when that incoming government brief was prepared, we weren't aware that disability was going to be brought into the portfolio, and so that incoming government brief was separate from the incoming government brief for disability. The answer to those strengthening Medicare is there's twofold. The first is we actually have a range of KPIs that come through the performance statements, which are prepared and then audited by the ANAO, and they put to issues that go to strengthening Medicare. But on top of that, we would look at metrics that track access and affordability to Medicare as key metrics for the department. Okay. Yeah, so, I mean, I'm just trying to understand what is this parliamentary term's goals in terms, if you want to say to the Australian public, the Department of Health and Aged Care and Disability and Aged Care, goals for this parliamentary term are 1, 2, 3, 4, 5. What would you say they are?
Well, I would go back to the incoming government brief and talking about access and affordability for strengthening Medicare. So one key metric would be outcomes on bulk billing rates. Another key metric would be the proportion of Australians that report that they were unable to access medical care because of cost. They would be the two obvious ones I would point to. The second pillar that we had in that incoming government brief was cheaper and better medicines available, and so a key metric we would be looking at is things like co-payments and out-of-pocket expenses for medicines. We'd also be looking at the availability of medicines, so that would go in part to the rollout of the health technology assessment review and the implementation of that to ensure that the right medicines are available in Australia.
We'll get to that.
Yep. The third pillar that was outlined in the incoming government brief was ensuring that we have the right workforce, health workforce, and that they're working to the top of their scope of practice. And so we will be monitoring obviously numbers of key professionals, in particular, not exclusively, but in particular GPs, and also the distribution of those, that workforce. And we'd also be looking at how we track the whether health professionals are working.
So can I just take, we've obviously, in terms of time, I'm just keen to understand how you measure this, and so where are these measures going to be delivered? What is your success? So you've said GPs and DPA.
Yep.
So what is your measure of success? How many GPs? When? Where? I mean, are those sorts of things
Yes, Senator.
able to be provided? Is it possible to provide?
So those are published in our annual report. The indicators themselves are in the portfolio budget statement from budget. The results against those indicators will be part of our annual report.
Okay, so there will actually be the targets in your annual report?
Senator.
And the times for those targets. Okay, well, I don't need to waste any of your more time outlining them. We'll wait for the annual report and talk to you about it in December. Can I just...
I have those numbers for you, Senator, in terms of the ons and offs since June.
Oh, okay.
The MOGs out were a headcount of 79 people left the department.
Out, and that was sport?
That was sport.
Yep.
No, that's just from the department, not the separate agencies.
Yep.
And the staff coming in with disability and carers, 496.
496, and that was disability. So in terms of health and aged care, there has not really been any substantive change?
Small reduction.
Okay, thank you. Thanks. Can I just ask you, well, first of all, what has been the expenditure of the department on advertising in relation to the strengthening Medicare and the...
So particularly in relation to some of the campaign work that's happened? Yep. So I'll just... Ms Ringwood is joining us.
Good morning, Senator. Leanne Ringwood, Assistant Secretary, People, Communication and Parliamentary Division. So the expenditure on the Medicare benefits campaign in last financial year.
What did you call it, the Medicare benefits campaign?
Yes.
Okay, so that's the... Okay, please, no, sorry.
That's our working title.
That's our working title for the campaign.
Yep.
So the spend on that campaign was $14.5 million, Senator.
14.5 million. And does that include things like your website and the like, or is that external expenditure on like your billboards and, legacy media?
Yes, so that doesn't include work on the website. That's done internally, Senator. So that expenditure is on things like research, creative development and media placement.
Okay. So in terms of the website particularly, the website was getting stronger after 40 years was the wording. Why did the department use that wording?
So we're talking about the old website?
Well, yes, we are at this stage.
Yes. So that was a website that was active during the 40th anniversary of Medicare.
Okay. That website then changed its wording to strengthening Medicare. When did the change of that website change from getting stronger after 40 years to strengthening Medicare? What date?
I'd have to take that on notice, Senator, the exact date.
Okay. Because, it appears it was sometime late March, early April. Would it be possible to determine that reasonably quickly?
So we'll see what we can find out for you, Senator, and see when we can come back to you.
So what was the basis of the decision to change from the 40, getting stronger to after 40 years to strengthening Medicare? What was the process that took place to make that decision?
I'd have to take that on notice, Senator. It's part of the regular website update process. It would probably be to do with the timing of the 40th anniversary and where we're at in terms of any live campaign activity.
Okay. Would it be possible to get any correspondence or communications between the Minister's office and the department in relation to the change to changing that website to strengthening Medicare? So that process of moving from getting stronger after 40 years, which was the working title of that website for quite some time, and then it changed to strengthening Medicare sort of like March, April this year.
We can check what there is, Senator.
Any correspondence or communication. Also interested to understand, on the getting stronger after 40 years, there's a whole heap of statistics. Is there any way that you could provide us information as to why the particular timeframes were used? I mean, as an example...
We have covered that at estimates before, Senator. So
but we never actually got the answer to it. So I'd be keen for you to maybe have, now you've had time to have a bit of a think about it, because it's not like it's the term of this government, it's just some arbitrary time that was chosen in that. So now, if I go on to that website today, strengthening Medicare doesn't come up anymore. It appears to go to something called About Medicare. So is there a different Google search on it or whatever? Because if you put in the same thing that you were previously coming up with, getting stronger after 40 years, it then changed just as you were going into caretaker mode to strengthening Medicare, which quite coincidentally also happened to be the government's campaign slogan in relation to their health policy promotion. And now when you go in there, it just comes up back with the old Department of Health sort of standard non-Medicare, coloured, branded, just says About Medicare.
So the website has always had the About Medicare content, and that gets updated as new changes come through. The other content was related to two particular things, the 40th anniversary and the campaign activity that Ms Ringwood talked about.
Okay, so I'm keen to understand.
So whenever we have a campaign, we have a campaign site that presents information relevant to that campaign, the campaign materials, helps consumers to easily find additional information about that topic.
Okay, so just quite coincidentally, Ms Balmano, the Strengthening Medicare campaign that was on your website prior to the election, during the election campaign, and post the election campaign for a small period of time, completely and utterly replicated the campaign imagery and messaging of the Labor Party. Subsequent to that, it is now returned back to what it was prior to that. You just referred to that you update and do things when campaigns are being run.
Yes.
This looks to me very, very like the department was mirror imaging what the government was doing during an election campaign. Your promotional activity looks exactly the same as the government's election campaign material. And you changed it at the same time that the government went into election campaign mode. This looks to me very much like the department has actually been either actively or coerced or asked to make your departmental communications reflect what the government was doing. Now, I'm not saying you did it, I'm just saying that's what it looks like here. So I'd be really keen to understand if you can provide me with a paper trail to show why you chose to do this incredibly coincidentally at the same time that the government was actually in election mode when they shouldn't have been using the Medicare logo, and I'll ask Services Australia about that tomorrow, or tomorrow. Can you defend the fact that the government, that the department was replicating the government's election campaign at the
The
same
department
time?
did not replicate the government's election campaign. The department ran a campaign that went through all the usual clearance processes.
Could you
for
provide that
campaigns,
for me?
including creative development, approval of those creative materials. That included the use of the Medicare brand, and that's the campaign that was run. When the election started, as with all of our campaigns, the campaign material was removed from all channels.
Okay, and you'll be able to provide me with that?
Yes, Senator, to the extent that Cabinet rules allow some of the
Senator
clearances
Ruston,
to
can
be
I
provided.
I'm sorry to interrupt. Just check how much longer you might need on this call. I'm going to share the call with Senator Steele-John. He just wants some clarification.
Yeah, sure, please. I'm happy to join.
If that's okay.
Yeah,
thank you, Senator Steele-John.
Thank you, Chair. Good morning, everybody. Good to see you. I just want to ask, I've got some questions around the outcomes of the last Health Ministers' Forum meeting. I get the sense that this might be actually the best place to ask them, as the outcomes that I'm interested in exploring across a few different areas. Do you think that would be the appropriate place to ask them here in the day?
Well, subject to guidance from the Chair, happy for you to ask the questions, then we can work out whether it is the right place. I mean, obviously the Health Ministers' meeting is broad-ranging at one level, but each item is quite specific.
Yeah, that's why I wondered. So it goes to the question of ADHD diagnosis and prescribing. The last forum resulted in a communique that stated clearly that there was an intention to develop nationally consistent guidelines for diagnosis and prescribing in relation to ADHD, and a commitment to commission the development of a nationally consistent set of rules. So my first question would be, who will be developing these rules?
I'm just thinking it's probably outcome one.
Which we're moving
to after this.
Which will we move?
Yeah, so it's not a sort of cross-portfolio and it's not a corporate issue. So it'd be outcome one would be that where that come up. We can alert people to make sure that they're ready when we come back for that.
Fabulous outcome, wasn't it? Well, that clarifies that, Chair.
Excellent.
Thanks very much.
Well, that was short and sweet. Thank you for facilitating that, Senator Russ, and I'll hand the call back to you.
Okay, so just quickly to finish up on this, so if you could provide me the complete timeline in relation to the 40th anniversary strengthening Medicare, and now when I just Googled, if you go on to search the URL, it actually says page not found. So the strengthening Medicare page apparently has just disappeared. So if you could let me know when it disappeared, that would be terrific. So yeah, a whole timeline. If that was possible to get that today, because as I said, this is looking awfully like political manipulation. And also, does the minister approve these campaigns, or does he have no knowledge whatsoever of a campaign for? Would you say it was? That include? I mean, it's 14.5 million, as well as whatever you've spent internally on this particular campaign. Does the minister have, what is the process in relation to the minister's involvement in any decision making?
It is the same as it has been for many successive governments, where there is a government approval process for both, for content, for expenditure, for the actual campaign materials.
So the minister approved this campaign?
The government approves the campaign.
Okay, so the government, so it's a cabinet process?
Yes.
Yep.
Senator.
Okay. So
Can I just add though, Senator, because I'm familiar with this, there is also an approval process where I as Secretary have to sign off on any campaign to attest that it meets the guidelines, the government communication guidelines.
Yes.
And that process, I receive attestations from, well, the comms people can give the full list, but there's a legal clearance, there's information on how campaigns are tested with target audiences to see whether they're actually effective.
And the advice of the Independent Communications Committee
I'm only
informs that.
asking about the timing.
Yep.
The timing is just so wildly coincidental that this was up and running as a campaign during the election period, and now it's gone. So it wasn't up before, it's not up now.
The campaign was not operational during the campaign was not operational during the caretaker period.
So if I went onto that website during the election campaign, there would not have been a strengthening Medicare.
the phrase strengthening Medicare might have been used because it was used in quite a number of policy decisions and announcements prior to the election.
Okay.
But the campaign materials were not on the website during the election, during the caretaker.
Okay, so the Strengthening Medicare website that previously was Getting Stronger After 40 Years, that changed to Strengthening Medicare, was taken down before the campaign started. Is that what you're just telling me?
So the campaign website was not active during the caretaker period.
Okay, so you're telling me that the website that now
The department still had information about government policies, government programs, including obviously Medicare.
Okay. I'd really like the time frame.
Yes,
I'd
Senator.
really like to understand the communications that occurred between the minister. You don't have to tell me what they were, but I mean, like in terms of,
Senator.
you know, what the approval process, when did the cabinet approval process occur? I'm not asking you what that was, but when it occurred. Because, as I said, this looks awfully like the department was replicating the government's election campaign. Did you want to ask a couple of questions?
Can I just ask just a couple of follow-ups? This is probably something you'll have to take on notice. How many specialised campaigns has Medicare run in the last 4 years in total? So we've got Strengthening Medicare, we've got the 40th anniversary. So how many specialised...
Yeah, so Senator, the 40th anniversary was not an advertising campaign.
There's quite a formal definition of campaigns in terms of the Australian government communications
So
guidelines.
we'd have to take that on notice, but there has been obviously campaigns run to support the urgent care clinics program as well, and there's been 2 phases of that campaign run to date.
And then if we can find out exactly how much has been spent on each of these, I guess, micro campaigns, whatever you would call them, that would be really helpful as well, because I think that 14.5 million amount didn't include website.
No. We do our website work internally.
But I guess it still costs the taxpayer dollars because they're paying for that. Yeah. So that would be good to get a number for that as well.
I don't believe the website development is something we can separate out, but the other costs that you've mentioned, absolutely. Okay. The other sort of campaign type activities.
Have a go.
Yes.
You would have to have some kind of idea. You know, I guess private businesses have to know how much they're spending on website development and so forth.
We do, but it would be for all of the department's website.
But every time you're changing something, there would be graphics. I'm sure it's...
Which we do internally. So we have teams who do that work.
Yeah, no, I understand that, but you still have to pay those teams. You would apportion a certain amount of their work time to it. So, like with graphic design, they would keep hours of what they're spending on each project, surely? Are we running
I
this
don't think we'd be able to disaggregate the time of the teams for our
Okay.
graphic design or our web teams.
How about give us a costing for what
We don't have a chargeback model. We don't have a...
Okay,
it's-
if you've got a graphic design team and a web team, what does it cost to have those teams going per annum?
Certainly.
Yeah, that would be helpful. Sorry.
Yeah, no, you're fine. And look, just finally on this particular issue, like in terms of the information that's been contained on this website, and I know we did traverse some of this at the last estimates. I draw your attention to the national bulk billing rate graph that was on that page that now has disappeared. The government's own advertising guidelines, which I assume, Mr. Comley, you're the one who has to sign off on ultimately. It says, and I'll quote from it, in demonstrating compliance with the principle in relation to presenting an objective, fair and accessible manner in terms of the information, demonstrating compliance with this principle, consideration, including basis of factual comparisons, is clear and does not mislead the recipient about the situation. Now, in your graph, you start at this arbitrary date of July 2023. Would you concede that in July 2022 that the bulk billing rate was 88%?
So if we want to have I'll rephrase that. We're happy to have a conversation and get people to the table to talk about bulk billing rates at particular periods of time, but I wouldn't...
No, I'm not. I know that's not what I'm asking for. I'm asking in the advertising guideline principles, it says that you need to provide information in a way that you can make an objective assessment.
Yeah.
I would contend that anybody reading that graph would look at that and say, wow, there's been a significant increase in bulk billing rates. And yet if you had put the graph for a year prior to it, you would have seen a plummeting of bulk billing rates in that period of time. But for some reason, you've made a decision to start using data from a period where it actually provides if you look at that, you think, oh, yeah, that looks all right. Whereas if you actually had shown it from a year previously, you would have seen that it was absolutely plummeting. So I'm just keen to understand whether you, as the person who signs off on this ultimately, believe that this meets the guidelines of providing clear information that does not mislead the recipient about the situation.
Well, first of all, if it's part of the campaign, I sign off and I get attestations from people who look at every detail to say that it is. I personally, over time, lots of data is presented with different time periods. That's not unusual. It's a matter of judgment. I don't think that's misleading.
Okay. All right. And so, once again, the fact that you were running a campaign prior to the election period that was the exact same campaign that the government then chose to run as their election campaign, you contend that's just a coincidence?
Well, we certainly had no intention of, I won't use your words, we followed our usual process of what we thought was appropriate to put on our website and have in a campaign with all the usual checks and balances, and I think that was done appropriately.
Okay, thank you. I'm sure that I would contend that it doesn't look like that, but when you provide that information, maybe you'll be able to show me the independent process that you went through and that they're no influence by the government.
Thank you, Senator Ruston. We will now move on to outcome one. So we're heading to health policy, access and support. Thank you. And cross-portfolio Indigenous matters for the first time. I now call officers from Department of Health, Disability and Ageing in relation to outcome one, health policy and access and support, and invite questions. I think can you go to Senator Steele-John?
Thank you very much.
Oh, yeah.
All right. So I'll have a crack at the ADHD pieces. So we have had a meeting of the National Health Ministers, and that meeting resolved to commission nationally consistent guidelines in relation to diagnosis and prescription for ADHD. And I would like to know, first of all, who will be developing these rules.
Professor Anthony Lawler, Deputy Secretary, Health Products Regulation Group. Hello again, Senator. Thank you for the question. So, as the Secretary highlighted earlier this morning, this isn't a cross-portfolio matter, but it is a matter that engages a number of different groups within the Department of Health, Disability and Ageing. As previously discussed, when I was simultaneously in the role of Chief Medical Officer and also Deputy Secretary for Health Products Regulation, we took on the role of consulting with key stakeholders, including states, territories and peak bodies and medical colleges around the current landscape, which includes matters such as what is the prescribing process, what is the authority to become a prescriber in jurisdictions, what medicines are allowed to be dispensed and in what quantities, and also what cross-border arrangements are in place, which is particularly important for places like Tasmania and Northern Territory, but also, of course, when you're living in a border area. What we found was there a significant variance in practice across, but what we also found was that there was a real willingness in states and territories to, in many instances, liberalise the access, because, of course, this is an issue of balancing safety and quality versus the ability to access treatment. So it was a very useful conversation, and it gave us the ability to understand the landscape. We've incorporated that and, as you mentioned, advised the Health Ministers meeting on the matters that do relate, and what has come of that in terms of the communique that you've cited is that there was an acknowledgement of the reforms already announced by several jurisdictions and that there was an endorsed need for national harmonisation of ADHD diagnosis and prescribing practices and that there had been work commissioned to develop nationally consistent rules with a progress report to be provided at the next HMM. Now, the challenge is, of course, that this is happening in at the same time as a number of other scope of practice pieces of work. So I do have at the table with me Eliza Strapp, who might be able to add to that.
Hi, Senator. Eliza Strapp, First Assistant Secretary, Health Workforce Division. So as Professor Lawler just outlined, we are undertaking a range of things around scope of practice for health professionals. And part of that, it came out of the scope of practice review that was undertaken by Mark Cormack last year. Part of that was a recommendation around harmonisation of drugs and poisons legislation. So as part of this, and as detailed in the communique on health ministers, we are working with our state and territory colleagues, and part of that work is, I think, fast-tracking the ADHD work to harmonise, to make consistent how we treat and diagnose and prescribe different ADHD and other things that can ensure that our health workforce is working to its full scope of practice.
Okay. So just to be clear, when it says there's been a work that has been commissioned,
yes,
who specifically has been commissioned to do that work?
It's a joint piece of work between all states and territories. The Commonwealth is, we're setting up a working group that's working with, because it doesn't just sit with, I guess, one area in jurisdictions. So we're setting up a working group that will be working across health departments. And the Commonwealth is leading that setup of that work, working in conjunction with the Health Workforce Task Force. That's a subgroup of the Health Chief Executives Forum.
Okay. And when will that working group be established?
I believe we're in the process of setting it up. I'm hopeful that it'll be this month, Senator.
Okay. And when will they complete their work? When are they expected to complete their work?
It's probably, I think we want to fast-track the ADHD work as an example. We've got to come back to health ministers with an update in October. I think a lot of work has already been undertaken. We've got some good examples from states and territories who are ahead of doing things. So what we want to do is build on what's already happened. And as Professor Lawler just talked about, a lot of work has happened in across jurisdictions. I think we have to, obviously this does mean updating legislation. If you look at where each state and territory is up to at the moment, they're at varying levels. Some haven't legislated to change who can prescribe yet. I think we probably need to take stock of where things are up to, but we do have to report back in December. But I acknowledge we want to, I guess, fast-track the ADHD work ahead of other scope of practice or drugs and poisons work that we're doing.
Okay.
Sorry, that's not a clear answer for you.
If I may, Senator, and I think I've highlighted to you previously the challenges in the prescribing landscape across the country, that the TGA establishes the schedule for certain medicines, but it is state and territory poisons and medicines legislation that enact the ability to prescribe and the conditions and restrictions that apply to that, and that's particularly the case for S8 drugs.
Yes, of course. Okay, so we've got a working group that will be working to a timeline of December to deliver back to a subsequent meeting a proposed draft. Is that the intention of the working group?
I think it would work. And I'm saying this before the working group has actually met. I think the hope would be provide a framework of what the work would be that needs to happen in order to create national consistency around ADHD prescribing and treatment.
Okay. Thank you. So we don't have a time frame yet of when we would hope these nationally consistent rules will come into effect?
Not yet, Senator.
Okay. The communique said that there will be consultation on these new rules with relevant stakeholders. Will this include people with lived experience of ADHD themselves?
Without having the working group met, I would probably, I think consulting consumers on changes that affect them is a sensible idea. So, I would say that would likely happen, yes.
Yes, consulting consumers is a really sensible idea. Can you table the terms of reference for the working group? Is that possible?
When we have developed them, yes.
Thank you. Multiple states have recently, as you acknowledged, made announcements in relation to this area, either bringing them into effect or flagging an intention to increase access to diagnosis and prescription via an expanded GP pathway. To clarify, is it the position of the Commonwealth to support increased access to ADHD diagnosis via diagnosis and prescription via your GP?
I can't reflect specifically on that policy question, but I'm not sure if it would be helpful, Senator. I can reflect on some of the changes and some of the consultations that came of that. But on the question of perhaps Ms Shakespeare?
Penny Shakespeare, Deputy Secretary, Health Resourcing. The Commonwealth supports reforms that will make sure that our health workforce is operating closer to the top of the scope of practice. We're consulting about whether or not specifically ADHD prescribing is currently supported for health practitioners, including GPs, to operate at the top of their scope of practice. I think the consultations that we've seen so far indicate that GPs could play a much greater role in access to medicines to treat ADHD.
Okay, thank you. What has that principle that there is a greater role to play for GP here been communicated by the Commonwealth to states and territories?
So in various forums we have discussed, this is a reform that we would like to pursue collaboratively with them, including groups such as the Health Workforce Task Force, yes.
Okay. Can you guarantee that the national rules that are being worked on now and hopefully will be brought into effect once developed won't go against the state and territory decisions and intentions that have been flagged already in relation to increasing access to diagnosis and to prescribing?
Senator, I don't think we're in a position to offer guarantees. We're working collaboratively with the states and territories with the objective of nationally harmonised approaches to make it, clear and consistent for patients, for providers, about how they can access treatment.
Okay. Minister, are you able today to give some assurance to the ADHD community in Australia that are very excited about the potential of greater role for GP in both diagnosis and prescription, that your government's going to be backing them in their call for a greater role for GP in this space?
Thanks for the question, Senator Steele. John, Minister Butler has worked very strongly in this area, especially since the committee report that came down in 2023. We responded in December 24, and now we see the discussions at the national level with the states and territories. So there is absolute commitment by our government, especially in this area, and I give that commitment to the families out there who are wanting to see a way through this.
Thank you. Now, we are in a period of almost constant shortage of medication when it comes to ADHD, with Ritalin and Concerta currently flagged as in shortage, and only recently the community having gone through a period where Vyvanse was listed nationally as a medicine in shortage. And I've heard many times from my constituents that in local areas it's still very hard to access your Vyvanse medications. I'm aware that the government has approved overseas substitutes and replacements, but this is a temporary solution to what to me seems to be becoming a more long-term problem. So my question is this: is the government taking action to ensure that there is a long-term supply of these critical medications?
So thanks for the question, Senator. Nick Henderson, First Assistant Secretary, Medicines Regulation Division. Yes, we acknowledge that there has been an ongoing shortage across methylphenidate medicines. That shortage has been ongoing, particularly in relation to the modified release medicines. The TGA, we have been working closely with the suppliers of those medicines, and as you acknowledged, Senator, we have put in place a number of 19A approvals under our legislation for alternative overseas products, and many of those products are now also subsidised under the PBS. We also have convened a regular medicine shortages action group, which cuts across health professionals, the suppliers, and other key stakeholders involved in the supply of those medicines, and we continue to work closely with those. We are also working closely with the pharmaceutical wholesalers to ensure there is fair and equitable supply through those supply chains. I might refer to my colleague Dr. Fenner as well to go into a bit more detail in relation to other actions we're taking.
Thank you. Dr. Tali Fenner, Acting Assistant Secretary, Pharmacovigilance Branch, Medicines Regulation Division. So just acknowledging that we have taken, as Mr Henderson said, a number of actions in terms of approving overseas alternatives, and they are listed on the PBS. So that's for the Ritalin and Concerta shortages, which are in modified release form. The immediate release forms are available. We also convene meetings with our specific methylphenidate medicine shortage action group, and that includes medical colleges, health professional organisations, and through that we can work with those organisations to support them to develop some clinical advice. And we publish and communicate that on our website, and publish and communicate updates to the status of the shortages as they happen, because they do fluctuate. I note that you mentioned Vyvanse, difficulties with Vyvanse. The Vyvanse shortage has resolved at a national level, and we are working. We continue where there are shortages to work with wholesalers to ensure equitable supply. That's, I guess, there's just some of the actions that we can take. I think it's important, though, to recognise that we can't compel sponsors to make applications, either for an ARTG registered product or for an overseas alternative.
Of course. Thank you, Dr. Fenner. In relation to the Medicine Shortage Action Group, just to confirm, that group has discussed the shortage of these medicines.
That's correct.
Yes.
So we convened a specific medicine shortage action group on the methylphenidate shortages, and the Vyvanse shortages have wound up.
When did that convening of that group to discuss that issue take place?
That was, I think, the last meeting was in May, I believe. I'll just confirm that that's correct.
Senator Steele-John, I do need to share the call, so I'm happy to come back to you in the next round. Sorry, I'll wait for the official to finish up and then we'll share the call. Thank you.
Sorry. I'll just take it on notice. I'll be able to confirm that.
We'll come back to this in my next slot, so we can do that.
Thank you very much.
Thanks, Chair.
Senator Brockman.
Professor Lawler, I believe, gene technology regulation. In 2021, all of the gene tech ministers agreed to a reform process going forward. Can you give me an update on where that's up to? Did it continued, I assume?
Well, I'm just waiting for Mr Bedford, our First Assistant Secretary of our Regulatory Practice and Support Division, to come up. The gene tech policy does sit there. I would also note that we did have the Office of the Gene Technology Regulator on the list, but I think they were discharged earlier this week.
I'm more interested in where the legislation is up to from the department's point of view, to be honest.
Sure.
I mean, you would have carriage of the legislation rather than the gene tech regulator?
I'll ask Ms Bedford and Ms Chipley.
So I'm correct, am I, Mr Bedford, that 2021 there was an agreement of all the gene tech ministers to progress regulatory reform?
Thanks, Senator. Chris Bedford, First Assistant Secretary, Regulatory Practice and Support Division. Senator, I believe that is correct. Yeah.
So has that progressed? I mean, obviously there was a change of government in there, but...
Yeah, this has been a long-standing piece of reform that we've been undertaking. We've undertaken the first lot of public consultation and jurisdictional consultation on the policy and the initial draft bill. So that's been completed. That was, I might need to get the details from Ms Chifley in a minute, but it was completed late last year, and we've continued to do further refinement of that bill, and drafting has been going on with OPC.
And so can you talk us through broadly what you would hope that change would achieve in terms of the sector?
I might let Ms Chifley answer a few questions on the details of the bill.
And to be honest, my interest in this is not so much in health, Ms Chifley, but in I've had a long history in gene tech in the agricultural sector, and I know a lot of people are very keen to continue and advance research in that area. So I'm just keen to see if we're going to get an outcome here that actually fuels research in Australia in this area.
Thank you very much, Senator. Danielle Chifley, Acting Assistant Secretary of the Regulatory Practice and Support Division. The reforms that will be introduced through the amendments that will implement the recommendations of the third review of the scheme will be the most significant changes to the scheme since its establishment in 2001. It will make some changes to key terminology. The main feature of the legislative reforms will be to provide a more risk proportionate approach to regulation, and it will introduce the opportunity for authorisation pathways that provide for regulation that's appropriate to the risk for the organisms that are authorised through those pathways. So it will continue obviously having a licensing framework, it will introduce a permits framework, and it will review and reform the notification framework, and that will introduce productivity benefits from having different and appropriate timelines associated with the assessments required for those authorisation pathways.
Does this follow the New Zealand model, which in layperson's terms I think effectively creates a tiered structure where less dramatic changes to the genetic structure effectively require a less rigorous approach or a less technical approach to approvals?
Senator, I think...
That's probably butchered language for what I'm trying to explain.
We've been following a little bit of what New Zealand are doing, and the gene technology regulator is best placed because I know she's been following that really, really closely. But my general understanding is, look, we're introducing a risk tiering model, as Ms Chifley said, that the level of regulation and oversight is proportionate to the risk involved. So for...
So a relatively minor change would require less significant approvals process than a very significant change.
That's right. Some of the reform is looking at the assessment timeframes would be significantly less than they currently are. So hopefully the productivity gains Ms Chifley talked about will mean that there will be, more investment in gene technology in Australia because the regulatory burden has been reduced through this bill.
And so what's the time, you're going out to another round of consultation? Is that the plan?
Of course, that's the plan. So there'll be consultation on the bill once that the next stage of drafting has been done. We're working with OPC, to finalise those, the drafting, particularly around the risk tiering, which the sector's very interested in.
And you probably can't answer this, but would you expect to see it hit Parliament next year, or?
Look, we're doing everything we can to get it introduced as quickly as possible, but as you'd note, it depends on the other priorities that are coming through.
Excellent. That's all I needed. Oh, chair's disappeared. Everybody's disappeared.
Well, peace negotiation over there. Sorry, yes, I missed that one. Oh, Senator Polly.
Thank you very much.
Thank you.
Nice to have you in front of us again. I have some questions in relation to the progress of the standalone hospice in Launceston. If I can get an update, please. Thank you. Back in 2022, the federal government committed $20 million to work with the Tasmanian government to establish a standalone hospice in northern Tasmania. I just wanted to get an update. There's been some delays. That was in 2022. It is due to be completed in 2026. Could you give us an update as to where we're up to in terms of whether we've even moved into the designated site yet?
Good morning, Senator. Liz Devlin, Deputy Secretary for Primary and Community Care at the Department. So the progress to date includes a site selection, which is the Alambi building, which is in Howick Street. The building refurbishment concept design has been released, planning approval and the construction tender has been advertised. The construction, we understand, has been delayed as the Parliamentary Standing Committee in Tasmania on Public Works is yet to be re-established following the state election in Tasmania, so that seems to be the most recent delay, and they are required to approve the contract for the Launceston Hospice. So we are expecting now the practical completion in early 2027.
So can I ask whether or not the Alambi site was actually the one that was identified by Friends of the Northern Hospice some many years ago? Has the other Department of Health, have they moved out of that building, and is it in fact ready to start the renovations?
I'll see if my colleague has any further details, but as you're aware, the Commonwealth Government's role in this has really just been through the funding agreement with the Tasmanian Government, who are responsible for the delivery of the project. But I'll see if my colleague has any further details on what's happened on the ground.
And that would be really helpful, because then I'd like to know whether they've met the milestones and what money has already been allocated. Thank you.
Thanks, Senator. Ariane Herman, Acting First Assistant Secretary, Chronic Conditions and Screening Division. In terms of additional information, questions should be directed towards the Tasmanian Government, but I can give you some information on the money that has been provided. So the Federation funding agreement was executed on the 9th of June 2023, with $15 million paid to date of the $20 million. The final $5 million payment is due in June 2026 on acceptance of the progress report that Tasmania will provide to the Commonwealth.
Can you confirm whether it's actually a 10-bed hospice? Because there's some confusion that it is 12. I'm really happy to accept 12 beds, but if you can confirm whether it's 10 or 12. Please.
I'll need to take that on notice, Senator.
Right. And the milestone, there was supposed to be December 2026. You're now saying that it will be early 2027. Is there a benchmark? Is that February? Is that June 2027?
At this stage, we just have early 2027.
Right. Thank you very much. Thank you, Chair.
Thank you. Senator Nandaraja, I believe, has some questions.
Hi, thank you. It's great to see Closing the Gap outcomes integrated into the broader program, and my questions relate to the National Aboriginal Torres Strait Islander Suicide Prevention Strategy, the 10-year plan. If we could just wait for the officials to come. Could you please provide us an update, perhaps on the work that the Social and Emotional Wellbeing Policy Partnership is doing on this strategy? Thank you.
Senator Gavin Matthews, First Assistant Secretary of the Mental Health and Suicide Prevention Division. So the strategy was finalised and released earlier this year, as you know, and released by government. for that. So it's obviously been a long-standing piece of work for the update of that strategy that the Social Emotional Wellbeing Policy Partnership has contributed to the development of, actively of that strategy. It is something that the members of the policy partnership are remaining very actively engaged in. That we have formal meetings with the policy partnership, but we also have regular discussion with GADUI, who are really the peak, the peak organisation and sort of play the key role in coordinating that policy partnership and the process for that. So it is an ongoing piece of work that isn't just something that we take through for the formal meetings of that work. We are continuing to invest in the strategy, so we have an investment of around about 85.3 million that we invest in 25-26 in overall in Aboriginal and Torres Strait Islander social and emotional wellbeing, into suicide prevention and mental health generally. As you know, probably for First Nations people, they don't tend to separate health from mental health, from social and emotional wellbeing and from suicide. They tend to look at it very collectively from that point of view, and that is, I think, what comes through the strategy and something that we're actively trying to pursue as government and work with the policy partnership around to make that work fairly effectively. And that is everything from the work the department does to build the broader Aboriginal community controlled health sector and grow the ARCHER sector in particular, but also through the investments we make, particularly in mental health, where we've continued programs like the Culture Care Connect activity that's been funded for a further period of time, which is about 20 million a year, that particularly works for aftercare, and a lot of that goes into the ARCHER sector and other providers. And of course we have things like, continue to fund things like 13 Yarn, etc., that provide services for people.
Sorry,
and then
what was that last one?
13 Yarn, 13 Yarn, it's the crisis line specifically set up for Aboriginal and Torres Strait Islander people, similar to Lifeline, but run specifically for Aboriginal and Torres Strait Islander people for that. And that works in complementary with the investment that comes through the National Indigenous Australians Agency for Social and Emotional Wellbeing. So there's a body of work there that we're really trying to get the policy partnership's advice about how do we progressively bring that and integrate it more over time. And then, of course, there's the work that the Productivity Commission's been doing, reviewing the national the National Mental Health and Suicide Prevention Agreement, which specifically calls out that there is some further work needed specifically for Aboriginal and Torres Strait Islander mental health that will also give us a future thing. So there's a range of things we have been doing. The policy partnership's been guiding through the strategy what we're doing, activities that we're doing now, and then work that will be done through the renegotiation of that national agreement.
And do you have a close working relationship with the policy partnership?
Yes.
Your constant conversation?
Yeah, we work, there wouldn't be a week go by that we don't have some engagement with GADUI in particular.
Yeah.
We also work very closely with NACCHO as the peak body for the Aboriginal community controlled health sector, that are obviously a very, very significant part of that landscape as well, and a range of other organisations.
And are there new elements being drawn up as part of this 85 million, or is it funding of ongoing programs?
There are ongoing programs, but like most ongoing programs, you're also looking at what you can do within those programs to improve them over time. So it's not, we try not to do them as a set and forget program as well. So there are a range of things in there. Really, what the policy partnership is looking at, I think, is at that question of, well, how do you progressively take what has probably been where governments have probably put health in one basket, mental health in another, and then suicide in another, and then how do we collectively bring that together a little bit more effectively over time is the question I think that the policy partnership is asking us to think through. But that is a complicated piece of work, because obviously that's both the Commonwealth but also for the states and territories to do that collectively. So it'll be an active area under the renegotiation of the national agreement.
The government invested 9.2 million in the, forgive me if I get this wrong, Gadajini Centre in parallel with launching this strategy. Can you just go through how this investment will help with driving down the suicide rate?
Yeah, I think we can. I might refer to my colleague Ms Price to provide detail on that.
Hi, Senator. Kristen Price, Assistant Secretary, Suicide Prevention Branch. So the Gadajini Centre is kind of an expansion of the current Centre for Best Practice in Aboriginal and Torres Strait Islander Suicide Prevention, led at the University of Western Australia by Professor Pat Dudgeon. And they support a range of projects that kind of contribute to Aboriginal and Torres Strait Islander suicide prevention. So the kind of additional investment that you're talking about expands the investment for that and also merges in some other Aboriginal and Torres Strait Islander-led suicide prevention initiatives into one kind of large centre. Gadajini is the working name for that centre, so I imagine there might be some change to that upcoming as well.
Okay, and when you say best practice, what does their best practice look like that others can learn from? The core elements, maybe?
I don't have them off the top of my head, Senator, so I can get that for you on notice. But I think the kind of core components include kind of culturally led programs that are place-based and community-focused.
Okay. And just with respect to the workforce, how are we growing the First Nations health workforce?
There's a range of things through there. So, I mean, obviously we have a range of workforce programs already underway. So there were, in a previously funded initiative, some positions around 500, say, for example, psychology, placements, university placements additional there, and 500 traineeship placements. And so there was a priority given for those to prioritise access to, priority groups of which, of course, First Nations people are part. So that's an example of, for where we do have workforce programs, generally for each of them there's an element that is targeted towards First Nations workforce for mental health, but also for other, and then that applies into other disciplines as well. There are things like the Puggy Hunter Scholarship Scheme that run generally as well, and I probably also would note that there is also funding for a range of additional psychology positions that's funded through the National Indigenous Australians Agency as well. It doesn't come through the health portfolio, but will contribut to the overall health workforce.
And how many trainees or how many students are currently enrolled, do you know?
First, from a specific point of view for First Nations, I'd have to go and take that on notice and provide it. Senator, I don't have the detail with me today on how many of those specifically we have for First Nations across those initiatives. It would be a reasonable number, but we would need to take that away and add it up across all of the programs.
I can certainly say with the Aboriginal health practitioners, in terms of the 500 traineeships across Australia, we've certainly got over 400 in place.
Fantastic.
So there's some that are specific to the mental health that we probably run, and then there are broader ones across the broader health workforce as well.
Can you explain for the benefit of the committee why it's important to have culturally appropriate care, particularly for First Nations communities?
Look, from a mental health point of view, but I guess from a general point of view, which is consistent with every other aspect of First Nations health, which arguably which is broadly across social policy generally, is that obviously it is critical that there is clear evidence that Aboriginal and Torres Strait Islander people, their adherence and uptake of services is more effective and more likely to happen and more likely to be continued where you have high proportions of Aboriginal and Torres Strait Islander workers in those services, because obviously from a cultural understanding point of view, for people that are non-Aboriginal or First Nations, then you can learn lots, but obviously for people that are First Nations, their absolute understanding of that is so much richer than anybody else's can be. So having that workforce there makes people feel far more comfortable and understood, and they understand where the perspectives and the culture from where they're coming from, and are more able to tailor messaging and care to people in that context.
I imagine trust is important. Professor
Absolutely.
Kidd, do you have anything to add?
Thank you, Senator. Professor Michael Kidd, AO, Chief Medical Officer. Trust is very important, and increasing the number of First Nations health professionals is absolutely important for Australia, and not only people working in their own communities, but also the influence that people have right across the healthcare sector.
Absolutely, thank you. And just my last question, can you just talk us through how culturally appropriate care is provided? How do we train up that workforce? Are there training centres that provide this sort of specialist training?
I think...
yeah.
Yeah, no, sorry.
Who are you looking at there, but are you looking at Natalie? Or?
I am, yes. Okay. But anyway, as Mr Matthews talked about, we fund a range of organisations that are tasked with boosting the First Nations health workforce, and that includes health practitioners and health workers, doctors or medical doctors, nurses and midwives, and allied health, and they run a range of programs, but they also provide holistic support to those health workers and the health professionals. And they work closely with universities, with TAFE organisations, with vet organisations around the support that's delivered. In many cases, it's with Aboriginal community-controlled RTOs, but that run, culturally appropriate services, but also working very closely with universities, with TAFEs across the country around ensuring that their training and their support is culturally appropriate, and that we can, attract and retain a really high quality First Nations workforce. And we've had, I will say that we've had a really good increase in the number of health workers that are registered with APRA over the last few years. I think we've reached. Yep.
Sorry, Senator. Natalie Beak, Assistant Secretary, Workforce Planning and Strategies Branch. We have seen significant growth in our Aboriginal and Torres Strait Islander workforce. We have seen a 50% growth over a number of years, and we can provide those numbers on notice. In terms of the traineeship program that you referenced before, just to give you those numbers as well, Senator, we have the target was 500. We have 551 trainees who are registered. We have 289 that have completed 152 that have completed the training, 289 that are currently in the training program. But what we are also seeing is really strong employment outcomes. So the cohort is also, we have 85% of the cohort that is employed in Aboriginal community-controlled health organisations, 11% who are working within our mainstream health services under government, like hospitals that are funded by government and the like as well. So we are tracking this program very, very closely, working together with Nacho, who is delivering this program in partnership with Aboriginal community-controlled RTOs across the country.
That is fantastic to hear. What a good problem to have. Thank you.
No problem.
Senator Bragg.
Thanks very much. Some questions for APRA.
Yeah, they're coming. They're just upstairs. Yep.
Okay, thank you.
We're just waiting for the officials to come up.
The waiting room's on a different floor, so they're on their way. Won't be long.
Just how long will they be, Mr. Cromley? Because otherwise we could share the call.
Taking the lift or the chair.
Yeah.
They're downstairs. They're on their way, so it can't be more than... Well, we'll see how puffed they are when they get here.
Okay. Senator Bragg, if you'll entertain, Senator Little just wanted 10 minutes quickly, if we can go there first and then we can come to you to share. That's okay?
Yep.
That's fine. Senator Little, you have the call.
Thank you. This question is in relation to the financial management and work that's done on due diligence in relation to Aboriginal community-controlled health services. Can somebody talk to me about that, please?
Yep.
Yep, they're here.
Thank you.
Chair, we have APRA here now.
I'm all right for a little while, so if you want to go now and go, yeah, you
Sorry.
can go now.
Sorry.
No, that's absolutely fine.
Okay.
So, sorry, it's up to the chair.
Chair, am I okay to ask APRA questions? I think they're here. I'm in the hands of the chair.
If Senator Little's happy to hand the call back, we'll go to APRA with Senator Bragg.
Okay. Thank you.
Sorry for the jumping around.
Have you got your name tag? Great.
Morning, Senator Bragg. We are.
Okay. Now, your role is to maintain standards in the Australian medical profession. Is that right?
We certainly play a key role in setting standards in the, for health practitioners, yes.
Okay. And part of that is ensuring that patients feel that they are safe in the hands of Australian medical practitioners. Is that right?
Absolutely. It's paramount within our legislation.
Okay. Well, I mean, you would know that we are living through a period of extreme anti-Semitic material that's been circulated around our country, where Jewish Australians often feel that they have been targeted, including sometimes inside your profession. How many complaints have you had in relation to medical professionals engaging in anti-Semitism?
Sure, and you're right, this is a very serious issue that we're taking very seriously, Senator Bragg.
Okay.
And just from the outset, I want to call out as the CEO of the Health Practitioners Regulator, we have no tolerance for discrimination in the health system, whether that be against any form of discrimination. In relation to the conflict in Gaza that we're seeing at the moment, we've received 188 notifications since October 2023 that relates to 95 different practitioners.
95? Now, you also have a role in registering nurses, don't you?
Correct.
So, in relation to I have to say, some of the most outrageous things I've ever come across in my time in the Parliament was the statements from the nurses in the New South Wales system that they would kill Jewish patients and they wouldn't treat Jewish patients and that they would like to send them to hell. What happened to those nurses?
Yeah, so probably helpful to give a little bit of context about the national scheme and how that works. I'll keep it brief. We currently work in a federated system, so the power that APRA has comes off the back of state and territory legislation. There are some differences in that legislation, and one of the differences is most evident in New South Wales. What that means is, although we are the national regulator and we register practitioners nationally, it is actually the Health Complaints Commission in New South Wales that has the legislative jurisdiction to manage complaints around practitioners within New South Wales.
Nurses or doctors?
Both.
Both,
yeah.
Okay, so what about other states in terms of, let's say, doctors? In other states, you do have...
We do, absolutely.
You do, so you can deregister or you can issue sanctions?
Yeah,
okay.
Absolutely.
Now, I want to ask you about a particular matter concerning Dr. Omar Azam. Are you aware of this case?
I'm aware, so we're aware of the matter you're talking about, yes.
Okay. So the allegation here quite clearly is that this particular doctor has put red triangles over IDF soldiers, has said that Zionists are Zion Nazis. These appear to be extraordinary, disgusting statements to have made from a medical practitioner. So what has happened in this case?
I am under our legislation, we are bound by confidentiality of practitioners. So unless the matter becomes public through a tribunal hearing, publishing, I'm unable to talk specifically about any ongoing or closed matter. But again, I might just step back and flag that we do take this very seriously. Put aside this case, these kind of allegations, we take exceptionally seriously. And so we have within the organisation, we have a dedicated unit that is looking at these matters. We look to expedite those matters to make sure they are taken seriously. Right. We have special training of our employees to make sure that they're ready to handle those sorts of matters. And where we need to, we are making referrals through to the tribunal for action. So again, we we have zero tolerance for discrimination in the system.
So you say you've had 95?
Correct.
And that would be one of them?
Again, I can't talk about a particular matter, Senator Bragg. And it's not that I don't want to be helpful. We have very particular confidentiality
because I think,
obligations.
I mean, if you've had 95 of these, that would indicate to me that it's a major, potentially systemic issue where if, I was Jewish and I was going to get a procedure done by someone who was threatening to kill people, I mean, that's not the Australian standard. I mean, Australians would expect better than that. So I guess what I'm seeking from you is what assurance can you give this committee that in relation to these 95 complaints, let's assume that they're all valid or mostly valid. I mean, why would people want to raise complaints that weren't valid? I mean, think people would raise them if they were fearful. What confidence can you give that the Australian medical system is a safe place for Jewish patients?
Sure, I'm happy to answer this question, Senator Bragg. So what I can tell you is of those 95, about half of those relate to some form of complaint about anti-Semitism, and about half of those relate to complaints about Islamophobia. So we're talking about half-half. When we look at the makeup of those matters, many of the complaints or the notifications, as we refer to them, relate to some kind of social media activity.
Right.
And of those, many of those do relate to a complaint that someone has reposted some kind of news article, for instance. So it could be an ABC article or something like that. So many of them fit within that, and in many of those cases, we wouldn't see those as a case where we need to take particular action.
Sure.
However, of course, there have been more serious matters than that. I won't pretend there haven't been.
So how many have been rubbed out? How many doctors have been rubbed out?
Well, we haven't had... so first of all, I just need to flag, we don't have the power to remove registration, but we have the power to refer to a tribunal, and we currently have 2 cases waiting a tribunal. Yep.
In relation to anti-Semitism?
I believe I might hand over to Jamie Orchard, General Counsel, just to answer that question.
Thank you, Jamie Orchard, General Counsel of APRA. They relate to the nature of the complaints that Mr Untersteiner was referring to, namely social media posts. They might relate to anti-Semitism, they might relate to Islamophobia type posts.
So 2 before the tribunal?
Correct.
And what are the sanctions?
Tribunals have a range of powers. Once they consider the matter, if they were to determine that the conduct in making those posts amounts to professional misconduct, they're able to impose a range of sanctions ranging from cancellation of registration and disqualification for a period, suspension and so on.
Okay, well, my understanding in relation to this particular matter is that there's an ongoing issue here, and that, frankly, as I say, if I was a Jewish patient, I would be very worried about the kind of treatment I would be receiving from persons who are effectively threatening the community by wishing death upon people. I mean, doctors have a special role in our society. We would expect that, it's not like posting a news article is not the same as wishing death on people. It's a different thing. So in this case, I understand that, you can't refer to it in detail in this committee, but my understanding is you've closed that case. Yes, so I guess what I would seek from maybe the chair is whether it's possible for this committee to seek some sort of private briefing on how in fact these sensitive matters are being progressed, because the Parliament here in Canberra would expect that we've set up a system for all Australians to get safe medical treatment.
And Senator Bragg, I can share with you, I've got confidence that that's what they're getting. And I share your concerns about discrimination in the health system, and again, I say we have no tolerance for it. We are taking absolute action where we need to. Again, it can be very difficult where I can't talk about these cases, because in many of these cases there's always further facts that I'm sure you and others might not be across as well, which is important to understand, and I'm sure you do understand that, Senator Bragg. But again, I can give complete confidence that we've got no tolerance for discrimination, and I feel confident that any Australian is able to go and get safe health care and not worry about discrimination because we're dealing with it.
Minister.
Chair, if I may, before you conclude with Senator Bragg, just also for the benefit of the committee, just say that on the 12th of September 2025, health ministers met and issued a policy direction to Australian Health Practitioner Regulation Agency, APRA, and national boards to improve the health practitioner response to racism and discrimination, including anti-Semitism. And the policy direction asks them to ensure health practitioners undertake education and training to help promote a culture of anti-racism in healthcare and to undertake a review of the current complaints process on racism and discrimination, including anti-Semitism.
Yeah, well, can I ask one final question?
Yeah, can I just
Through you.
add just a comment that I'm very happy to take up the issue of organising a private briefing with APRA at your request by your colleagues as the voting members of this committee, and to ensure that we have some of those questions answered. So yes, final question.
Thank you, Chair. I mean, that you've covered it off. Effectively, I think it would be important for us to have a private briefing so we can be absolutely confident that these issues are being properly progressed and taken seriously by APRA. I mean, our role as the Senate is to ensure that all the agencies are doing what they can to protect the community. So I understand that you can't canvass everything necessarily in this domain, but I'm grateful for the Chair's offer of a private briefing.
Thank you,
Chair.
Senator Bragg. There is 5 or so minutes, Senator Little, if we wanted to return to you in the coalition block questions.
Okay. So we often hear that I've got to change over, do we? Thank you.
Sorry, thanks.
Please don't use into my 5 minutes.
There you go. You've got a 15-minute block. Do you want to check with him? Okay. Do you want to ask him? Are you using the old 15? Okay. Yeah, no problem. We've got...
Thank you. We often hear in this area that due diligence is done, so I want to ask you about the financial statements of Yadu Health Aboriginal Corporation, which you fund, and their 2023-24 annual report. You know that there have been some governance issues at Yadu which delayed significantly the building of a clinic in that area, most concerning post the removal of the cashless debit card and the significant issues, increased issues in that area. What I'm wanting to ask you about that is that in Yadu's financial statement, it refers to $554,000 paid to other related parties, and other related parties are defined in their annual report as close family members of and entities controlled by key management personnel. When you did your due diligence in handing over millions of dollars, did you actually look at stuff like that and ask questions?
Melinda Turner, First Assistant Secretary, First Nations Health Division. Senator, I would have to take that question on notice. It would have depended when the annual report was actually completed and whether we had time to look at it. So I'm not quite sure that I can answer that question for you right now. So I will take that on notice.
Okay. And this is not particular to Yadu. There are a number of annual reports you can look at where this particular issue occurs.
Yes.
But their annual report reports an underspend of some $220,000 for their organisation, which obviously means that some aspects of their service were not delivered. Do you look at those kinds of things and actually ask the question, who missed out because this organisation couldn't get its act together on delivering what it said it could deliver when you gave it the funding?
Ben Barrett, Assistant Secretary, First Nations Health Division, and sorry, I've lost my nameplate. We do consider underspends, and many organisations, many ARCHOs do have underspends, but that primarily relates to things like an inability to retain workforce or for infrastructure projects that might include delays in being able to get the correct accreditation or, weather-related delays. So we don't necessarily look at an underspend as a failure to deliver services.
Well, I put to you that when there is underspend, the practice, and I've had complaints about this, is that those organisations just retain the money, whereas there are other providers that could do the work. And people miss out because of the inability to put the money with the organisations that can actually do the work when it's required. How do you respond to that?
In the particular case of Yadu, I'm not sure there is another organisation in that area that would be able to pick up that slack and has the capacity or the workforce necessary to deliver those services.
Do your agreements allow for that? Because it's not just a problem at Yadu.
Yeah, that's what I was about to say. Our agreements don't actually allow for that, so it is we would not be able to move funding between organisations as such. So it basically would be looked at as a case-by-case kind of situation, but there is not that ability to move between grant agreements. If funding is given committed to, for example, an infrastructure project, it is for that project, and unfortunately is not able to be moved.
Yeah, but we see this
project.
on programs for medical programs. It's not just infrastructure.
Yeah, okay, yeah.
Let's be clear on that. Okay, now the government committed to reducing public sector consultants, but in that same annual report, Yadu says it spent $1 million on consultancy fees in that year. Is it acceptable that consultants are just outsourced by these taxpayer-funded bodies? It's a significant amount of consultancy fees.
Is it in relation to the actual infrastructure project itself? Sorry, I just clarify.
Well, one would assume, considering that build's 2 years behind,
yes,
that it probably would have not been $1 million for that.
Yeah.
Celia Street, Acting Deputy Secretary for Strategy and First Nations Group. I don't think it's unusual for organisations to bring in those services and those specific expertise. So when it's about infrastructure, we wouldn't necessarily expect the organisation to have all of that expertise at hand, and that they would be outsourcing some of those components. So I'd say that wouldn't be that unusual. If it was delivering the specific services for which they've been granted, that might be a different question. But I think for something like an infrastructure project or for an evaluation, that wouldn't be unusual.
So what you're saying is $1 million wouldn't trigger you to go, what's actually going on there, and should we put even more money, which you have done, into that organisation?
I think with organisations in particular that have infrastructure projects, we recommend or we advise that they contract a construction project manager.
Let's not keep talking about infrastructure, because this is not about infrastructure alone, please.
I think with some of the organisations, we also encourage or support organisations to seek consultancy services for things like business management services or business improvement management services. Okay. Nurse advisors, I think, are currently employed by Yadu to help them improve their practices. So there's a wide range of reasons that they might consult.
All right. I assume I'm going to move on to another topic, but I'm assuming you're the same people that can help me with this.
Senator Little, I do need to share the call, so I'm happy to come back to you, but I will need to go to Senator Steele-John and then
that's fine.
To a few others before we hit the break, but we will get back to you.
Thank you.
So, Senator Steele-John.
Thank you, Chair. Minister, through the national standardisation process for diagnosis and prescription, through the national standardisation process really for ADHD care, can you guarantee and assure people that no one will end up worse off? And that is, if you live right now in a state or a territory that is currently in the process of opening up pathways to ADHD care via your GP, which makes it much less costly, that as the result of the national standardisation process, nobody will have those access pathways shut off.
Thank you, Senator Steele-John. As I said previously, Minister Butler has been very committed to wanting to move on the recommendations in regards to the report that came through on ADHD, and he's done that through the recommendation 5, which was in coordinating with the states and territories in terms of the recent health ministers meeting in September. And so that I can say to families across Australia that there is a committed minister here, followed by his department, to work in that. It also includes, Senator Steele-John, the uniform reforms enabling GP diagnosis and prescription of ADHD medication, and it should be designed to ease pressure on individuals, on families and carers, without a doubt, and who currently navigate through a really costly and overloaded specialist system. So there is a real commitment by Minister Butler to do the work in terms of the recommendations that have come through.
Thank you. And does that, I just want to be really clear for people that you will ensure, and your government will ensure, that people won't go backwards in relation to access of ADHD care that they might be able to access in their state or territory.
Look, I would certainly say to all Australians that our government is focused on wanting to improve health and, cost of living in terms of health, with cheaper medicines, with what we've done with Medicare, and certainly the families that you're representing, Senator Steele-John, we are very aware, and the Minister's very aware of the need to be able to move in this space. I cannot say any further what I've said to you already on the matter.
Okay. Now let's go back to the meetings of the Medicine Shortage Action Group. I'll give a moment for Dr. Fenner to get to the table.
Thank you. Yes, so I can confirm that the meeting of the Medicine Shortages Action Group was on the 13th of May, and since that time we've communicated with them regularly via email. We've done so providing updates, particularly when new 19A overseas alternatives become available or are PBS listed, and so we've communicated with them through May, June, July, and most recently in September.
Okay. And when is the next meeting of the action group?
I don't think we have one scheduled at the moment. We've been communicating, as I said, through email updates, and if there's a big shift in supply, that would prompt us to reconvene that group.
Okay.
Yeah.
Is the government looking at new ways to encourage onshore manufacturing of these medications so that we can have more long-term confidence in availability?
Senator, I think the Department of Industry has a range of programs to support local manufacturing of different products and has a focus on medical therapies, but we're probably not in a position to talk to you about those. We do have a range of approaches in the Health Department to try and manage shortages beyond the work that Dr. Fenner has been discussing. So we've had a pharmaceutical wholesaler agreement reached in the end of last year, which included additional funding for wholesalers to make sure we're managing shortages of PBS medicines in a more coordinated way. So millions of dollars in funding under the community services obligation arrangements for wholesalers of medicines to support the Commonwealth in managing shortages, to proactively manage the supply of PBS-listed medicines into regional, rural and remote areas, and triaging orders of PBS medicines to make sure that we are supporting the National Medicines Policy. We also have the onshore stockpiling arrangements under PBS, which applies to certain medicines. We have, as discussed earlier, arrangements for the PBAC to urgently consider overseas brands listed by the TGA Section 19A listings. So we've got a range of approaches to manage shortages across the medicine supply chain.
Can I also highlight, sorry, Senator, and I might just ask Mr Henderson to comment on this as well, is we recognise that there's a perception that we are simply reactive to shortages. There is a challenge in that. We have a number of mechanisms for identifying shortages, but they're reactive. But I might ask Mr Henderson just to speak on the stakeholder forum that we've assembled and are using to approach that in a more systematic way.
Thanks, Professor Lawler. So, yes, so Senator, we have set up what we are calling the Medicine Shortages Stakeholder Forum, and that is represented by over 40 groups across healthcare, health professionals, consumer groups, industry. We held the first meeting on the 3rd of September 2025, and we are going to utilise that forum ongoing to test potential reform options, particularly in relation to reform options that the TGA can implement in relation to how we mitigate the impacts of medicine shortages, but also as a key area or forum where we can receive signals and information back through those key stakeholders in relation to their ideas and views, but also the impact shortages are having on their representatives.
Thank you, Mr. Henderson. If you could table for us the membership of that forum and the next meeting date for that forum, that would be much appreciated.
Certainly.
Thank you. Now, one of the challenges that I'm hearing about really clearly from the community is that overseas registered replacements under 19A are often inaccessible to many people, particularly that those that are not on the PBS currently, not PBS listed. Basically, that causes a significant financial barrier to being able to practically be able to afford the medication, even if it is technically available, and often you rock up to your pharmacy and they don't even have it in stock. So my question to you is this: are overseas registered replacements eligible for listing on the PBS?
Yes, Senator, and many medicines that go into shortages, we use PBS listings of 19A alternatives as an effective way of managing the way out of that shortage. So last year we had an example of entrocitabine and tenofovir, where we were able to make 19A listings. Recently, Bicillin has had a 19A listing so that we've got greater access to that medicine in shortage. So many of them do get PBS listed.
And in relation to the shortage of ADHD medications, how many substances have we got under 19A at the moment that have been approved and are on that list as an overseas replacement?
We have several 19As with PBS listing, but supply can fluctuate a little bit. So it depends on, as I said, supply can fluctuate, and we keep them up to date on the website because of that fluctuating supply.
And I should clarify how many of them that are approved under 19A that are not PBS listed.
I don't have that in front of me, but I can come back with that.
Okay, if you could. And have any of the currently 19A listed replacements, have their sponsors made an application for PBS listing?
Senator, thank you. Duncan McIntyre, First Assistant Secretary, Technology Assessment and Access Division. My division handles the listing of items on the PBS. I would need to take on notice the current status of applications for listing on the PBS of these drugs, but we deal with these in an expedited manner and we encourage sponsors to bring them forward. We work actively with sponsors that suggest that they may be able to get supply of suitable substitute medications. It's fair to say that in some cases sponsors aren't able to procure a sufficient quantity that means that they're confident that they can provide that supply, but we work with them to try and manage that dynamically. We also work then with the pharmaceutical wholesalers that distribute these medications to pharmacies to seek to ensure that there is as equitable access as possible in cases where supply is limited.
A particular example that we can provide, Senator, is a 19A approved product of methylphenidate hydrochloride tablets. So a Switzerland brand was recommended at the May 2025 PBAC and has now been listed on the PBS. So we do have some 19A brands listed.
So just to be clear, that's the Section 19A replacement for Concerta it's sponsored by MedSurg Healthcare. Is that the substance you're referring to there?
It's a Switzerland version of Concerta.
Because that, my understanding was that that was not PBS listed. I've had reports of people facing costs of up to $200 for 30 tablets. So you're saying
my advice is that we've listed it on the PBS, yes.
Thank you. Could you...
yes, Senator, I can confirm that it has been listed on the PBS under 19A.
And when was it listed under?
It was listed on the 1st of July 2025 for provision on the PBS until the 31st of January 2026 at this stage.
Okay. Now, the TGA's website, the relevant medicine shortage website pages around these substances indicates the government expects the shortages of ADHD medications to last through till 2026. Mid-2026, I think, is the wording used. So are you telling me that the PBS listing will expire in January of 2026?
Senator, the way the 19A applications work is at the time the application is made, there's a sunset date, but there are provisions that allow those to be extended. And as we draw closer to that date, there will be an assessment as to whether there's a need for an ongoing Section 19A application, and we will work with the sponsor, and if they are willing to do so, then we will ensure that there are arrangements in place to allow that to be considered. There is, as I'm sure you're aware, Senator, ongoing tight supply for a range of reasons to do with these medications. There are issues associated with the country of origin and the APIs that underpin them, and restrictions of these drugs which can be misused, of course. And that means that global supplies of these drugs are subject to regulations in other countries that mean it's challenging for the sponsors to bring them to Australia. But we continue to work on those supply chains to ensure that we can get as much of the globally available supply as possible.
Thank you. And this is my last question, and then we'll share the call. Could you provide on notice the list of currently 19A approved overseas replacements that are not PBS listed currently, and whether their sponsors have in fact made an application for listing on the PBS, and the status of that application if it has been made?
Yes, we can, Senator. And I might also add, Senator, we also strongly encourage when we go out for the 19A that they then pursue that PBS listing as well, so that's part of our processes.
Thank you. Thanks very much.
Thank you for your diligence, Senator Steele-John. I will hand the call to Senator Hanson.
Gender dysphoria. So who's be able to answer those questions, please? Thank you. Just for some context, I'm going to ask about the advice the Minister requested from the National Health and Medical Research Council in regards to advice on gender dysphoria that was released under Freedom of Information. That was 2425, document 009, doc 4. Is it still the case there's no current Medical Research Council approved guidelines on gender dysphoria for use in Australia?
Good morning, Senator. There are no National Health and Medical Research Council guidelines.
Sorry, just for the hands, Dr. Devlin, can you just state your name and the capacity of your statement?
Good morning. Liz Devlin, Deputy Secretary of Primary and Community Care. That is correct, Senator Hanson. At the moment, there are no National Health and Medical Research Council guidelines. However, clinicians are working under other national guidelines that have been developed through professional groups. So it is just the sense that the Minister has asked the NH and MRC to undertake a national process, a very rigorous and evidence-based process, but there are clinicians working under guidelines that have been developed by their own professional bodies.
So anyone in Australia prescribing puberty blockers, hormones or surgeries for gender dysphoria cannot be possibly doing it under your guidelines?
Senator, as I said, there are no national guidelines. There are, however, professional bodies who have released these guidelines. All of these services that are operating under the states and territories will have their own clinical governance models, and all the professionals need to meet their own requirement standards for their for the health professional that they are.
how are you going to, if these people are actually prescribing puberty blockers and hormone treatment and they're not under the health professionals' guidelines, and if these are actually doing damage to the children, then who's going to be held responsible?
Senator, in regards to puberty blockers, it is actually reasonably rare for those to be prescribed. It is not common. Does it happen? Yes, but it is not common. Quite often these children are seen in multidisciplinary services, and puberty blockers are only one form of that care that those children and their families may work with their professionals on. The professionals prescribing them are working under their own clinical, requirements as a health professional.
Well, I tend to disagree with you because I'm getting a lot of complaints from parents that have actually lost control over their children because they've gone to see clinicians and they've given the right to it and the parents can't interfere and no one can actually advise them differently, and they've lost control over the children. Children who are as young as 15 who are actually being told they've got gender dysphoria and actually going and as young as 15 having their breasts removed or having their penises removed because of this gender dysphoria that's been taken away, and telling the kids that, no, you've got a problem with what sex you are, so therefore you must have gender dysphoria. And the parents are saying they're losing control of their kids. There is one case here, and I want to know what the health department has case here. This is from one parent. A 3-year-old child was the subject of a PhD research project published in 2025 that named the child as transgender at 3 years of age and socially transitioned the child in a Victorian preschool classroom. How the hell is that happening?
Senator, I'm not aware of the circumstance that you are referring to, and we wouldn't comment on that. That is not something that's in the remit of the Department of Health, what has happened in Victoria.
The Department of Health should be looking at the wellbeing of the children, and I just feel that it's just not being looked at all. You don't have guidelines for this. You've got clinicians giving puberty blockers, and it's true also that your puberty blockers are they're actually off-label use. The TGA, they're not TGA approved for gender dysphoria. Is that correct?
So, Senator, my understanding is that the common medications used for puberty blockers, there are reasons for them to be approved by the TGA. There's certain types of cancer or early onset puberty, those sorts of things. They are then privately prescribed if it is for the purpose that you are discussing.
Senator, can I suggest here that we have the TGA at the table? It may also be the case that the Chief Medical Officer may want to comment. Just want to reiterate what Dr Devlin said, which is there are not national guidelines at the moment, which is why Minister Butler referred it to the NHMRC, but there are local guidelines that are being used by clinicians.
But he's asked for a review because there are concerns about it. Now, that review is not going to go ahead till about 27, is that correct?
Well, the Minister has asked for a review to look into whether national guidelines would be appropriate, noting that there are local guidelines in each state and territory that clinicians are operating in. But I think if you had the question about the TGA, I'd like to throw to Professor Lawler, and then perhaps the Chief Medical Officer might like to comment. And we also have... Yeah, I know, I'm just thinking whether you're a professor or not. I don't want to get it wrong.
Super professor. Thank you, Secretary. So, and Senator, thank you for the question. There is some. I'll ask Dr. Dascombe to give us some clarity around the approvals and the specific indications for the medicines that we have entered onto our register.
Thank you, Professor Lawler, and thank you, Senator, for your question. Dr. Daniel Dascombe, Acting Principal Medical Advisor, Pharmacovigilance Branch in the Medicines Regulation Division. As you alluded to, Senator, there are 5 types of medicines that are called gonadotrophin releasing hormone analogues, to what you referred to as puberty blocking medications. There's 5 types registered for use in Australia. Of these, only 2 single active ingredient products, so leucoprelin acetate and triptorelin embonate, are registered for use in children. The only TGA approved and registered indication for these medications is for the treatment of central precocious puberty. The use of these medications in gender-affirming care is done off-label. This is a common and legal practice in Australia.
What age can these puberty blockers be given to a child?
It's at the discretion of the treating clinician in consultation
There's no age limit to it?
with the patient and their carers, Senator.
Yeah, but as mentioned, Senator, by Dr Dascombe, the indicated treatment for which it's entered into the register of therapeutic goods is for central precocious puberty. So that's a hormonal condition at which puberty kicks in too early, so it's the treatment of a medical condition. When it comes to the use off-label, that is a clinical practice decision that's not regulated by the TGA and is undertaken in line with clinical health practitioner practice, various codes of practice and also local guidelines.
Do you investigate these psychologists or people put them on to, about their qualifications? And some of these, I hear, they've only just interviewed the child for about 20 minutes or half an hour and are prescribing drugs to them. Where's an oversee of this?
It's not the role of the TGA to regulate clinical practice or practitioners, Senator.
Well, OK, I'll go back to the Health Department. Who can answer that question for me? Who oversees this? When parents are complaining, understand where I'm coming from. When parents are telling me they've got concerns and they're taking the children to see these clinicians or these psychologists or whatever, and within 20 minutes or half an hour, they're actually prescribing. And then these kids got it and they can't stop them. And the parents intervene, well then actually they're questioned over their care of the rights of the child.
Senator Hanson, if we can let the officials
Yes,
answer the question. Sorry to interrupt you.
But they need to actually have the full understanding of what
I agree, but if we
needing.
can cut to the questions and less of the content, we can get the officials to give you some answers.
I may ask in the first instance, thank you for the question, Senator, for Trish Clancy, First Assistant Secretary of the Population and Health Division, to answer. Also see if the CMO wants to comment, but also note in terms of regulation of professionals, APRA would be the body for that. So I'll turn to Ms Clancy.
Thank you. Trish Clancy, First Assistant Secretary, Population Health Division. So decisions regarding clinical care for minors are shared between the clinician, the young person and their family. And if there's a disagreement on the diagnosis, such as you suggested in some of the cases you've heard of, on the diagnosis, the treatment or the capacity of the minor to provide informed consent, the family court has ruled that this requires an application to the court to resolve the dispute consistent with the child's best interest.
So the parents have to go through the court system?
If there is a disagreement on the care or diagnosis, treatment or care of the child.
Your review, that review is going to go ahead, is that right? I understand. It's a three-year review, a $1.5 million review, is that correct?
Yeah, hi, Steve Westling here, CEO of NHMRC. Yes, we've been asked to write NHMRC guidelines, and that process has started, and the committee has been appointed, and the committee will start to meet. And that process will take 3 years, but we have been asked to provide interim commentary on the use of puberty blockers in the middle of next year.
Thank you. Does your review cover the fact that Justice Strum, in his Devon judgment, had also questioned the Australian standards of care and treatment guidelines for trans and gender diverse children and adolescents, authored by Professor Telfer, for not recognising children who may not be capable of making life-altering medical decisions about their gender identity?
So the committee will look at all of the guidelines, both Australian and international. I should emphasise there are no NHMRC endorsed guidelines at the moment, but we will be looking at all guidelines, we'll be looking at all commentary, and that will be considered by the committee, absolutely.
Right. There's been a lot of controversy and it's been discussions on the floor of Parliament about whether puberty blockers are reversible or irreversible. Can you answer that question? Are they irreversible?
So again, the committee will be looking at that, and we have members on the committee who are experts in that area.
I'm not asking about the review, I'm asking now, your expert opinion, are puberty blockers irreversible?
So I'm not an expert in that area. I'm an infectious
Is there someone
diseases.
here who can answer that question?
Well, there are members on that committee who will be looking at the evidence.
I'm asking, is there anyone here who can answer that question now?
Senator Hanson, I think the official was going to provide the answer to you, so if we can just wait until Professor Wesleyan can provide the answer to you.
So the way the NHMRC works with its guidelines is that these are evidence-based guidelines. We look at the evidence very carefully before making determinations, and so at the moment I can't answer that question because the evidence has neither been collected or looked at very carefully to make that determination.
So at the moment, you're allowing puberty blockers to be given to children that you can't determine whether they're irreversible or not irreversible. So don't you believe that's a failure of our health department to allow these drugs to be given to children who may be going through a phase at the moment and really are being led down the path that they are in the wrong body?
At the moment, we are developing guidelines and the oversight of the prescription of puberty blockers doesn't sit with the NHMRC, so I can't really answer that question. I think that question has been answered, but maybe Professor Lawler would like to answer that question further.
Thank you, Professor Wessling. So as I'll just reiterate, Senator, that there are a number of elements within the regulatory space here. The Therapeutic Goods Administration, as the regulator of therapeutic goods, has assessed a number of these gonadotrophin-releasing hormone analogues, as Dr. Dassam's highlighted, but the only ones that are currently indicated and entered into the register by the TGA for treatment in children is for central precocious puberty. The regulation of health practitioner practice, including off-label prescribing, sits with AHPRA and with local clinical governance mechanisms.
So can you answer me? Are they irreversible?
Senator Hanson,
sorry,
I just
Chair.
need to check how long you need. I do need to share the call before we head to the morning tea break to Senator Antic. So just if your last question,
right,
you can wrap up.
So what would your recommendation be to the Health Department if there is no guidelines? You can't answer whether these are irreversible. Would it be in the best interest that these should not be given to children at the moment until we have a clear indication, are they reversible or irreversible? Because I have had a parent who came to see me. Their child went through this, thought they were in the wrong body as a female, then took home hormone treatment, are now locked in the room 3 months at a time, will not come out, lost their hair on their head, growing a beard, and has hair on the chest, hate the way they look. And I'm sorry they've made the decision to take this. So what I'm asking, is it in the best interest for this, for the people of Australia and the children out there to put a block on these hormone treatments until you can give a clear indication of are they irreversible before destroying any further children's lives? Do you think is that common sense?
Can we just get a response from Mr. Conley?
I'm not sure we can add anything more. The procedures that, to the extent they exist, and Ms. Devlin commented that it's a relatively small number, notwithstanding the importance of it, that they are occurring under clinical guidelines. They're just not national guidelines at the moment. The NHMRC is being tasked to do a review to see what the appropriate national guidelines are. Professor Wessling hasn't completed that review yet and wants to draw on the best experts, and so I don't think we can comment more than we can at the moment about that process.
So it's only very few. So I call on every parent out there, if you're going through this, please write to the Department of Health and tell them your concerns.
To the next question from Senator Antic.
Thank you, Chair. These are questions for the TGA. We've got everybody here who...
We should have the people you need, Senator, in the room.
Thank you.
Depending, of course, on your questions.
On the questions. Understood.
Yes.
I just got one question while we're waiting for is that okay? Just to you, Professor Kidd, I was just wondering how many times during the pandemic did the CMO use the powers of the Biosecurity Act?
That is a question we'd have to take on notice, Senator. I'm sorry I haven't been in the role during that time.
You were the acting CMO. I mean, so the deputy CEO.
I had a small number of periods where I was acting CMO during the period when I was the Deputy Chief Medical Officer, but I have been away from the department for 2 years from the middle of 2023.
Because so if you could find out how many times the power was used and for what purposes. Thanks.
Thanks. Senator Antic, I think you've got your officials.
Okay, thank you. In February of 2021, the TGA produced a document called the COVID-19 Vaccine Safety Monitoring Plan. This is it here. I've got copies if it needs to be tendered. But in broad terms, it was a document which the TGA spelt out the implementation plan for the monitoring of the COVID vaccines. And a couple of months ago, I asked the Senate to order to produce documents from the TGA, documents including those showing the timely collection and management of reports of adverse effects, any safety signals, documents which show those, a timely action to address, and so on. Can you tell me about whether or not that monitoring plan was used, and were documents collected? Are those documents available, which I can spell out later?
Thank you for your question, Senator. I would say that the TGA has ample documentation demonstrating compliance with the principles and objectives of that COVID vaccine safety monitoring plan. And the 5 key elements that are articulated in that plan essentially describe the process of post-market surveillance and safety investigation that our medicine and vaccine surveillance teams follow at the TGA every day. Now, whilst there's no single specific evaluation report outlining or benchmarking us against the elements of that plan, there is ample information in the public domain which provides evidence of compliance with the plan and underscores our commitment to transparency as a regulator. Since the time that you mentioned, February 2021, since the start of the COVID vaccine rollout in Australia, the TGA has investigated 148 safety signals for COVID-19 vaccines. Updates have been made to product information and consumer medicine information documents on 57 occasions, representing regulatory actions taken by the TGA. The TGA's database of adverse event notification captures and reports on information reported by consumers, health professionals, jurisdictions in Australia. That's all publicly available, Senator. And in addition, the TGA has released a number of documents under freedom of information. There's been 70 requests directed toward our branch since February 2021. To summarise, I would say that each of those elements is evidence of us working toward the principles and objectives contained in that.
But there will be documents that aren't in the public domain that were associated with the plan. What I'm proposing to do is to put on notice the request for those documents and ask for an undertaking that they would be produced to the committee. Is that something that can be done?
There would be some difficulty in doing that, Senator, because as I said at the outset of my response, the 5 key themes outlined in that report essentially describe our day-to-day processes. This is our standard sort of process in terms of post-market surveillance and pharmacovigilance. So that there would be a vast volume of documents that would relate to our day-to-day work since February 2021.
Well, I don't think these are looking for vast volumes of documents. These are just documents which show that there are adverse events reports were being done, that all of the things that were being said in this document. This is a public document which, in its essence, was designed to give confidence to the Australian public that this pharmacovigilance was taking place.
Senator Antic, can I seek some clarification for you?
Yes.
From you, sorry. Is this a document that you have in your possession?
It is. I have a copy.
And are you able to table that to committee?
I have a spare. I can tender that, if that's all right.
Thanks very much. Just so that the officials can reference it.
Yep. Sorry, Chair.
Yeah, thank you.
If I might just highlight, Senator, and we have had this conversation with your colleagues previously. We do recognise that. I mean, Dr. Dascombe's highlighted that we receive frequent and multiple freedom of information requests. We do endeavour to meet those. There are circumstances in which we are challenged in that. We are committed to transparency in our practices, as any public service operation should be. There are times when when that is made difficult for a number of reasons, and we articulate those in our decisions and the communication that's undertaken for our decisions. But I would just highlight that the COVID vaccines have been probably the most scrutinised and monitored therapeutic treatments that have been introduced in Australia in the last 50 years.
So with that, then there should be no difficulty with providing the documents to show that that scrutiny has taken place, that pharmacovigilance has taken place in accordance with the document that was produced in February 2021. Why can't they be produced to the Australian public so that people out there who are interested in this subject can make their own assessment with the greatest respect?
I might also highlight, Senator, as well, through the pandemic, we were putting out weekly safety reports, COVID-19 safety reports, which highlighted the number of adverse events that had been reported to the TGA. We then moved to fortnightly, but through the pandemic, I believe we put over 140 of those COVID-19 vaccine safety reports.
There are a lot of
publicly.
concerns about that process in the sense that it was deemed to be very complicated for adverse events that may not initially have seemed reasonable. We're also talking about 5 years down the track now, so there may be a lot of data that would be collected that wasn't during that period as well. So with the greatest respect, it would be my submission that these documents should be produced. I will put them on notice, the request for documents, and I'd ask that they do be produced. I mean, at the end of the day, we can take the TGA's views on whether there's too much, too many or whatever, but I think the purpose of the exercise, the purpose of freedom of information is to show people that what the TGA said was going to be done was done. That's the purpose of the exercise.
Absolutely, and I concur with you entirely on that, Senator. That's the absolute purpose, and we're very happy to receive any request for freedom of information. The matter of the order to produce documents is obviously outside of our control.
Sure, but this is as a result of this committee.
Yeah, absolutely, and we're very happy to receive any request for documents through the appropriate channels, and indeed we've answered Senate questions on notice multiple times through this committee previously on those matters.
I've got other questions on a different topic. The Chair is just otherwise occupied at the moment, and I will wait for her to.
Excuse me, Chair.
But sorry, Chair, not to try and that was not staged, by the way. I promise. But I have some more questions. But we want to go to a break. So
we do want to go to a break. In the interest of everyone's health and wellbeing in this wonderful committee, we are going to take a short suspension, and we will be back at 11:32. proceedings, and the committee has agreed to this. I remind the media this permission can be revoked at any time, and the media must follow the direction of Secretariat staff. If a witness objects to filming, the committee will consider this request. The media are also reminded that they are not able to take images of senators or witnesses' documents or of the audience. Media activity will not occur during suspensions or after the adjournment of proceedings. Copies of Resolution 3 concerning the broadcasting of committee proceedings are available from the Secretariat, so thank you. We will continue in outcome 1 on health policy, access and support. I'm going to go to Senator Waters.
Thank you, Chair. Hello, everyone. Good morning, Minister. I've got some questions firstly about the Sexual and Reproductive Health Alliance STI awareness campaign. We've got the right folk here for that one? Maybe I'll ask the question, we'll see how we go. The right folk can come to the table.
We will have the right people. They're on their way.
Well, I understand there's Commonwealth funding for an STI awareness campaign being run by the Sexual and Reproductive Health Alliance, and an evaluation of the program is showing that it's working. People are booking screening tests. But what we've discovered is that their targeted ads are being blocked by Google as adult content. And then in November of last year, Google added STI testing to its list of sensitive topics, which triggers an automatic review. Now, that's meant that during the nationally funded STI awareness campaigns, ads are being rejected, delays for weeks, costs have risen from $5 to $17 per click until the issue's resolved. So firstly, is the department aware of this? And secondly, if so, what's being done about it?
So, I think we have people on the way. Not aware of it? We have an STI campaign. We've got the before play.
Thank you, Senator. Can you just repeat the question for me?
Sure. Thanks. The Commonwealth-funded Sexual and Reproductive Health Alliance STI campaign is having its public health ads blocked by Google because they've changed their terms where they deem adult content, which is obviously delaying the public health purpose of the campaign and leading to increased costs and frustration. So just wondering whether the department is aware of this, and if so, hopefully you are, what can be done about it and what are you doing about it?
So,
sorry.
I just want to check, and that Ms Ringwood can answer. We have a campaign which is the Before Play campaign, which we have had in market. But I'm just wondering whether this is a different campaign.
I'm not sure of the name of your department's campaigns, but it's the Sexual and Reproductive Health Alliance that's been funded to run an STI awareness campaign. Hopefully you're aware of the name of your campaigns.
So, Senator, that's not a campaign that the department's developed under the advertising guideline.
But the Commonwealth has funded it. So what is the Commonwealth doing to ensure that the public awareness can flow?
Yeah.
Sorry to interrupt. In the interest of letting the officials answer your first question, I know that Ms Ringwood had started speaking, so we could just wait for the answer before we continue.
Yes, so Senator, I will defer to Dr Devlin to provide a response for this one. It's not something that we're aware of. It's not something that we've developed under the guidelines, but certainly happy to take that on notice and look into it.
Oh, so the department's not aware that Google are blocking the ad campaigns that the Commonwealth has funded?
Before we definitively say that, I just would like to see either Ms Balmano or Dr Devlin. The issue we have here is that it's run out of the other part of the department, which is the grant funding for that body, if that's what I think has happened, not our comms area. So I'm not going to definitively say we don't know until we have the right people at the desk.
Oh, okay.
Yeah, so we'll
right
check
person?
on that. No, I think I've got the right person here, though, downstairs. We're assuming it's a grant that we're providing, so we'll need to find out more information about that one.
Okay, great.
So we'll find that out now and come back to you.
Come back, that'd be wonderful, because obviously it's interfering with public health objectives and potentially wasting the Commonwealth money if the ads are only meant to cost $5 per click and they've gone up to $17 because Google's censoring actually what is a very protective public health campaign. Thank you. Look forward to an update on that. Can I ask now some questions about menopause? Following the Senate inquiry of this committee and the consensus recommendations therein, there was some funding in the budget for a public health campaign to raise awareness. And just like to know what the timeline on that is and who've you consulted on the content of that campaign. Hello.
Good morning, Senator. I recall last time we talked to you about the campaign reference group, and at that time we hadn't established it. So I'm happy to confirm for you that sort of external advisory group to the campaign has been established. So that includes representatives of organisations such as Jean Hales, the Australian Menopause Society, the Australian Longitudinal Study on Women's Health. We have Monash University, Multicultural Centre for Women's Health, the RACGP, the Obstetrics and Gynecology. We've got Consumers Health, NACHO is involved, LGBTIQA plus Health Australia is involved, the National Rural Women's Health Coalition, and we have a representative from the Victorian Department of Health noting the work they have done in Victoria. So pleased to say that will be the group that will be providing us input to the campaign as it's developed, and I'll hand over to Ms Ringwood to give you the timeframes for the campaign.
Thank you.
So, Senator, the campaign's currently in development. Where we're up to at the moment is we are talking to people within the target audience for the campaign, so undertaking research to help inform the communication strategy and the creative content of that campaign, so we can be confident that it is evidence-based and audience-informed. We are looking to be rolling that campaign out in the new year.
Okay.
Subject to government approvals under the guidelines, of course.
Okay. And who have you identified as the target people?
So the target audience that we're talking to is women aged 35 to 55 years old.
Okay. And how will you ensure that the information is going to be helpful for everyone and in particular reach Aboriginal and CALD women?
So we'll be working closely with First Nations and multicultural suppliers on the development of the campaign as well, and are looking to engage closely with those audiences on the development of the strategy and the content for the campaign for them as well.
Okay. The TGA website says once again there's a shortage of various HRT or rather MHT patches. Given the likelihood of an awareness campaign increasing demand for treatment, will you work with the TGA to secure supply and ensure that any extra demand created by the campaign can be met? And I do have some separate questions for them.
Yes. Just in relation to the campaign, I think it's likely the campaign is unlikely to recommend what women should do specifically, because as you can imagine, every woman's needs are different. And so we do anticipate the campaign is more likely to raise awareness of the symptoms so that consumers are more likely to be aware of the symptoms, but then seek health professional further advice. So it is more likely to point consumers to go see their health professional if they're concerned or they have any questions about symptoms, as opposed to recommending a particular course of treatment or action.
I understand that, but it may naturally increase demand, and where there's already a shortage, have you got that on your radar? What are you doing to work with the TGA to minimise existing shortages that might get worse when demand increases, if demand increases?
I'll refer to the TGA.
So thank you for the question, Senator. So as you highlight, there has been an ongoing shortage of HRT treatments. We've looked to provide alternative options through our 19A mechanism. So there's a number of approvals, 19A approvals for alternatives to manage and mitigate the impact of those shortages. We've also put in place what we call a serious scarcity substitution instrument, whereby pharmacies can, at the point of dispensing, rather than going back to prescriber, provide an alternative product to the patient. But I might defer to my colleague, Dr Fenner, to go into more details about how we're mitigating that shortage.
I probably don't need more detail because we did cover the processes available to you quite extensively in that excellent inquiry, but maybe on notice if you could provide that to me, that would be great, but I only have a short period here.
We'll do some stuff.
I've informed that there's not been, and I've lost my bit of paper, but there hasn't been a new HRT patch added to the PBS from memory, at least 20 years. Firstly, is that true? And secondly, how are you encouraging some of the more modern manufacturers to seek PBS listing?
Well, I can't talk to the PBS, Senator, but I can talk for the TGA. And in relation to encouraging more sponsors to come forward, we do have a very, open invitation for things like pre-submission meetings, whereby we do, offer that opportunity for sponsors to come forward and talk through potential products that they may have coming through. We also have what we call pipeline meetings, where we discuss with sponsors, the products that are coming through their clinical trials and other aspects in that drug development process, and try and give them, as well as, receiving a great insight in relation to how those products could go through the regulatory pathways. But I might, in relation to PBS?
Yes, thank you, Senator. I would need to take on notice when the last time an HRT patch was listed on the PBS, but we are actively managing the products that are on the PBS, including through the... we have various ways of managing things that are close to shortage that we've introduced over the last 5 years or so, that we're increasingly able to use with the existing sponsors of HRT medications. So we have a minimum stock holding requirement for drugs listed on the PBS that meet certain requirements, and there are a number of brands that are becoming designated brands for those processes. So there's 4 new designated brands of HRT patches. What that means is that as supply is available, we are requiring that those sponsors provide a 6-month supply in Australia, and that they provide assurance that they can do so, and they have notification obligations in instances where they are unable to maintain that supply. So many of the issues associated with HRT medications are global supply chain issues, and they're affecting all countries, not just Australia, but we increasingly have mechanisms such that we can get more surety and therefore manage the stock that we are able to get in Australia in a way that ensures it gets to the patients that are most in need.
Okay, thanks for that. I remain of the view we should be locally manufacturing, but that's above your and my pay grade, so to speak. The new MBS listing for menopause and perimenopausal health assessments, is it possible to get the first quarter data on how many people have used that? Perhaps on notice, if possible. Can I just get a nod that we can get
we'll
that
take
data
that
on notice? Great. Okay.
Senator, so through you, Chair, we now have people from the interim CDC who could answer the sexual
first
health...
question?
Yes.
Yes, please. That'd be great.
Thank you.
Just to let you know, Senator Waters, you have just under 5 minutes to turn your call. So,
hello, folks. So presumably you're across Google blocking public health awareness raising ads on STIs, and just keen to know what the department's doing to rectify that.
Yeah, thank you, Senator. Mandy Charlton, Acting Assistant Secretary, Communicable Diseases Branch. We are aware of the issues that have been created by Google in blocking these ads, and we have discussed those with Australian Sexual Health and Reproduction Australia. At this point in time, we have not been asked to escalate the issue any further, and we understand that the campaign is actually performing quite well, and it's meeting all and exceeding all of its metrics.
Do you mean the Alliance hasn't asked you, or the Minister hasn't asked you?
The Alliance hasn't asked us.
Oh, okay. So the government's happy with ads costing $17 per click rather than $5 per click? Won't that mean that you can't get as many ads out with the limited budget that you've got?
Yeah, we have discussed with ASHR.
Sorry, can you speak up?
Sorry, we have discussed it with the Alliance, and we are meeting all of those metrics. So at this time, the campaign is actually performing to the standards that have been set for it.
Okay, so it sounds to me like the Alliance ended up resolving it directly with Google, and well done to them, but should not the department assist so that future public health campaigns aren't impeded by Google's strange definitions of what is and is not adult content?
Thanks, Senator. Stephen Bauhaus, Acting First Assistant Secretary, Health Protection Policy and Surveillance. We generally work with the stakeholders, so where we're funding someone under a grant or arrangement, we'll have the conversation with them about how to proceed. So in this case, they've had the conversation with the organisation and it's been resolved subsequently.
Okay, so it's not your job to fix Google. You think it's their job to have that argument? That doesn't seem great to me from a public health perspective.
So, Senator, it's a conversation with them about how best to proceed.
So does government have a policy on dealing with public health campaigns, not just this one but generally, when Google decides something is adult content, in a way that makes the expenditure of Commonwealth funds inefficient and that costs more taxpayer dollars and therefore reaches fewer people, I don't think that should just be left up to the people who are doing the work. I think that should be government's concern. So I'd like someone to let me know how you're approaching that, please.
Yeah, good morning, Senator. So if the organisation had sought our assistance, we would absolutely raise that with them. At the point that it was raised with us, raised that with Google.
Mm-hmm.
At the point that they raised it with us, they were in ongoing discussions with them about the nature of the content and the charging and those things. And they haven't sought us to specifically intervene. But absolutely, we agree that were this to continue to be a problem and to block the effectiveness of the campaign, that would be a role that we could assist with.
So do you have a policy on how you'll deal with that in future, or is it a wait and see until it happens again?
We don't have a specific policy. It goes to the different social media and search platforms that are always evolving. We do obviously have quite large followings ourselves as an organisation and have worked quite closely with those platforms, particularly during the pandemic, to make sure that public health information is surfaced appropriately and available. So we have those relationships and those ability to influence where we need to.
Okay, but you just wait and it's a case-by-case thing. You don't have a policy of reaching out saying, here's our new campaign, don't block it because it's
To be clear, this
people.
isn't, while it's funded through a grant by the Australian government, it's not a government campaign. It's not an authorised government campaign, so it's not our campaign to launch and to advocate for in that way.
Do you factor into the amount of the grant the time that the organisation will have to spend hassling Google to not get in the way of a Commonwealth-funded public health program, or do they just have to suck up that cost and time in fixing it directly with Google?
So the size of the grant is not something, in this case, I have any visibility of in terms of that. As Ms Charlton said, the campaign itself is performing. So in terms of the use of Commonwealth funds being used for this purpose, it is achieving the purpose that it was provided for.
Senator Waters, I do need to share
just
the
one
call,
final
so,
question, if you don't mind, Chair, just for clarity. Do grants factor in the time and money that a grant recipient will have to spend arguing with Google, or do you consider that they just have to suck that up in the cost of the campaign? And if that's not you personally, perhaps like the actual government can answer.
Chair, I'll step in here if that's okay.
Thanks, Minister.
Senator Waters, thank you for your questions. This is the first I've heard of it in terms of what happened with Google, and to hear the responses from the department here. I will follow this up with the Minister, and we'll certainly follow that up with the Communications Minister as well.
Thank you. Thanks, Chair.
Thanks, Senator Waters. Senator Little.
Thank you. In 2022, I'll just ask those officials that were here before to talk about the Aboriginal health area, please. I'm assuming they're the right ones. I'll just give some context, which I'm sure they're already aware of. In 2022, there was a significant diversion of funds into Central Australia following the lifting of the alcohol restrictions under the Commonwealth program that had been in place for many years, Stronger Futures, and it had catastrophic effect. I'm just trying to unravel where the money has gone that has gone into the significant harm that has been caused by alcohol in that community. And as you know, there was a leadership group formed of a number of organisations in Central Australia that provided advice on where that money should be spent. And yesterday I was told that the Department of Health also has some responsibility, and that brings me here. So my question goes to the Central Australian Aboriginal Congress, the Luratipura Aboriginal Corporation, Central Land Council and Tungunjira Aboriginal Corporation essentially got millions and millions of dollars to address the catastrophic harm of the lifting of those alcohol restrictions in 2022. I'm wanting to go to a question of your due diligence in decisions that are being made about where funding should go. And I was trying to find an analogy for this. I'm wanting to understand how it is your due diligence, which we so often hear about, failed to identify that some of the organisations that receive money to address the harm of alcohol misuse and abuse also have commercial interests in selling alcohol in Central Australia. And the analogy that I could come up with was, how has it occurred that the federal government and government departments have effectively given money to the vampires who are now in charge of the blood bank when you look at that situation there? I'm wanting to understand how your due diligence did not pick that up.
Celia Street, Acting Deputy Secretary, Strategy and First Nations Group. Are you talking about a particular grant from this department that's been undertaken in the NT? Because in relation to the to that package, we didn't have, as I understand it, any elements that were for alcohol and other drugs that I'm aware of.
All right, let me help you with that.
Thank you.
Have you given any money at all in your grant programs to the Central Australian Aboriginal Congress? Yes. Thank you. That's a yes. Have you given any money from your programs to Luratipra Aboriginal Corporation?
Not that I'm aware of, no.
Not for drug and alcohol, domestic violence programs, FASD, anything like that?
Not from the Indigenous Australian Health Program, but we can take on notice whether or not there's any through our other programs. Senator?
Okay. Not Tunganjira Aboriginal Corporation?
No.
Doesn't ring a bell? Okay. So let's talk about Central Australian Aboriginal Congress that got a significant amount of money to address FASD and does some terrific work in administering health in Central Australia. My issue is actually with an organisation who has in the last 3 years got significant amounts of money to address the harm that has been caused from alcohol, right? Yesterday we heard, or we didn't hear rather, from the Central Land Council, who was a shareholder of a business, couldn't tell us what businesses that company is involved with, despite the fact it is a majority shareholder. Central Australian Aboriginal Congress is a shareholder, and Tunganjira Aboriginal Corporation is a shareholder. I'm wanting to understand about your due diligence around organisations such as this, and I'm all for business development and opportunity, but how is it that health money has gone to organisations without, it appears, people understanding they have associated entities where they are directly involved that sell alcohol in Central Australia? I just want to understand how the government bureaucracy doesn't pick that stuff up. I want to understand how, Minister, how is it that, maybe you can help me understand, because you have a federal member of parliament there. How is it that there's been so much silence around this?
Senator, we might have to get some more information from you in regards to your allegations against Congress. Congress, I'm sure, can speak for themselves, but to my understanding, they have no interest in alcohol. So I'm not, unless there's a specific piece of information that you have there which you'd like to table, there is, to our understanding, no vested interest with alcohol other than to assist their patients to overcome the effects of alcohol.
What I will inform you, and you heard yesterday, the ANAO has done an audit. They went to the Central Land Council and asked for more information because they identified an associated entity that required more information. Now, the Central Land Council was really clear yesterday that it is a shareholder, sure, but it doesn't get a drawdown from those shares, but it is an associated entity. It has a connection to it, and in that instance needed to, under the instruction of the ANO, put more detail in its annual report about that relationship. But the other shareholders are also Central Australian Aboriginal Congress and Tunganjira Council.
Yes, but at no point
I'm not saying they get a return from that.
But no point was alcohol mentioned in that. And I just think, Senator, we would need to see either documents that connect Congress in your allegation against Congress to alcohol in order for the department to be able to responsibly respond to you?
I've just explained the ANAO discussion that was held yesterday in which you sat in that discussion.
I did, but there was no mention of alcohol. In regards to your questions to the CLC, it was about their participation and shareholding in an entity, but there was no conversation in any of those estimates yesterday around alcohol. So I'm saying that if you have documentation, and more than happy to respond to it, but if you have information in regards to alcohol and their involvement in it, that was not in any context the conversation yesterday.
Minister, I'm going to put to you that the question is around due diligence in understanding any connections.
And that's fine,
right?
Absolutely.
Okay, and I gave you an explanation that there are other entities as well. I'm trying to understand how it is government departments do their due diligence, because I keep hearing they're doing it well, when some of those other organisations, I want to know how many more organisations perhaps have associated entities that we are not aware of or we become aware of that have connections to the very thing that we are actually trying to address.
Sorry, Chair, but I just put to you...
really, I'm not saying... And I've said
but I need
that.
to understand the allegation. This is where we're
the
not
allegation
clear.
is a due diligence one. I'm wanting to understand.
But you're talking about alcohol in regards to due diligence. So I need to understand, are you accusing Congress...
Don't keep going back to Congress. I've named a number of organisations I'm asking...
Well, Congress is all this...
yes.
The department have said that they fund, so I have to refer to Congress.
Right. Okay.
So, sorry, Minister and Senator Little, what I heard was that the Minister is happy to receive additional information and to help get some more clarity on the purpose. Are there any other questions for officials in the First Nations Health Division that you have? Or?
Well, I want to know what it is that the department will do to ensure that corporations or organisations, they don't have to be Indigenous, they can be anybody, what do you do to understand the associated entities which might have a bearing on the integrity of the work that you're trying to do and that they are trying to do? How do we actually improve that?
Yes, Senator. What I would add to that is, as part of any procurement process or any grants process, we do look at things like conflict of interest. I can't talk in this particular case, but there's an element in terms of people disclosing conflicts of interest, and that would be part of our due diligence processes.
Because surely, I know that the Minister is compartmentalising this to the entity that you actually directly fund, but regardless, any money that comes from the Commonwealth, from the taxpayer, that goes to addressing these issues is going to have a blowback to you from a health perspective. That's why I'm asking the questions in here, because ultimately it's going to have blowback from a health consequence. So how do we actually make sure that the due diligence is done better?
We can take on notice, Senator, how we can do it. What I'm just mindful of is, if we, in all of our grants processes, tried to track every associated entity with everyone we deal with, it would be a very, very difficult and onerous thing to do. So we do rely on, in some cases, we do rely on the declaration by grant recipients of their conflict, which we then follow up from time to time to see whether we deliver any other information on conflicts. And we're happy to provide details of how we do this on notice, but there is a balance here between the other criticism we have is the speed with which we actually do get grants or commitments out the door and how long those processes take with tracking every associated entity. So I'm happy to take that on notice to see, reflect on our policy and whether we've got that policy right, but I'm having worn other hats know how difficult it is to trace through all associated entities.
All right, if you can take on notice how you're actually going to make sure that at least that question is asked, and as in the case where the ANAO has identified that the question wasn't sufficiently answered, at least there's a mechanism there if you ask the question in the first place. And I'm wanting to understand how you ask that question in future. Thank you.
Thank you, Senator Little. Yep, you finished? Yep, great. Thank you. I've got Senator Ananda Raja.
Hi. I have some questions around bulk billing. If we have the right people there.
Yes, except one too. So bulk billing is individual benefits, which is under outcome 2. So just take the guidance from the chair as to whether you want to take this here or under outcome 2.
What about the urgent care clinics? Where does that fall in? 1.6?
Yes, urgent care clinics does fall under 1.6.
Okay, let's talk about the urgent care clinics. So the urgent care clinics are a relatively new discipline in healthcare, and we introduced that in 22. Could you provide us with a bit of an update as to what has happened since 22 when we were elected with the urgent care clinics?
Yes, good morning, Senator. As you're aware, the government's commitment has been $1.4 billion over 7 years from 22-23 for the urgent care clinics. We now have 90 open, and there is a commitment to get to 137, and we expect to do that. We are seeing that the clinics are serving the purpose they were intended for. We are seeing acute injury being about 27% of the presentations, acute illness making up about 63%, and a very small number being an exacerbation of a chronic condition. We're also seeing just under a third of the patients seen from the urgent care centres being under 15 years of age, and a significant proportion, sort of around 29% of presentations are on weekends, and then a really significant proportion, about 25%, are after 5 p.m. on weekdays. So we are seeing from that data that they are serving that purpose they were intended in terms of the sorts of presentations they are seeing and making urgent care available in the sort of weekend and after hours. We did release earlier in the year the first evaluation report, which will be one of a series of 3, and we have seen some very promising findings in the early evaluation in terms of the wait time is relatively low in an urgent care clinic.
What is it?
I have it somewhere. Let me find that for you. I think it's in about the 14 to 15 minute range, and you can imagine for those sorts of presentations that you might see in an emergency department, a lot longer for that. You can imagine for those triage category 4 and 5. We also, there's a general sense that many of the patients seen in an urgent care clinic say they would have gone to an emergency department should the clinic have not been available. So again, we're seeing that consumer behaviour of seeking out the urgent care centre rather than attending an emergency department. We also really, in the evaluation, saw very high numbers of the referral post-it, whether people were sent to their GP with some sort of information or given some sort of written thing. A very small number of patients are referred to emergency, which would suggest, again, that they're doing what the purpose that they were served to do.
Could you get us some table that report for us later when it's available? And just with regards to the number of patients, how many patients have actually used urgent care clinics now, do you think?
So we've seen 1.9 million presentations.
Wow, that's incredible. And in terms of the other way around, do you have a sense of how many patients have been referred from emergency departments to urgent care clinics? Is it in that report as well?
In the evaluation report, the information we have that 46% of patients say they would have gone to the emergency department if it had not been available.
And have you got any qualitative data from patients as to how they have responded to the urgent care service?
Our information that's in the evaluation report on our website, the sense from patients is that they really value having an alternative to the emergency department. And the 2 key reasons for that being the avoided waits, as you can imagine, but also the free service in the sense that it's bulk billed and they don't have to pay.
It's free. It's a free service, bulk billed. And what impact has this had on Australian emergency departments?
Senator, the evaluation report very clearly says that you would need at least 16 months of data for each urgent care centre, which is then matched to the relevant emergency department to make a sense of it. And that's because emergency department presentations can be seasonal based on tourism, population growth, other things that have happened in the community. So you do need to see the data for over a year. So the evaluation was mixed. In some cases, we had seen emergency department wait times reduced for the triage categories 4 and 5, which would suggest they're being seen somewhere else. And in other parts, it was a more mixed result. So we do anticipate that evaluations reports 2 and 3 will give us further information about the impact on emergency departments.
I gather there was, in one urgent care clinic in Launceston, there was an improvement seen in the local hospital. Do you have any information on that?
I'll see if any of my colleagues have the specific data for Launceston for you.
While do you have that data?
I do have that.
Oh, amazing.
Data. Thanks, Senator.
Please share.
Sarah Sinclair, Assistant Secretary, Urgent Care Clinics Branch. So for the Launceston General Hospital, in 23-24, they averaged around 1,200 Category 4 and 5 presentations per month, which equated to around about 281 presentations per week in those categories. In comparison, the Medicare Urgent Care Clinic in Launceston treated around 509 visits per week in July and 516 visits per week in August for those same conditions.
That's fantastic. Professor Kidd, there was some resistance in the medical profession before we introduced this in 22. How do you think the profession has responded, particularly general practitioners?
Thank you, Senator. So you're right, there were initial concerns about whether the establishment of urgent care clinics was going to have an impact on continuity of care, whether it was going to further fragment care, and whether it was going to have an impact on workforce in general practices. I think that as we've seen through the evidence provided by Dr Devlin, there's been huge community uptake of the urgent care clinics. We've also seen a lot of engagement and communication between urgent care clinics and the general practices where patients may normally receive their care, so the continuity of care is continuing. And of course, we've seen a number of, or a large number of general practitioners who are doing some of their work in these urgent care clinics as well as working in their regular general practices.
Have there been any issues recruiting GPs into these clinics?
Mark Rodham, First Assistant Secretary, Primary Care Division. GPs are generally speaking, from the evidence we have, enjoying working in the clinics and enjoying the variety that it brings to their working lives, as Professor Kidd said. As we get into more regional areas, as in generally with health workforce, there can be more difficulties in recruiting medical staff, including general practitioners, but it has proved a very attractive model to the workforce.
So we've got 90 that are operating now. We're heading towards 137. How are we tracking? Do you have a timeline as to when you want to see 137 delivered?
There will definitely be all 137 this financial year, Senator, but we would expect to see a significant number open this calendar year as well.
That's fantastic. And have you had any expressions of interest from seats or electorates where there aren't any urgent care clinics, perhaps from local MPs who have written letters to the Minister?
It's a very popular model, Senator, so yes, we do get representations about seeking urgent care clinics.
Would you be able to give us a breakdown of how many MPs from other electorates that don't have an urgent care model have actually made a petition to the Minister?
I'd need to take that on notice, Senator.
Okay, that would be wonderful, including the breakdown of where they are, etc. And then just finally, with the expressions of interest, can you give us an update on how that's going with the next tranche of clinics that you want to roll out, the 90 to 137?
Yes, so in all cases, for all the remaining 47 clinics, Senator, the commissioners are undertaking or have undertaken the expression of interest process at the moment, so they are largely in the field.
And can you just talk me through briefly how that expression of interest occurs? Is it through the PHNs or...?
Yes, in every jurisdiction for the new clinics apart from the Northern Territory, the local primary health network is the commissioner and they undertake that process.
Okay. And finally, I'm just interested in the 1/3 being children under the age of 15. Are you able to give us a little bit of an overview of what kind of conditions children are presenting with? Because I can imagine that's a big win for families, for parents.
Indeed, Senator. So, as I said, about sort of 30% of presentations are people under 15 years of age. The most common sorts of presentations are acute injury at about 27%. So you can imagine as a parent, the Saturday afternoon becomes pretty busy after the weekend sport, as many of us have experienced, or the acute illness, which is about 63%. So those sorts of things, you might get earaches, gastro, other things that affect young children that parents want sort of urgent care for.
And just finally, do I have time, Chair? One more?
One more question.
One more. Just with the diagnostics that are required after a consultation, whether it be imaging or pathology, where do parents and where do patients go and get that care? Is it within on-site or is it separate?
There are varied arrangements, and I'll let Ms Sinclair talk you through the varied arrangements.
Mm-hmm.
Thank you, Senator. So all Medicare UCCs are required to have local arrangements in place for diagnostic imaging, be that X-ray, access to a CT or ultrasound, and those requirements are outlined in the operational guidance. That could include pathways to services on-site or proximate local arrangements in place with other local service providers.
Okay.
I can tell you my experience of taking a child not under 15 by a long shot with broken leg to an urgent care clinic, and it was amazing. It was late on a Saturday afternoon. They were just brilliant. So I love my urgent care clinic. Thank you.
Thank you, Senator Grogan, for that contribution. From the government senators, I'll go to Senator Antic.
Questions again for the TGA, picking up a bit where we left off. So I'll just... Thanks, Professor. I want to ask some questions about the childhood immunisation schedule, if I could, and start with a broad question. How many vaccines are children scheduled to receive from birth to adolescence, and how many diseases does it cover as it currently stands?
I might just take some clarity from you, Senator. Professor Anthony Lawler, Deputy Secretary, Health Products Regulation. While the TGA undertakes the pre- and post-market authorisation and monitoring of vaccines and other therapeutic goods, we're not in charge specifically of the immunisation schedule. So I might refer that question to Dr Anna Peet from the National Immunisation Division.
Thank you.
Hello, Senator. My name's Dr Anna Peet, First Assistant Secretary, National Immunisation Division. First of all vaccines that go on the National Immunisation Schedule go through Therapeutic Goods Administration assessment. They're also recommended by ATAGI and then also go through a Pharmaceutical Benefits Advisory Committee
I will come to those questions. I just simply start with the first one. How many are there? Thank you, though.
We've got 31 vaccines in total.
For how many diseases?
For 18 diseases, but that's for adults and children.
Right.
For children, I think it's about 16, but David Laffin will have to take that on notice.
You'll take on notice how many?
But the vast majority are for children.
Okay. All right. Well, then, of those vaccines, how many placebo-controlled studies have been done on vaccines on the childhood schedule?
Senator, that'd be a very difficult question to answer, and the TGA might be able to add to that, who do the initial assessment on the safety and efficacy of the vaccines.
Sure.
Thanks very much. I'm just going to ask Dr Nitin Bagul, who's one of our senior medical officers, to the table to respond, Senator.
Thank you, Senator, for the question. Dr. Nitin Bagul, Principal Medical Advisor, Prescription Medicine Authorization Branch, Medicines Regulation Division. Can I please ask you to repeat the question?
Yeah, the question is how many placebo-controlled studies have been done on vaccines on the childhood schedule?
I can take that question on notice. I don't have it in hand at the moment.
You need to take that on notice?
Yes.
I would just highlight, if I may, Senator, this is a question that's also been asked of other regulators. I think part of the challenge that we have is that while it is frequently held that placebo-controlled or double-blinded or randomised controlled trials are the gold standard in science, and certainly in the introduction of new medicines, particularly when there's no established standard of treatment, that is often the case. There are fairly substantial ethical questions to be answered around introducing a placebo-controlled trial when there is a demonstrated effective medication that is used to either prevent or treat treatment. So, for instance, given that we do have demonstrable efficacy of vaccines for many vaccine-preventable diseases, it would be ethically not only questionable but probably not arguable that a placebo-controlled trial would be appropriate, given that you would actually have to specifically not vaccinate children, expose them to the disease that we know has serious morbidity when we also know we have an effective prevention.
These are injections that we're giving to almost every child in the country at the moment, and they're not, and we can't say at this stage. You have to take on notice how many placebo-controlled studies have been done, which is the gold standard.
No,
it's not the gold standard.
I might just try and explain it in a different way, Senator. The gold standard for science is contextual, and so when there are new treatments to be determined, absolutely there is a preference for a placebo-controlled trial, so you can compare a control arm with an intervention arm, and that way you're able to remove a number of the confounding factors, but also able to demonstrate both the risk and the benefit of that treatment. When there is an established treatment for which there is not only demonstrated efficacy in terms of preventing the disease and the consequences of the disease, but also decades of real-world evidence on the safety and the positive risk-benefit analysis, the lack of an ethical basis for a placebo-controlled trial where, as I say, there is an accepted and efficacious treatment for a significant disease with significant morbidity, that cannot be described as gold standard.
How many are we talking about? Many of these cover multiple antigens, and I think in 1990 the full schedule was 21 antigens, and now it's about 60. So with that in mind, what placebo-controlled safety studies have been done examining the combination of multiple antigens in these injections?
Yes, thank you for that question as well, Senator. The growth or the evolution in the immunisation schedule, and again it might be something that Dr. Pete might like to comment on, has been cited as a challenge, and it has been in some quarters, and I'm not suggesting that you're doing this at all, Senator, but in some quarters has been spuriously associated with the rise in certain diseases or disease states. The reality is the antigenic load that is experienced by children has decreased over the years, despite the fact that the number of antigens which provide coverage.
How is that?
The volume of the antigenic load.
So, all right. So with that in mind then, back to the question, what placebo-controlled safety studies have been done examining that reduced antigen load?
Yeah, so I think it's so the comment about the antigenic load is not around the impact or the immunogenic response in the patient. It's about what is presented to the children, and there is an enormous amount of work that's being undertaken by ATAGI on a regular basis in recommending what goes into the schedule, and that's one of the considerations. I think, as Dr. Buggle has said, we will provide you with information. Okay. Given the number of vaccines and the number of diseases for which we vaccinate, it would be more appropriate, I think, for we to
I'm
provide that information.
that can't be provided now, given the history of it.
But
just to go back to your point,
information on notice.
Yes. All right. So it just, excuse me, because this is a complicated area and I'm a lay person, but to sort of summarise, you say placebo-controlled studies are difficult when there's a history of the use of the product later down the track. If we have a look at Infantrix Hexa, which was approved, I think, in June of 2006, that covers a range of antigens. I just want to explicitly look at that. Perhaps it might be easier if we look at one. How many adverse effects in total have been reported for that drug, both internally and externally, since it was introduced?
Thanks. Just while I'm waiting for Dr. Daskin to come to the table, I just wouldn't mind just addressing the fact that I didn't say.
Sorry, I don't want to put words in your mouth.
Yeah, no, that's right. I just want to be really clear. I didn't say that a placebo-controlled trial for these vaccines would be difficult. I said it would be ethically indefensible or ethically difficult.
Right.
The ethics around a deliberate process of infecting a child whom you know to be unvaccinated when there is demonstrable efficacy and safety in those vaccines, I think is difficult to defend ethically.
Right, okay, well that's a...
and that's I would say that's not just my opinion, it's a fairly broadly held
It's convenient. It's a convenient opinion, though.
Well, it may be convenient, that doesn't stop it being true.
Convenient. Sorry, back to the issue of adverse effects in total for Infantrix Hexa, internally and externally, since it was introduced.
Thank you for your question, Senator. Dr. Daniel Daskin, Acting Principal Medical Advisor, Pharmacovigilance Branch in the Medicines Regulation Division. I would say that the TGA maintains a robust system of post-market surveillance for all vaccines, including Infanrix Hexa. We publish publicly on our database of adverse event notifications all adverse event reports received for all registered medicines and vaccines, including that particular vaccine. In terms of the specific number, I'd have to take that on notice and come back to you, Senator.
Okay. Okay. Can I ask you just a separate question about recently, September 2025, in the United States Senate Committee on Homeland Security and Government Affairs, a report was produced to that committee, the Henry Ford Health Study. It's a study that found it's an unpublished retrospective study comparing health outcomes in 18,000 odd children born between 2000 and 2016, and just under 2,000 were unvaccinated, 16,000 were vaccinated, and it showed that vaccinated children had a statistically significant rates of chronic conditions, 3 times atopic disease, 4 times just over asthma, 5.5 times neurodevelopmental disorders, and 5.96 of autoimmune, to name a few. It's pretty concerning stuff. To the question, though, is the TGA aware of that study and in outcomes between vaccinated and unvaccinated children? And if so, have there been any internal reviews or assessments of its methodology and preliminary findings, noting that it was not just it was the US Congress, I think, or Senate, it was produced to?
Yeah, thanks, Senator. Look, I don't feel that that we're at a position where we can provide a significant or detailed critique on that. I recognise.
Is aware of it?
I'm aware of the report. I know that it has.
Senator Antic, sorry, Professor Lawler, can I get you to table that?
I don't have the report on me, but I can table it later.
Yes, if you can send it to the Secretariat, that'd be great.
Sure.
Thank you.
So I'm aware that it's been commissioned by a non-profit vaccine safety organisation called the Informed Consent Action Network.
Yep.
The motivations and methods of these groups are not always clear or transparent to external review or critique of articles or reports. I also note that it is an unpublished draft currently, so we're not really in a particularly strong position to assess that. I would say also that in line with our pharmacovigilance practice, we do incorporate signals from a variety of sources, our adverse event reporting, discussions with health professionals, conversations with other regulators, publications in peer-reviewed journals, and indeed we do maintain an open eye to even unpublished drafts from non-profit advocacy organisations.
Just one final thing before I think we might have to hand the call back, but a number of weeks back, the US government released some information about the use of paracetamol in pregnancy, and it was suggested that there were some risks and developmental risks for children. And the makers of one of the paracetamol drugs, Tylenol, in 2017 tweeted, actually, we don't actually recommend using any of our products while pregnant. Thank you for taking the time to voice your concerns today. Yet I see that the TGA 23rd of September released a press release suggesting that use of paracetamol in pregnancy is okay. That is, can the TGA confirm that the use of paracetamol when pregnant is safe and has no causal link to any developmental disorders?
So thank you for that and question, and thank you for the opportunity to discuss this. This is a very important issue, and obviously has generated a significant amount of excitement and interest. And the TGA and the CMO, I think I can speak for Professor Kidd, we're very pleased to have the opportunity to make public comment on this matter. Obviously, determinations and announcements by the US government are a matter for them, and questions of that should be directed to them. On the issue of paracetamol safety, I think it is important to note that the statement that was made by the Commissioner of the FDA, who the scale is different, but his role is broadly comparable to my own, was that there is an identified association between paracetamol and autism in pregnancy. I think it's worth noting that a correspondence went out, and the indication was made that they would write to all doctors in the US. A communication went out from the FDA on the 22nd of September saying, to be clear, and I'm reading here, to be clear, while an association between acetaminophen, which is the generic name for paracetamol used in the US, and autism has been described in many studies, a causal relationship has not been established, and there are contrary studies in the scientific literature. There was a study that was cited that showed potentially mild association between the use of paracetamol in pregnancy and autism. Pardon me, I think it's important just to take a brief aside at this point to clarify the distinction between association and causation. Association is a situation in which two things occur at the same time and can be demonstrated statistically. Causation is when one causes the other. The reason it's important, I think, to note that is because earlier this year a study was published by Alquist et al., which looked at about 2.5 million births in Sweden over a significant period of time, and was able to remove a number of confounders, which are kind of external factors that can change the way a study comes out. Most importantly, they were able to correct for various variations, but also very importantly, they were able to undertake sibling matching, which meant that they looked at pairs of siblings which you would assume had the same, at least, well, I was going to say at least exactly half the same genetic profile, the same maternal health issues, and predominantly the same environmental issues, one of whom had had paracetamol, one of whom had not had paracetamol. What that study showed, the largest study to date showed, is not only is there not a causal link between paracetamol and autism, there's not actually an association. And so we recognise that, that this has been potentially a very difficult time for patients with autism, for people with autism, but also for mothers who potentially are struggling with some of the decisions that they made, and this could have caused particular issue. And so one of the very important things that Professor Kidd and the TGA were very keen to say is that yes, indeed, it is still regarded as a Category A drug, which indicated that it's safe and effective in pregnancy. A couple of other things I would say that I think are really vital here is that there are very few alternatives for pain and fever treatment in pregnancy. A number of the other drugs that you or I would take are simply not appropriate at any stage of pregnancy. And so paracetamol is something that pregnant mothers, because it's important to note that one of the confounders is actually the fever of the condition that's being treated with the paracetamol.
So, Senator Antic, sorry, I need to share the call in a sec if I can get one last question from you.
Yeah, sure. Well, it's actually, first of all, how much then do you recommend for pregnant women, and how much do you recommend for pregnant men?
Paracetamol is a medicine that has been used and is regarded as safe and effective used as directed. Every medicine that we have on the Australian Register of Therapeutic Good has both product information and consumer medicine information. There are directions. We have seen that there is the suggestion that you should not take paracetamol unless you need it in pregnancy. That's true for every medicine in every situation of life. You should take medicine only when you need it. I do also believe that it's important that conversations around medicine, when unsure, should be undertaken with your trusted health practitioner.
Great, thank you. I'm going to go to Senator Waters.
Thank you, Chair. Hi, folks. Just harkening back to the reproductive healthcare inquiry conducted by this committee several years ago now. It's been more than 2 years since that inquiry issued our report. Ending the postcode lottery, which was again a consensus report on women's health. I'd like some updates on progress on the recommendations, and in particular, I'm interested in the recommendation for essentially a national one-stop shop information portal for people seeking help with repro health services. The recommendation was for a national portal. Has anything been done with the states to develop that tool or with anyone to develop that tool? Excuse me.
Senator, I'm just working through to figure out which recommendation number that was. There are quite a number, and I do have notes against all of them.
Thank you. I don't have that number to hand, I'm sorry.
It is one we could get for you later this afternoon as well. There was a recommendation that the Australian Government, in consultation with state and territory governments, implements a national support information and referral model
that's the one.
For sexual and reproductive health services.
Thank you.
So a feasibility study for Health Direct to address the recommendation has been completed. The outputs from the study were delivered to health ministers early this year. However, the Department is looking to conduct additional research and stakeholder consultation before we will seek to kind of finalise the study.
Okay, I just couldn't quite catch all of that. So could you say that again a little more slowly, and perhaps can I get Hansard just to turn the volume up a smidge, please? Thank you.
A feasibility study for Health Direct to address the recommendation has been completed.
Yep.
The outputs from the study were to be delivered to health ministers earlier this year. However, the Department is seeking to conduct additional research and stakeholder consultation, which is delaying us finalising the deliverable, and we'll seek to finalise it as soon as possible.
Okay.
This was a recommendation that was supported in principle.
Okay, that's great. Thank you. And so, sorry, why was it delayed to go to health ministers? What was the issue upon which you sought further stakeholder consultation?
I would need to take that one on notice.
Okay, thank you for doing so. Another recommendation was that the department work with state governments to review the effectiveness of programs providing free period products, and some states are doing better than others in that regard. So is that happening? Are you working with the states on free period products? And then I have a separate question about the period products that the nachos have been funded to deliver.
Yes, we are engaging with states and territories to gain an understanding of the various measures that they have undertaken to address period poverty in their jurisdictions.
Okay, you're engaging with them to see what they're doing, but what is the Commonwealth going to do?
So if I can just turn to a different page so I can give you information on that.
Senator, you would be aware of the announcement of the government of the partnership with NACCHO for remote communities.
That's my second question, but just not quite there yet. Thank you, Ms Devlin.
I was going to turn to the NACCHO one, because that is what we have been doing already.
Okay, so that's the extent of your activity. You're not going to do anything to supplement the states because you're reviewing the adequacy of the state programs. Is there an intention, if you find gaps, which I think there are, for the Commonwealth to address those gaps?
We're working through the analysis to understand the size, complexity, etc.
Okay.
It would be a decision of government whether
Minister,
it would be addressed.
Sorry to cut you off there. Is there a commitment from government to address any gaps in period programs?
I'll certainly take that question on notice in regards to right across Australia, Senator Waters. We've certainly made a commitment in regards to NACCHO and the Aboriginal Medical Services and their relationship with First Nations clients.
Yes, thank you. Well, I will come to that now. How many NACCHOs are participating in that program, and how many facilities in communities are getting access to free period products?
So NACCHO was engaged and a grant agreement was executed in February. NACCHO has been scoping out and understanding what kind of products are offered, types, costs, stocks and other products across the country. They've engaged with 113 ACCHOs through this process in MMM 3 to 7. And they've engaged with some of the other NGO programs that are delivering free period products. They have selected a provider for an initial 3-month period to test the logistics, etc. And that will be rolled out to 7 starter sites. We expect that will start shortly.
Okay, why just 7?
Because it's they want to test first before rolling out more broadly. It is a complex piece of work to deliver.
Thank you. Is there an intention to roll them out to all First Nations communities once you find a model that works? They
need to test the model and come back also with. So we're Nacho is doing this work for us, and come back with an understanding of where the need lies as well.
Yes.
So it's a combination of a model and a need overlap.
And Minister, is there a commitment from government to meet the need?
Yeah, sure. Look, I'll just jump in on that one, Senator Waters. I'm certainly watching where we're going in terms of this particular policy in rolling out the period products with Nacho and the model. At the same time, we're rolling out food security and 30 essential items across 152 stores. 152. We've reached about 102 stores in remote Australia so far. So those 30 essential items don't include the free period products at the moment.
They might though. They could.
Well, that's right. So I am watching this very closely because clearly we want to be able to do it, but I am mindful that Nacho will be able to give us some solid advice as to how they're going with rolling it out.
Thank you. Can I move on now back to perimenopause and menopause? Firstly, for the Women's Health Advisory Council, which was tasked by the inquiry and the government's response to look at particular matters. But firstly, is there a work plan for the Women's Health Advisory Council? And is that available anywhere publicly, or if not, can you table that work plan?
Yes, there is a work plan for the Women's Health Advisory Council. I believe it would be on the website. I will check for you. If not, I will table it here.
Okay, thank you very much. So one of the recommendations of that menopause inquiry was that the council, the Women's Health Advisory Council, work with states and territories to develop a menopause action plan. Has council discussed that, or has anything been done on that one?
Again, I just want to check the number of that one and go through it. So that was the committee recommends that the Australian Government task the National Women's Health Advisory Council to assist state and territory governments to deliver a national menopause action plan, which addresses best practice. That was supported in principle. The council is currently working, it is not part of its 2025 work plan. Council's term ends at the end of this year, and kind of consideration of the next term and what might be on that is yet to come.
Okay. What's the mechanism for in making, like presumably it will, if the government's accepted it in principle, how do we make sure that happens?
I will.
Forgive my ignorance, I don't know about those processes.
Yes, so Senator, I think the Women's Health Advisory Council obviously is made up of sector representatives and chaired by the Minister. So in a way, it kind of has no capacity to direct states and territories. It really is advisory to the Commonwealth Government. And I would suggest that most of their advice has been very informative to the women's health budget packages that we've had through 2 successive budgets now. So I think that has been the focus of their efforts, as opposed to sort of coordinating or directing states and territories. They have, however, had a role in the National Women's Health Strategy, and if you like, the report that has been collated around that, because that is a collective effort of the states and territories in terms of women's health, the national strategy. And so the advisory committee has had a role in shaping sort of the measurement of the progress of the National Women's Health Strategy, but also the report that has been recently released. So that's been their mechanism in terms of working with states and territories, because we do work with the states and territories to report on the measures in the National Women's Health Strategy.
Thank you. The government's response to the inquiry also suggested that the Women's Health Advisory Council talk with the Australian Medical Council and the medical deans to include, and that's recommendation 23, to include actual education for folks studying to be doctors and nurses about women's health, and in particular about perimenopause and menopause, because in some cases they get 1 hour, which is outrageous sexism. Have you been directed to undertake that work to encourage the council and the deans to update their curricula to bring it into this century?
Under the last term of the government, the former minister, Assistant Minister Carney, actually met with the deans, and so we would have to go back and these were certainly the issues, because she was very keen to raise them personally. So we would have to go back to that meeting, but that was kind of the government's efforts in terms of the minister personally working with the deans to advance that.
Okay, so one meeting. Do you know if the new Assistant Minister for Women's Health, if that's the right terminology, Ms Carney's replacement, has taken that issue up as well?
I'm not aware of that, but we would need to check with her office.
Okay, thank you. The August communique of the Council refers to an update on the development of a contraception decision support tool, and I understand that's the budget allocation to support some kind of decision-making tree. Can I have a bit of information on who's doing that tool, where's it up to, and will that tool also include information about the barriers to accessing contraception and the cost of contraception?
So the tool, the policy parameters for the tool are largely complete. So they were developed within government, working with a wide range of stakeholders through consultation, including the Women's Council. The Health Director are building the tool. They have started the process of user design for that, and we expect to have a tool early next year.
Okay, so it will be able to be used by people early next year.
That is our expectation, yeah.
Great. There was a Medical Research Future Fund grant for an Australian perimenopause and menopause study, which I welcome, and I'll put some questions on notice in about that. But a proposal researching the impacts of peri and meno on First Nations women didn't get funding. What is the government doing to address the lack of targeted peer-reviewed research on First Nations women's experience of perimenopause and menopause, particularly research that's actually led by First Nations women?
I think we would need our colleagues that support the MRFF and the NHNMRC to help you with that in terms of their programs.
Well, I'm happy for them to take their bit on notice, but given that nothing's actually happening under their auspices, my question is, what is the government and the department doing, given the lack of support so far?
Well, Senator, as you would appreciate, the Commonwealth's largest investments in health and medical research are both through the NHNMRC and the MRFF, so any direction of efforts are through those two programs.
Okay. And since they haven't funded any, what's the government doing about that? Maybe that's a question for the Minister. Will you now intervene? Or
Senator Waters, that will be your last question. I do need to share the call.
Thank you.
Senator Waters, I can take that question on notice for you.
Okay. Can I just put one more on notice quickly, Chair?
Yes,
just
quickly.
Thank you. Just to the TGA relating to our earlier discussion, could you let me know on notice, please, since 2005, have any pharma companies applied to the TGA to bring their MHT patches to Australia? Thank you. Thanks, Chair.
Thank you, Senator Waters. And Senator Ruston.
Thank you very much. Can I just ask some questions about the CDC or the proposed CDC? Does that go to you, Mr. Kidd, or
we do have colleagues who are
Professor?
about to join
Sorry,
us.
Professor Kidd. How rude of me.
Thank you, Senator.
It'll be primarily Mary Wood, Miss Wood, when she gets here, who's the head of the interim CDC.
Okay. Well, actually, maybe to go to you, Professor Kidd, what did the CMO actually do during the COVID pandemic, particularly in relation to the powers of the Biosecurity Act?
So can you just repeat that, Senator?
So what did the CMO actually do during the COVID pandemic, with particular reference to the Biosecurity Act?
So if I may just go back to the question you asked before, I have advice that there were 75 instruments for COVID-19 made by the Department under the Biosecurity Act of 2015. Under each of these instruments, powers would have been used a variable number of times, and we have can provide further details on how the Act worked, if you wish.
Were any of those 75 instruments issued during the time that you were the CMO? Acting, as the CMO?
Yeah, I only had very brief periods as acting CMO. I don't recall being involved in any of those particular instruments, but we would need to, again, take that on notice.
Yeah.
It's 5 years ago.
So you weren't acting when the declaration in relation to Australians from India being prevented to coming back into the country?
So if I can just give you a little bit of background to the Biosecurity Act, the Governor-General made the declaration on the 18th of March 2020, and that was on the advice of the then Minister for Health and Aged Care, who of course consulted with the CMO, the Australian Health Protection Principal Committee at the time, and with relevant colleagues in the government at the time.
Okay, so the CMO makes a recommendation. So the Director General of Biosecurity, what's the interplay between those two, between the CMO and the Director General?
Yes, so at the moment, the Chief Medical Officer is the Director General for Human Biosecurity.
Okay. So CMO, Director General of Biosecurity, makes a recommendation in relation to the use of these powers. It still then has ministerial discretion in relation to the exercising of those powers, and then it goes to the Governor-General for the determination.
That's correct.
Okay, great. Okay, thank you. So under the legislation that is currently before the Parliament, who has the decision-making power with regards to public health and social measures should we have a pandemic?
I'll ask Ms Wood to start this answer. It's not... She will answer, but it's not as straightforward as that. There is a difference depending on the nature of the decision being exercised.
So you're making it more complicated by this Act?
Well, I'll allow Ms Wood to comment, but what part of the CDC design is responding to is the recommendations of the COVID-19 inquiry. And one of the distinctions being drawn is there are some decisions which you might describe as, without diminishing them, reasonably technical decisions and on medical and health basis, and there are others that go to significant issues with whole of government or whole of society concerns in terms of the trade-offs that might be involved, and that's really what the COVID-19 inquiry highlighted. And so the design that is proposed in the legislation tries to reflect the different nature of the decisions and therefore who's the appropriate decision maker on that, where that decision maker always should be informed by the best available health advice at the time. But I'll allow Ms Wood to expand on that.
Thank you, Secretary. Mary Wood. I'm the Deputy Secretary at the Interim Centre of Disease Control. Senator, by and large, the powers that the Parliament are considering are being distributed differently, so there's no expansion of powers, if you like.
Sorry, maybe I should ask the question again so we'll be really clear here. I want to understand, under this legislation, who has the decision-making power, and maybe you could explain what changes to decision-making powers occur under this legislation in relation to public health measures during a pandemic.
In relation to the Biosecurity Act in particular, Senator?
Well, in relation to the Biosecurity Act, but I mean, just more generally, what I'm really concerned about is that we have this enormous great organisation about to be created and we really can't follow where the powers are going. So if you could just tell me, how many people have powers under the new Act?
So I'm happy to take that question. So there are two bills, as you know, Senator, that are before the Parliament. They transfer responsibilities and powers of the Commonwealth Chief Medical Officer in some powers to the proposed Director General of the CDC. So in relation to the Biosecurity Act, there's some powers that are proposed to transfer to the Director General that reflect their discrete public health functions in the Commonwealth. As you appreciate, a new statutory agency comes with different functions and responsibilities that is designed in ways to be distinct from the Chief Medical Officer, whose role has changed somewhat since the pandemic.
Okay, so I'm particularly keen to understand there seems to be a transference of powers to the Secretary from the CMO that cannot be delegated. Could you explain to me what those are?
Thanks, Senator. So there's the Director of Human Biosecurity is the broad function that you're describing, and that's been split into different responsibilities. So the key current decision-making powers of the Director of Human Biosecurity are in relation to determining listed human diseases. That's one of the powers that is proposed through the bills to transfer to the Director-General of the CDC.
No, I just asked you about the ones that have been transferred to Mr Comley or whoever holds that position.
So the Secretary will, under the bills, be the Director of Human Biosecurity in relation to each of the powers, other than those two powers that are proposed to go to the Director-General of the CDC. I've mentioned the first one, which is the listed human diseases. The second responsibility that's proposed through the bills to transfer to the CDC is responsibility for providing a human health risk statement if required by the Department of Agriculture.
So, Professor Kidd, do you think that Australians would accept a declaration coming from the Secretary as opposed to a declaration being informed by the highest medical officer in the land as being the appropriate place for these sorts of decisions to be made?
So if I may, we have a similar situation with the chief vet and where the responsibilities sit with the Secretary of the Department where she sits. And my understanding is that this will mirror that arrangement which works in that department. I might let the Secretary speak, though, about the consultation that he might undertake when making decisions.
Yes. Well, I mean, and that's fine. Mr Comley can obviously speak for himself, but I'm just somewhat confused by what does this legislation seek to do that currently can't be done in terms of all this transference of powers and delegations and declarations? What are you trying to do here that you can't currently do?
So if I might start at the sort of principle level, the philosophy behind the CDC is that it has three elements to it. Independence, so it can make independent recommendations, is expert. So the expertise sits within a statutory body that is separate from the Department of State and is generally advisory. And that distinction between expert, independent, advisory and the operation of the department is to recognise that in the exercise of many of these biosecurity functions, there is going to be a need to balance a range of considerations that go beyond straight health. So, as we saw during the pandemic, a decision to make certain health-related directions had very significant economic consequences, triggered a range of other things at both state and Commonwealth level, and so we're trying to achieve that distinction. The CDC in the first instance will primarily concentrate on communicable diseases, but over time will also be independent, expert and advisory on non-communicable diseases to elevate public health at the Commonwealth level. Perhaps one thing that is worth pointing out, because in the design of the CDC, many people, there were some people who advocated the CDC should make decisions unilaterally and that should have impact both on the whole of the Commonwealth but also on states and territories. That's not the intention. The intention, again, is that states and territories would still have responsibility for their public health powers, so we're not fundamentally rewriting the arrangements between the Commonwealth and the states in the process, but they would be informed by the independent expert advice of the CDC, and the intention is that the AHPC would still continue, chaired by the Chief Medical Officer, but the DG of the CDC would be on that AHPC as well. Yep. So we're trying to have a centre of expertise that can be independent and be seen to be independent, can at some circumstances be in a position where it publishes its advice that could be informing the community, but it is also advising...
So Mr Comley, sorry, we're really short on time.
Sorry.
So what is this body going to do that you can't currently do now?
Well, I think the point I come back to this independent, expert and advisory, and Ms Wood won't want to comment. One of the things apart from having a centre of expertise on public health, it is really the sense of, in times where people in the community really want to know, it is independent statutory advice that is available, and then it informs decision making that has to, by its nature, take account of a broader set of considerations when forming a final judgment.
So the Centre of Excellence on Public Health, you just referred to it as?
Independent expertise on public health, including communicable and ultimately non-communicable diseases.
Okay. So this is actually expanded out to be something quite a lot bigger than the original intention of being able to have a centre for disease control that was enabled Australia to maximise its preparedness for another pandemic. That doesn't seem to be what it is anymore.
I can't comment on exactly who you might be referring to who had expectations of what it would do. I would say in terms of the vast majority of stakeholders that we deal with, they always envisaged the CDC to have a remit that was beyond just communicable diseases and went to non-communicable diseases. In fact, if we've had any criticism, it's because of the staging of the approach and a desire to have more work on non-communicable diseases. I don't know if you'd like to comment, Professor Kidd.
I'm just interested. So what activities of the department will be transferred to this? So out of all the things and all the organisations that currently do various things, including yourself, Professor Kidd, which of those functions are going to be transferred into this CDC, including from your own department, Mr. Comley?
Yes, I'll ask Ms Wood to comment. I just note that there's a separate thing. I restructured the department, not motivated by the CDC, but with the idea of having the CMO have a role as a chief medical officer without the need to run a group. And so Ms Wood is running the group that used to be run by the CMO, and a significant number of those functions are transferring into the CDC. Maybe you'd just like to list those, Ms Wood.
Thank you, Secretary. And just to directly answer your question, Senator, in relation to what powers to be conferred to the CDC from existing legislation, there's 3 acts of parliamentary transfer.
That's all in the EUM?
In terms of the functions, so as the Secretary's indicated, the CDC will be progressively implemented with an initial focus on communicable diseases, strengthening pandemic preparedness, as you've indicated, environmental health, climate change, and other areas of public health risks such as antimicrobial resistance. A lot of those functions
currently in the department.
That's right, and they will be. The anticipation is that they will be mobbed out to the CDC. The numbers of staff who would be transferred hasn't been decided in granular terms, but on the whole, we're expecting something in the order of 200 or so people who are currently in the department to move to a statutory agency if the bills are passed in their current form.
So the 200 people that will be mogged out of the agency into the CDC, is that all the staff for ASL the CDC will have? Or will there be more than that?
No, it's envisaged to grow over time and to the order of sort of 250 or 260 people, but the exact number will depend on a couple of things, obviously including the seniority, technical skills and expenses of the additional skill set that the Director General, once he or she is appointed, will want to bring in, which will also be a little determined by strategic
She will want
priorities.
to bring in?
Sorry, as in new recruitment.
You just said she will want to bring in.
He or she,
sorry. Okay. Sorry, you just said she.
No, she said he or she.
Apologies, I intended to say he or she.
Okay.
We haven't determined the person.
No, well, that was what I was about to ask.
I think that's what she's alluding to.
Yeah.
So, okay, so I'm interested to understand what the need or the rationale is in, Ms Wood, you were talking about the acts that are seeking to be changed by the Transition and Consequential Provisions Act that include amendments to the FOI Act that apply specifically and only to the CDC. I'm interested to understand why it is believed that the current FOI Act in its current form is insufficient to be able to deal with this.
I'm happy to answer that at a high level, and Mr Madden might have some further information to add. But the Consequential and Transitional Bill, the second of the bills that are before Parliament, amends the FOI Act essentially to ensure protected personal and commercial information won't be disclosed. So it's consistent with other FOI principles.
So what I'm understanding is, why do you need this provision, and what is the insufficiency in the current FOI Act that you are seeking to remedy by actually making, because the changes to the FOI Act are quite substantial.
The changes just reflect a new data regime that's proposed for the CDC. So there's obviously some reasonably significant additions through the creation of a proposed public health network that's manifest in the data provisions in the bill, and with that comes some consequential amendments to the FOI Act. It's not changed, it's just consequential rather than substantive amendments.
Okay.
Senator Ruston, it is now 1 o'clock and I've always prided my career on never standing between a room full of people and food. So I'm just going to get a sense of how much longer you need to wrap up this block.
Look, I'd prefer to come back if that's easier.
The Hungry Bunch will probably agree with you. So if we can convene for lunchtime. Sorry, Minister.
Thank you, Chair. I just want to, for Senator Waters, just to clarify that the period products are on the 30 essential items until we see the model of nachos so that they can be part of the free period products.
Thank you for noting that for Hansard. We will convene to lunch and we will return at
Chair, could I just ask before you go to lunch if you'd had any opportunity to be able to get me that timeline in relation to the Medicare website?
Can we seek to have that before the end of outcome 1 this afternoon by officials, Mr Conley?
We'll do our best. It's very hard for me to commit. I haven't seen any of the material. I don't know how hard it is to extract.
Okay, great. But we'll endeavour to do that. Thank you for the reminder, Senator Ruston. We will see you at 2 o'clock. Still a continuation of outcome 1, and I will now hand the call to Senator Roberts.
Thank you, Chair. Could I have questions of the TGA, please?
Oh, can you just give me 1 second as the TGA make their way? The Secretary just wanted to correct the record on it.
Thank you. TGA will come to the table, but in evidence that Ms Clancy provided to Senator Waters, she asked about the timing on the design of a contraceptive decision support tool. Ms Clancy said that it would be available from January, but in fact the build will commence in January. It will be available from mid-year. So I just wanted to make sure that that was on Hansard so that we correct that piece of evidence.
Excellent.
Thank you.
Secretary, and we'll draw Senator Waters' attention to that. I'll hand the call back to Senator Roberts. It's the TGA now at the table.
Thank you, Chair. Thank you for being here again, especially Professor Lawler. Before I start, can we deal with a statement I hear on the internet all the time, that you get more aluminium in your food than you do in vaccines? Aluminium in food is ingested at 0.3%. Aluminium in vaccines, it's ingested at 100%. Individual results may vary. Is this a fair statement?
I'm not sure where you're seeing that. Sorry, Professor Anthony Law, the Deputy Secretary, Health Products Regulation. I don't have the information you're referencing in front of me, Senator.
I'm asking you, is it accurate?
Well, I'm not sure that that's necessarily a question for the TGA to respond to. We can provide you information on the process that we undertake in terms of the evaluation and authorisation of therapeutic goods, including vaccines. It would be important. Is this a claim that the TGA has made, and where?
No.
Okay.
That's my understanding. What is the TGA's recommended maximum daily intake of aluminium for a child aged 6 months, please?
By mouth, in terms of as a recommended daily. I don't believe that the TGA sets a recommended daily injection of aluminium.
What about what's the daily maximum for a child of 6 months that can ingest aluminium, food or
ingesting? I would suggest that those are probably questions best posed to the Food Standards Australia and New Zealand, Senator.
Okay. The US Food and Drug Administration recommends exposure of 5 micro mcgs per kilogram in infants. At 6 months, the average weight of an infant is 7 kilograms, making the maximum daily exposure 35 mcgs. Hexa infant vaccine contains 825 mcgs of aluminium per dose, which is 24 times its safe daily limit. Do you accept that injecting children at 23 times the safe level? And do you accept that this unsafe aluminium exposure is a contributing factor to aluminium-derived autism?
Okay, so I'm going to throw to Dr. Dascombe in a moment. I'll answer a couple of the things there in reverse order, if I may. The first is, in answer to your second question, no. I don't believe that there is a regulator. I'm happy to be corrected. I don't believe that there's a regulator, a recognised regulator that does.
So rather than relying on someone else, do you have any research?
So I'm just trying to answer your question. I don't believe that there is another regulator. I'm just using that as a backup, that we have seen no credible safety signal that aluminium load, either in single or through the scheduled immunisation delivery, is a contributor to autism. The second thing I would say is I'm not sure that this is the forum, nor do we have the time to clarify the distinction between injected and ingested aluminium. They're quite different biomechanical processes, and I don't think that the two are comparable. But I will ask Dr. Dascombe perhaps to add to that answer.
Thank you, Professor Lawler. Dr. Daniel Dascombe, Acting Principal Medical Advisor, Pharmacovigilance Branch in the Medicines Regulation Division. I'd echo the comments of Professor Lawler. Senator, neither the TGA nor any international regulator has detected nor confirmed any safety signals relating to any vaccine and autism. And this is also supported by the weight of scientific evidence.
What is the TGA guidance for the injection of multiple vaccines into a 6-month-old at the same time, causing amplified aluminium? Each of those doses has these levels of aluminium adjuvant, a preservative. So each of them is 24 times the daily safe limit.
Yeah, my apologies. Apologies for breaking this. And so there are a couple of things on that. It is not the practice of the TGA nor the role of the TGA to make recommendations on immunisation schedules. That sits within the province of the ATAGI, the Australian Technical Advisory Group on Immunisation. I would also highlight that we have frequently responded to questions around the aluminium load in the vaccination schedule and their consequences. Most recently, I think, but perhaps more recently, is Senate question on Notice 24-003075. We discussed at this place a number of times.
Thank you. You see the problem, just one vaccine can be 24 times over the safe daily limit, and you're recommending injecting multiple of them at the same time. These infants could be 100 times the safe limit, or far more than 100 actually, and you just keep on injecting them right in there and then claim aluminium poisoning isn't the reason they come down with autism, on some cases the very next day. How can you justify this?
So I'll answer those questions in reverse order, if I may.
Sure.
I'll answer the second. There is no indication that that the vaccination schedule is linked to autism, and indeed, as has been highlighted just today, but also previously, there's no credible evidence that there is a linkage between vaccination and autism. And as I just indicated in my previous answer, is not the role of the TGA to recommend vaccinations. We assess them for safety, quality and efficacy. It's the role of ATAGI to recommend the vaccination schedules.
Thank you. Why don't you tell the pharma companies to reduce the aluminium preservatives down to safe levels so you can get parents to trust your vaccine again?
Thanks for that.
Actually trusting your advice again. So that you can get the parents to trust your advice again.
Yeah, so thank you for that, Senator. So there are a couple of elements in your question as well. We evaluate the submissions from sponsors and evaluate the process of manufacture and also quality control to ensure that the balance of risk versus benefit is appropriate, and that's a determination that we make in not only in the authorisation but also in the post-market monitoring through our pharmacovigilance of any therapeutic good with the inclusion of vaccines. In terms of trust, we recognise that there is an active campaign to undermine the trust of regulators, the TGA particularly, and we undertake to restore or bolster the trust of the public, which I have to say is despite some narrative still at a high level since and including during the pandemic. We seek to do that through education and guidance, through being very clear and transparent about what we do, and by addressing mis and disinformation when and if it occurs.
Thank you. How many vaccines in the Australian schedule have been subject to a gold standard trial, meaning specifically a randomised, double-blind placebo-controlled study where the placebo was saline and not another vaccine?
Thanks for that question, Senator. I recognise that you weren't here before lunch. We did have a conversation with Senator Antic regarding the use of the term gold standard. We recognise that the use of a placebo-controlled, randomised, double-controlled trial, there are a number of different terminologies used, is of a very high standard and presents robust and dependable evidence. The challenge, of course, is whether something constitutes gold standard in the way that you've used it. Actually, very much depends on context. So we use controlled or blinded trials or placebo trials when we are interested in determining the difference between a control arm and an intervention arm. The challenge that we have is that this is a really effective way when we're looking at incremental improvements in therapies or when we're looking at the introduction of new therapies. The challenge we have, of course, is that when there is an established therapy that has been shown over decades using both documented and real-world evidence to be both safe and effective, it is ethically questionable and, in fact, in some instances, ethically indefensible to be using a placebo in that non-intervention arm. I might give you an example, if I may. Two examples. There is a consideration that if we have vaccine-preventable diseases and we have a very clear demonstration of reduction not only in mortality but morbidity in those diseases, let's choose polio, let's choose smallpox, diseases that have had specific impact for many decades and have led to untold suffering, one of which has been eradicated by the use of vaccines and one of which has been virtually eradicated. If we were to introduce placebo-controlled trials for those drugs, that would be horrendously unethical, I should say, because what we'd be essentially doing is knowingly infecting children with a disease that could kill or paralyse or maim when we know that there is a way of preventing that. That's not ethically defensible.
Thank you. So what you're saying is that there's been no double-blind placebo control study where the placebo is saline and not another vaccine?
No, what I'm saying is that that would not be an appropriate approach to be taking today with the vaccines that we use.
So has it been taken in the past?
Sorry, well, I also would highlight that that the introduction of vaccines have occurred some time ago, and also...
So it's not been done?
Sorry, Senator, I'll let you finish, sorry.
It's not been done then?
Well, we've actually already... Sorry, Senator, go on.
The test?
Whether these...
Double-blind trial?
Well, we've actually already taken on notice today to provide concrete evidence on which of those vaccines have been subjected previously to placebo blinded control trials.
Okay, thank you. How many COVID vaccines have been destroyed because they aged out, and what was the purchase cost for those products?
Dr Anna Peake from the National Immunisation Division is coming to the table to respond to that, Senator.
Can I just signal that this is your last question, Senator Roberts?
Okay.
Senator, if I may, could you please repeat the question? I didn't quite hear it while I was coming to the table.
Yes, certainly. How many COVID vaccines have been destroyed because they aged out, and what was the purchase cost for those products?
Senator, I'd have to take that question on notice. I don't have that available with me today.
Thank you. If you could tell me if it was close to 35% of the multi-billion-dollar COVID vaccine supply was binned, trashed?
Senator, I'd have to take that question on notice.
And I'm asking for you specifically to tell us whether or not it was 35%.
I don't have that figure in front of me.
No, I'm asking for you just to say what the figures are.
Okay.
And if you can confirm that that's 35% of what we bought.
Yes, can do, Senator.
Thank you, Chair.
Thank you very much, Senator Roberts. Senator Ruston.
Thank you. Back to the CDC, if I could.
Yep. Jordan. Yes, back to Alex, and then you might get on. Coalition have had none because we've been swamped with prosperity. So, Coalition have had no questions.
So if I could ask, what foreign CDC would you say that the model that is being proposed by this legislation is most closely aligned?
Mary Wood, Deputy Secretary, Interim Centre of Disease Control. Sorry, Senator, do you mind repeating the question? What forum did you say? Or what
I said, what foreign CDC would you say that the model that's being proposed by this legislation is most closely aligned?
Look, we took features from different models recognising the federated responsibilities in Australia and the design features that the Secretary described earlier, including that we're not seeking to change the roles and responsibilities within the Federation. So the Director-General's duties and responsibilities are additional and essentially add Commonwealth investment and further clarity to the purpose and nature of public health advice. It doesn't change any roles and responsibilities in regard to states and territories.
I didn't ask that. I asked you if it was aligned to any international model. I mean, did you consult with any overseas officials representing foreign CDCs in the development of this particular model?
Senator Ruston, if I can add to Ms Wood's comments. Helen Grinberg's First Assistant Secretary, Centre of Disease Control Oversight Division. So as we were designing the model for an Australian CDC, and as Ms Wood has indicated, the model and the design is very much in the Australian context. We did look at a range of different public health institutes globally, so the European Centre for Disease Control, which is primarily an advisory mechanism.
So can I just ask you, just to be really clear, you said you looked at, did you consult with officials from these agencies?
Yes, we did.
Okay, so that was my question, is whether you consulted with them. And so in the process of consulting them, you have not based your CDC or the proposed CDC on any particular model that you've seen somewhere else in the world that you believe was working well?
Not explicitly, because it had to be framed in the Australian context.
Okay, so there's Okay, fine. Okay, so just back to the roles and responsibilities, and particularly in relation to the transfer of the roles and responsibilities to the department. In your explanatory memorandum, it says the role of the Commonwealth Chief Medical Officer in the department regarding health protection will change following the commencement of the Australian CDC and the establishment of the Director General. As a result, the role of the Director of Human Biosecurity will be transferred from the Commonwealth Chief Medical Officer to the department's secretary. So I'm just really clear to understand from all of you who within the health system is the ultimate decision maker in a pandemic. Is it you, Mr. Comley, in your role as secretary? Is it you, Professor Kidd, or is it the new Director General of the CDC? Where does the ultimate buck stop?
I'll ask Ms Wood or Ms Grinbergs to comment further. I mean, I think the point about ultimate decision maker is I think the ultimate decision maker for most of the key decisions will be Cabinet for most of the key decisions on advice.
Yeah, I ask you within the health system.
Well...
So who ultimately is the one who signs their name on the recommendation, as you say, ultimately, you know, the government can decide what it wishes to do or not do. Who is the health professional who signs off on the health advice? Because, well, I mean, in your instance, you cannot assign the power, your power, to someone else for the human health response zone, as an example. So is it you, Mr. Comley?
So if we're talking at the official level and we're excluding the items that Ms Wood already indicated were reserved for the DG of the CDC, it would be the Secretary of the Department would be the most senior official making a recommendation on a biosecurity or health matter in a pandemic.
So just on that, I mean, I'm trying to understand.
Unless you would correct me. But
Yeah.
No, that's right. So there are no changes to the power or the decision maker. There's simply a transfer of two existing powers to the Director General and a transfer of the balance of those powers that currently reside with the Director of Human Biosecurity to the Secretary.
You're making it sound very much like this is actually nothing to see here, but I mean it quite clearly states in your EM that all the powers that are currently vested in Professor Kidd are now moved to you. There are some of those powers that now move to you that you aren't able to delegate, including some quite significant powers in the time of a pandemic under the Biosecurity Act. And I'm just interested to understand what the decision-making process was to suggest that you, and I mean with the greatest amount of respect, from your CV you don't look like you're a health official or with any, you know, health experience, also medical experience, whereas Professor Kidd obviously does. We've transferred his responsibility to you, and yet you are not the medical expert. So I just am interested, that is clearly the case, that all of your powers as they currently exist, according to your explanatory memorandum, have gone from you to you. So what's left in terms of responsibility for the Chief Medical Officer when it comes to a pandemic?
So there's a significant responsibility for the Chief Medical Officer because obviously someone, whoever might be in my position, does not make a decision of those type without advice. In the same way that across any large department there are pockets of expertise that are not held by an individual secretary, and so you have to receive advice. I mean, in fact, the example we provided, we were talking about before in terms of communications, people are providing certifications on legal matters, they're providing certifications from a comms perspective. In a current program they have, which I am from time to time a decision maker, which is the Medical Treatment Overseas program. The Secretary is the decision maker. The Secretary takes advice, including from the Chief Medical Officer, on the clinical matters. But some decisions are not purely clinical decisions or purely medical decisions, and that's the role of integrating that within the Secretary of the Department.
So what's the problem you're trying to solve by taking the powers away from the CMO?
Well, whether I describe it as a problem, I think I made reference to earlier that the COVID-19 inquiry, the one headed by Robin Cruck, made a number of recommendations and observations which went to the question of how genuine whole-of-government decision-making was made in a pandemic, and made it clear that certain decisions are not purely clinical decisions and needed to be located within a body or a person that took into account a broader range of considerations. That is essentially what is trying to be addressed in this matter. That's why the powers that have been will be moved to the DG of the CDC are what I might describe as the more narrow and technical questions. And then the questions that come to a broader decision-making on behalf of the balance of considerations across society sit with the Secretary. Obviously, in practice, the closer a decision looks like it is a straight clinical decision or relying on medical advice, then the advice of the CMO would be more and more, not whether it's definitive technically, persuasive in terms of determining the outcomes, but where you move to a point where you're making a significant decision that has broader conversations or a significant recommendation to a minister or cabinet, the idea is to integrate that within the Secretary of the Department, which, as Professor Kidd said, is the model that currently exists on the agricultural side of government, where you could have a Secretary of Agriculture who is not a technical expert but takes technical advice to form judgments about animal health and security.
So clearly, this whole act makes you the chief pooh-bah when it comes to the ultimate decision, so that basically saying the buck stops with you. I'm interested to follow up on the FOI, and once again in relation to your memorandum of understanding, and in there it says that there is certain information that must not be published. We're not talking about that you don't have to publish or you've got means to claim why you wouldn't publish. You must not publish, and you refer to the exemptions of things that cannot be published under the Freedom of Information Act as publications that will apply to matters affecting national security, matters that risk harming population groups, and the one I'd like to bring to your attention, and the integrity of other government processes. That sounds to me like a very, very big catch-all for anything that the government would not want to release. They will just say that it is the integrity of other government processes. Why is that necessary? Why wouldn't you rely on the existing processes that allow for Australia to have some level of confidence in transparency, although I know that we are seeking to change the Freedom of Information Act as we sit here at the moment to make it less transparent. But why would you need to have that as a must not publish provision in the FOI?
I'll pass this to Ms Wood or Mr Madden.
I might perhaps start and then pass to Mr Madden to add to. One of the design principles of the CDC, part of the rationale or the benefits, if you like, that will accrue if the CDC was to be created, is new publication and transparency requirements that are explicitly designed and reflect the legislation to increase the understanding of the community about the basis of public health advice. One of the observations of the COVID reviewers made...
With the greatest amount of respect, I was asking you why you needed to have a catch-all provision. I'm not asking you to explain all the reasons around the FOI. There is a specific requirement in here that says you must not publish and then everything in the internet. And the final is integrity of other government processes. I'm keen to understand why you felt the need to have a catch-all of that size change in this Act.
Thank you very much, Senator. Jacob Madden, Assistant Secretary of CDC Oversight Division. Within the legislation, as Ms Wood was stepping through, there's requirements for the CDC to publish its public health advice. There are then exemptions and things which are considered exempt material, and that's defined in the legislation. The exemptions mirror exemptions that already exist under the Freedom of Information Act. So we specifically refer to the sections of the FOI Act that would ordinarily offer protection from the release of information under FOI requests.
Why don't you just use the Freedom of Information Act?
So what we do in addition to Freedom of Information Act, so the Freedom of Information Act, which the CDC would be subject to FOI requests as an Australian government agency, FOI Act still applies. In addition to that, we are introducing a duty for the Director-General to publish all advice that it provides to governments. That include a recommendation, and that is provided in writing.
Yeah, I'm not asking about what you are publishing. I'm asking you what you are explicitly saying in your Act you are not publishing. I mean, look, I'm happy for you to have a think about this because the bill will come to the Senate and you can have much more fun with me there. Well, the Minister will when we go through it. But I'm just keen to get some more clarity because if you read your explanatory memorandum, it sounds like you've done that. You've just given every piece of responsibility to the Secretary and you've just taken a whole chunk and said we're not going to publish anything or we're not going to provide information because
so
Freedom of Information Act changes.
Creates a positive duty to publish. So anything that they provide must be published unless it meets the threshold of being considered exempt material.
Yeah, and then
the exempt material includes those specific references to things which would otherwise be exempt under the FOI Act as
which
well.
is a catch-all for any government process. So, okay, look, we will prosecute this further, but you probably see here I'm very concerned about where the transference of powers and who gets what in terms of this, and I'm also very concerned about the lack of transparency that appears to be apparent by the EM. So on notice for when you come to the Senate, those questions will be asked. Could I now go to the National Health Reform Agreement? Thanks. So I'm keen to understand, is the government still committed to the agreement that was struck at the National Cabinet in December 2023, where the government committed to the Commonwealth increasing National Health Reform Agreement contribution to 45% over a maximum of 10-year glide path and by from 1 July 2025 with an achievement of 42.5% before 2030? Minister?
Thank you, Senator Ruston. Well, that's correct. We did agree to that in December 2023, and we certainly are continuing the work with states and territories. In terms of the recent gathering of ministers in September with the Health Minister, and we do want to maintain this current situation, but also improve in terms of the total Commonwealth contribution to state-run public hospitals.
Can I just add something there?
Yeah, could I just finish with the Minister and then, of course, you can, Mr Comley. I'm just keen to understand, there was a commitment in the communique following the meeting in December 2023 where, and I read it out verbatim, what the commitment was. So I'm just seeking to understand whether the government's commitment to provide an achievement of 42.5% by 2030 remains the government's commitment.
I certainly have that the National Cabinet agreed in December 2023 that 42.5%, 45% was subject to a cap on Commonwealth contributions.
That is the very important point, Senator. I know that some parties to these negotiations represent at times that there was an unconditional commitment to 42.5 and 45%, but it was always subject to annual funding caps. Okay. And that if those annual funding caps were met, then it was possible that the 42.5 or the 45% would not be delivered, but the total funding caps that were committed by the Commonwealth would be delivered. So from the Commonwealth's perspective, there has been no backing away from the substance of the agreement that was entered into by National Cabinet in December 2023.
Okay, so in December 2023, the second paragraph, or the next paragraph after that said, National Cabinet endorsed the current 6.5% funding cap being replaced by a more generous approach that applies a cumulative cap over the period to 25 to 2030. And includes a first-year catch-up growth premium. So what was that more generous approach? So clearly they've moved away from the 6.5% to a more generous approach. And also in the agreement it doesn't say conditional on it, by the way. And which is what you've just said, that is not reflected in the communique that I have before me.
Definitely, the agreement at the time was that the caps and without being deliberate about it, the language cap what is indicated as a cap on the Commonwealth contribution, and the agreement that was struck in December 2023 was that the first year catch-up would be 13%, and then subsequent years would be a cap of 8% growth per year as the cap. So moving from a pre-NatCab agreement of 6.5% cap to 13% in the first year and 8% each subsequent year. And obviously the implication of that...
So where's that now? Because, I mean, your communique from 23 does not say...
So not all things, Senator, that are included in Commonwealth state agreements necessarily are in the communique, but they can be in other forms of documentation between states and territories. But the agreement was at the time to be subject to the cap of the Commonwealth contribution caps of 13% and 8% in each subsequent year.
So can I just clarify what you said at the start of your contribution here? Have you just said that the federal government may not reach 42.5% by 2030? And in fact, you're making it sound like they won't reach 42.5% by 2030. Are you telling me that the commitment that in this communique is not going to be able to be achieved?
No, I'm not saying that, Senator. What I'm saying is that the actual, what's known as the Commonwealth contribution rate, will depend on what happens over the next 5.5 years. So if, for example, there was hospital expenditure growth in 1 year of 20%...
I totally understand.
Well, I think it's very important.
But I'm just keen to understand...
Can we just let the official answer the rest of the questions,
there was
Senator
a public
Ruston,
commitment...
I think this is an important point.
Yeah, sure. There was a public commitment of 42.5% by 2030. It was not conditional when it was announced in the press releases that I've got here. It was basically a big fanfare, 42.5% by 2030, 45% by 2035. And in that public promise, there was no mention of, apart from that they were going to be more generous around the 6.5% cap. That was the only thing that's mentioned in any of the media that I have seen. Will the government or won't the government commit to 40.25% by 2030 or not?
Senator, there's a couple of points here. The first is that the Commonwealth has recommenced negotiations with the states on this. So the states haven't agreed to any final agreement. So that negotiation is still ongoing. Whilst it's been... the intention is to conclude that negotiation by December this year. Negotiation hasn't continued. States and territories and the Commonwealth are still negotiating parts of that agreement. The Commonwealth's intention is still to meet and to be able to be in a position that the CCR can be increased. The extent of increase depends on the growth in hospital and hospital price and volume growth, and the Commonwealth has always, and the agreement at NatCab in 2023 was that it would be subject to a cap from the Commonwealth.
So, Minister, is the government walking away from its 42.5% commitment for its federal contribution to hospital funding?
Before we get an answer to that, I just want to signal that's your last question. I do need to share the call.
Senator Ruston, I do believe that the Secretary has answered your question.
No, I'm not asking the Secretary, I'm asking you. The government, I mean, the Secretary can speak on behalf of the department, only you can speak on behalf of the government.
Well, I've given you my response in terms of Minister Butler's dedication to working with the states and territories in terms of reaching an agreement, and I will certainly continue to say that.
So I'm just to put it really clear.
Is
the government still committed?
Thank you, Senator Ruston. I'm going to share the call across to Senator Pocock. Thank you.
Your time is out. I'm keen to pick up on these questions that Senator Ruston was asking. And I'm not sure if any of you caught the interview with the ACT Health Minister on RN Breakfast on Monday, but I have some questions relating to that interview and the ACT. Minister Stephen Smith said in her interview that as it stands, with the funding put on the table by the Commonwealth so far, the ACT won't be reaching 42.5% by 2030, as agreed by the National Cabinet. And I've also gone back and looked at the communique and have some questions based on that. what is the current Commonwealth contribution rate towards ACT's hospitals?
I'll just ask someone to
Thank you.
have a look at that. But I would just reiterate my point that we're currently in negotiations with the states and territories, and for any level of funding cap, the Commonwealth contribution depends on growth rates, and obviously
I've got some questions about that.
Every party to the negotiation will have their own view or their own interest in putting forward what they think the growth rates are.
Sure.
The higher you put those growth rates forward, the lower the CCR would be.
Sure. As a senator for the ACT, I'm sure you'll know that I have a certain view on this. Go for it.
We actually don't have the CCR by state in front of us here. Is there a particular year you're interested in? We can.
The last year you've got available. Last year.
Yeah, last year that's available. We will, if we can take that on notice, we can get that back to you.
No one in this. There's 40 people in this room. No one has that figure. You had to have known that this would come up.
So we've got in terms of the funding that's in 25-26, and we've got those figures in front of us. We don't have the contribution rate in front of us.
So what's 25-26?
In terms of the actual funding?
Well, 25-26, again, would only be a projection since that hasn't occurred. So I think we should actually get you the latest available CCR based on actual data.
Okay, I'm very surprised that no one in this room has that figure.
We will get that figure.
Is that a concern for you, Secretary?
It's not a concern. I'm not concerned that people... Sorry, Senator, I'm not concerned that people... we don't have the number. We've been discussing that number with states and territories. I must admit I'm looking at my briefing notes and I don't have that number with me, but we're happy to provide that as soon as possible. That won't be hard to get.
How long are we talking? Sorry, I've got 15 minutes here.
Well, I think the team that's watching
as in today, or sort of on notice? What are you?
Today.
Today?
Yeah.
Okay.
I think that the practice has been since this morning, Senator Pocock, that we would attempt to get them by the end of the outcome area, if not later on today. And I think that was the commitment by the Secretary from memory. So if we could work on that, that would be appreciated.
And just to clear, from what I'm hearing, and I share the concerns, Senator Ruston, reading the communique, there are no sort of conditions placed on that 42.5%, but it doesn't sound like the government is that committed to actually getting to it. It sounds like there's a whole range of things that would have to go right. And what I'm hearing from Minister Stephen Smith and other territory health ministers, state health ministers, is that they are deeply concerned that this is just sort of an ambition with no intention to get there. Maybe, Minister, is this...
Well,
what's going on here?
That's a fair reflection. The issue, the capping of the total Commonwealth contribution was always part of the agreement in December 2023, and that's essentially because in both hospitals and in disability, the negotiations happen around what I might call the central estimate at the time as to how much is going to be required, and then also what are the risk management mechanisms that have to be put in place to recognise that things could change. The Commonwealth said at the time, and it is still the case, the Commonwealth was prepared to put a significant increase in funding for hospitals compared with what had happened in the past, but it wouldn't be uncapped. So the current estimate, which has been put in the public domain, is the offer the Commonwealth's put before the states and territories, is a $19.9 billion increase in hospital funding over 5 years compared with what is in the would have been the case if you had provided hospital funding increase of 6.5% every year over the next 5 years. It's a significant uplift. To achieve the 42.5 would require not having very high growth in hospital expenditure over the next 5 years.
Which would...
19.9 is based on 6.5. You just said that that was a growth cap of 8, 13 in year 1 and then 8. What would be the uplift if you applied that as it relates to the 19.9?
Senator, so what I'm saying is the 19.9% billion is the additional money on top as if you had a 6.5% growth rate. So effectively...
So how did that
Can I just, sorry, Senator Ruston, maybe if you don't have the call, Senator Pocock does, if you're happy to share the call with the coalition. I'm not going to do the tic-tac thing in the middle of a call. So if you're happy to follow up a question later on, I'm happy to give you the call to do a follow-up question, but I'm not going to do that in the middle of a call. So Senator Pocock, you have the call.
Thanks, Chair.
It's not an opportunity for an intervention.
Can I ask about the national efficient price? Ms Stephen-Smith has said that small jurisdictions like the ACT cannot deliver services at the national efficient price. And she says, and I'll quote, "With a different type of public hospital structure to the larger jurisdictions and a lack of economies of scale, it's not possible for us to deliver hospital services at the national efficient price. There should be a premium or a multiplier for small states that reflects the fact that they cannot deliver at a national efficient price." And she released data showing that it costs the ACT $1,999 more per patient than the national efficient price. Has the department received or seen this data or analysis from the ACT government showing that it can't deliver services at the national efficient price?
I might just ask the others at the table to comment on whether we received that data. We've certainly been in conversation with not just the ACT but other small states about whether they can meet the national efficient price.
Thanks.
As you... so I don't want to take up too much time, but I just think it is important to comment that there is not really one national efficient price. There are a range of loadings that already exist within the system to allow for circumstances. The argument being put by some jurisdiction is that the adjustments are not sufficient for their jurisdictions. The tension here is the reason the national efficient price was put in the first place was to try and drive efficiencies across the system, and it's very hard. The last point I was going to make before going to the team. The tricky thing is here, it's very hard for the Commonwealth, which is a co-funder of hospitals, to control and influence a range of those things, and so the point of the national efficient price is to try and drive those incentives at the state and territory levels. We are in the middle of negotiations, and every state and territory, not just the ACT or the small states, make claims continually that the national efficient price doesn't accommodate for their needs. We just have to bear that in mind with the need to drive that efficiency across the system. But I'll just ask whether we've seen that particular data, because I know there have been periods at the time we've asked for data but haven't received it from a number of jurisdictions.
Well, I'm asking you guys for data and not receiving it, so please continue.
So, Senator, I can confirm that we have received recent data from the ACT in relation to these matters, but I think what's useful is some work that's being undertaken in terms of reviewing not the NEP, but how the small state components fit in.
Yes, Senator Fafine Carl, Assistant First Assistant Secretary, Public Hospitals and Health Reform Division. There's been a piece of work across all jurisdictions to work with the Independent Health and Aged Care Pricing Authority to look at how the current processes for determining the national efficient price weight for particular circumstances. So that includes weightings of different kinds of patients and different locations. So the specifics concern that's been raised, and that IHACPA and jurisdictions are working together to do a review on, are the weightings for First Nations patients, the weightings for rurality, so location, and also for smaller jurisdictions. So that is a process that's currently underway. All jurisdictions are participating in that, including the ACT, who's heavily involved in co-chairing the cross-jurisdictional group of officials who are oversighting that.
And when will that be completed? Thank you.
I think at this point our expectation is that it will be completed in 2026.
2026. Is there a first quarter, second quarter, any sort of time frame?
We can confirm that for you, Senator.
And will the Commonwealth be taking this into account in negotiations? If you do find that there is legitimate reasons that smaller jurisdictions can't deliver those services for the same price. Will that factor into negotiations?
Senator, I think it is genuinely difficult when we're in a live negotiation with the states and territories to be discussing which of the items we're open to negotiating, not negotiating, what's our red line, what we can't do. I think that is a genuinely difficult position to be in.
So Secretary, you're saying that if your review finds that it's more expensive for, say, the ACT and Tasmania to provide healthcare to Australians, you can't even tell us if that will actually be factored into a landmark hospital agreement?
What we can say is it will be part of the NEP. So if it changes the methodology for the national efficient price, that would form not part of the negotiations per se, but it would impact on the underlying elements that feed into those estimates.
And
question, Senator Pocock.
Okay. And Secretary, you said that you can't say whether it will factor into negotiations, but did you not say earlier that you want the hospital agreements to be done by the end of this year, and this work will be done next year? So,
Senator, again, we're in the middle of a negotiation. I mean, it's not unusual for negotiations to not conclude every matter, but also to leave processes open at the end of the negotiation because there's an ongoing process between Commonwealth and state. So I think the idea that you, in a Commonwealth state negotiation of this size, get to the end and you've wrapped everything up with a bow, I don't think is often reality.
Thank you. And so just to clarify on notice today, please could you provide the contribution rate for each state and territory for the last 3 years?
For the last 3 years? Yes.
Thank you very much.
Thank you. Senator Antic.
These are probably questions for the TGA again, I think. Sorry, Deb. Thanks, Professor. Thanks. Yeah, I want to ask a couple of questions. I think some of these might have been covered before, but just I don't think all. Questions about adjuvants, thimerosal, which is mercury and aluminium, in the childhood schedule or in products that are on the childhood schedule. How many products on the childhood schedule currently contain thimerosal, the mercury adjuvant?
So thanks for that, Senator. So we might need to take that specific number on notice.
Yep.
I do recognise as well that there has been a strong international conversation around the presence of thimerosal or thimerosal, it's called a couple of things, as a mercury-bearing adjuvant, and that there has been a conversation around whether it is linked to adverse events. Again, there is not a strong international belief among regulators or indeed among the TGA that it is linked to adverse events of the nature that have been described.
My understanding is it's been largely removed. I mean, there may be one or two perhaps which you can take on notice, of course, but largely it has been removed, I think, from most of the schedule. And the reasons for that?
Well, my understanding is that there is. I mean, again, if this is incorrect, I'm very happy to correct the record. But there is actually no thimerosal in childhood vaccines under the schedule that we use in Australia, and indeed the move that has recently been taken in the US is actually is not removing it from childhood vaccines because again it's not present. It's removing it as a preservative in multi-dose vaccines in the influenza vaccine.
But it has been. Is there a reason for its being removed? Is what I'm asking.
Well, my understanding is that it was removed some 25 years ago. So I'm not sure that we would necessarily have that.
Right. Okay. All right. Well, perhaps you can take that on notice as well. Absolutely. Aluminium as an adjuvant in the vaccine schedule, though, how many of the current schedule vaccines have aluminium in the as an adjuvant? If I've said that right.
Yeah. No, you have indeed said that. Thank you. Again, there are some vaccines that contain aluminium compounds, which can include aluminium hydroxide and aluminium phosphate. They are included as an adjuvant to bolster the immune response to the vaccine. Once administered, those adjuvants do dissolve slowly from the site of injection into circulation, then eliminated through renal or urinary excretion. The exact number of vaccines and the nature of aluminium-containing vaccines, again, is something that we would probably have to take on notice if you are seeking that specific detail.
Thank you.
We've answered a number of questions previously, but if we have answered that, I'll reference the question.
Thank you. Can you then point me to any true placebo-controlled studies on the use of aluminium in the vaccines to newborns?
I'm not sure that I'm in a position to do that. Again, these are I think. Actually, it's not my call to say whether they're fair questions or not, but these are questions that we can respond to probably in more detail in writing, if that's right.
And also, the hepatitis B injections given to newborns on the day of birth, I think, and again in coming months, alongside the multiple antigen vaccines. Is there someone here who can tell me the rationale for newborn babies having a vaccine for a disease which is largely in the domain of intravenous drug users and prostitutes?
Okay, so you've thrown. I'll throw to Professor Kidd perhaps to provide something after I do comment. I think it's and obviously again there has been a significant amount of focus. I don't necessarily. Take as a given that this is the province of intravenous drug users and prostitutes. I think that that's not reflecting the public health initiative and the benefit that we've seen.
What are the rates of Hep B in the population then?
Say again, sorry, Senator.
What are the rates of Hep B in the population that so urgently require newborns to be injected with
Well, I'm not necessarily in a position to provide that, but what I would say is that there are...
Sorry. I think Professor Kidd is indicating he might be able to help us here.
Just briefly, Senator, people who are infected with hepatitis B, of chronic hepatitis B, can transmit the disease, and so that is a risk of transmission from the mother.
So what are the rates of Hep B in the community then? Now, given that we give this to every newborn baby, what are the rates of Hep B in the community then?
I'll have to take that on notice.
Well, much luck today.
Yeah, I would highlight, Senator, if I may, that there has been a profound and clear decrease in the identification of the disease sequelae of hepatitis B, and these include lifelong and debilitating conditions such as cirrhosis and hepatocellular cancer, and they are clearly related to the introduction and the maintenance of neonatal immunisation for hepatitis B. This has been, again, a matter for discussion internationally, and it's recognised that it's been a significant public health intervention to decrease the significant morbidity and mortality associated with those conditions.
So I'm not disputing the fact that nobody wants a dose of hepatitis B, but the question is why in every single incident we're giving that when we seemingly don't do placebo-controlled studies on the effects of it and the aluminium inside it, we're giving them to every newborn baby. I mean, the rates must be something in the order of 0.5% of the population. Something, whatever it is, whether it's 2, whether it's 1. The rationale for giving every baby that at birth is I would love to know the answer to that.
Senator, we do have Professor Katie Flanagan on the line, who's the chair of ATAGI, who could maybe speak to some of the considerations taken by ATAGI when they put forward a recommendation for a vaccine to be listed on the NIP.
Thank you.
Yes. I should go on camera, sorry.
Sorry.
Yes, thank you. I've been listening with great interest to this discussion. My understanding and the last figures I've seen, about 0.8% of the population have chronic hepatitis B, which is actually quite a lot. And it certainly isn't just there's a whole series of different people, particularly some of the culturally and linguistically diverse populations, and among many other populations, and in fact quite high in Aboriginal and Torres Strait Islanders. And every year there's many thousand notifications of new hepatitis B infections in Australia. So it is still a significant concern. Now, giving the vaccine to a newborn baby, it's the perfect time to capture a baby and start protecting. It will protect against congenital transmission if the mother is infected and it wasn't known to be. And in fact, about 1/3 of people in Australia who have chronic hepatitis B don't actually know they've got it. And what we know is this is a vaccine that protects cirrhosis, the carcinoma later in life. So its effects are many years later, but capturing babies at that point starts to give them that immunity straight away, and you still need multiple injections to actually get the protection. So we know that this is an incredibly safe vaccine, and it's given to more than 90% of babies in the entire world. Receive this vaccine at birth, and the safety record on it is really quite impressive. It has been in policies globally for many, many years. So that, I think, would be my response.
So you say that the safety is fantastic, except that we don't do blind placebo trials on it. The efficacy and safety really aren't fully established at approval. If they're not, then making a robust placebo-controlled trial, not its own mission, to me would seem like a more ethical position. And I mean, by the way, I say what 0.6% of Australians have Hep B, but we're giving it to 90% of the kids. That's really strange to me.
Well, because it can be transmitted to people, and you can get it if somebody in your family has got it, so the children can acquire it.
Yeah, but nobody's
in
got
that context, well, 0.8% of the population is still a reasonable number of people, I would say.
Yeah,
I mean, we go back to the point of placebo-controlled trials, which I think has already been addressed several times now today, that you can't always do placebo-controlled trials. Now, I would have to look back and see when hepatitis B vaccine was first introduced, what the placebo-controlled trials were, but there would have been, before there was a hepatitis B vaccine, there's certainly going to be a lot of evidence in terms of the impact of when the vaccine itself was then introduced, and how that would then reduce hepatitis B rates and also rates of hepatocellular carcinoma and cirrhosis. And in fact, there are a number of studies globally that have been done looking at the impact of introducing the vaccine. So different countries introduce it at different times. So there are definitely a whole plethora of data out there, and there will be many studies looking at safety of these vaccines as well. And we know that these vaccines are efficacious. We know that most people do mount an immune response, and we know that that protects against acquiring hepatitis B, and then protects against, obviously, people having hepatocellular carcinoma, which is still a big problem in many parts of the world where hepatitis B vaccination isn't achieved.
Senator Antic, can I just check how much time?
Oh, look, this will probably be the last question, if that's okay. So on the subject of the placebo-controlled studies, is it the case that we don't do, even if a new vaccine is introduced, they are not done on that new vaccine? I mean, for example, Infantrix was introduced in 2006. Now, I understand that in the years gone by, the Reagan administration introduced legislation in the United States which gave immunity to the companies that produce these drugs as a result of whatever. And so it seems that the process of not doing these full placebo trials stem from that. But the current introduction of a current drug would surely leave the door open for doing them now. Why aren't they done now? Why aren't they demanded to be done now?
Well, I'll start to answer that, and I'm sure Professor Lawler can also take this up. But yes, they are still done in the early phases of actually testing many, many vaccines. So many of the phase 1, phase 2, phase 3 trials will have a placebo arm. Although I have to say that quite often it's a different vaccine that's used as the placebo arm that then doesn't cause any effects on the disease that you're trying to test against. So I've been involved in malaria vaccine trials, and we would often give another vaccine because we're trying to actually make it fair for people to be taking part in vaccine trials, and just giving them a placebo when you're trying to vaccinate lots of children isn't always as ethically well received. And so they are done. And as Professor Lawler said, we will try and get the evidence around placebo-controlled trials and which ones they have been done for. But definitely, of course, over the years, the regulations and the rules have changed, and maybe many, many years ago for some of the earlier vaccines, they were not done. But safety and efficacy trials are always done, and they're always... You wouldn't introduce a vaccine in Australia unless it was shown to be safe and efficacious and the benefits outweigh the risks. And when Targi is considering any vaccine, we have very robust and long discussions going through all the literature that we can find about safety and efficacy of vaccines. And we're always keeping a watching brief on all vaccines that are coming through. and any new emergent data to suggest that a vaccine might not be safe, or that there might be a safety signal that needs to lead to changes in our recommendations.
And if I might just simply add to Professor Flanagan's response there. In the right setting with the appropriate ethical underpinnings, it is absolutely the case that we should be pursuing the highest level of science, which in that instance includes a placebo-controlled trial. But it is important to note that they are not the only sources of evidence that we use. There is the comparison with the current accepted level of treatment, but also the process that we undertake, and particularly for therapeutic goods that have been in use for many years and those that have been on the register for many years, includes, as Professor Flanagan highlights, the appropriate use of post-market monitoring, pharmacovigilance, the identification of safety signals through being raised by those who use it or those to whom it's been administered, from other regulators and from health professionals, but also the accumulation of decades of real-world evidence that can be used to point not only to effectiveness but also to safety and quality. And it's on that basis that we're comfortable that the risk-benefit analysis that for the vaccines that we approve and that are included by ATAGI in their recommendations for the immunisation schedule remain appropriate for that use.
We're still comfortable with the COVID shots being safe and effective?
Thank you, Senator Antic. I do need to share the call now to Senator Steele-John. Thank you.
Very much, Chair. Professor Lawler, before I get to my main line of questioning, I just wanted to give you the opportunity to clarify that during your last exchange with Senator Antic, when you quoted the Senator's phrasing of hepatitis being something associated with, quote, drug users and prostitutes, you were not in fact endorsing the use of such a derogatory term to refer to sex workers.
In absolutely no way, Senator. Thank you for raising
Thank you. I just wanted to make sure the record was clear on that. Okay, so I'll go now to the question of the TGA's regulatory response to what is rapidly becoming a bit of a national public health scandal in relation to sunscreen. I refer, of course, to the Choice report issued in June of this year, where it was revealed that some 16 of 20 sunscreens surveyed and tested by this consumer group did not, in fact, meet the SPF standards as advertised. We have seen announcements of significant recalls of sunscreen products and the voluntary decision of a lot of some of these manufacturers to withdraw them from the shelves. There's a lot of concern in the community given we are now in spring, heading towards summer, and we know that skin cancer is one of the most prevalent cancers in Australia, and that of the 5 lines of defence against skin cancer, sunscreen is one of them. Now, I understand that the TGA doesn't currently conduct its own testing in relation to every listed sunscreen and instead relies on data from or provided by sponsors. Is that correct?
Please. Thank you, Senator. Avinash Clark, Assistant Secretary, Medicines Regulation Division, Complementary and Over-the-Counter Medicine Branch. Sunscreens are regulated within a risk-based framework in the TGA, and so we apply a proportionate level of controls compared to the risk. So things like prescription medicine would go through a full pre-market screening before they're on. Sunscreens are regulated as listed medicines, and so they would go through to be listed. Those sunscreens would need to use ingredients from a pre-approved list. They would need to have indications or claims from a pre-approved list, and then sponsors would certify under law that they hold evidence to substantiate their SPF claims and that they meet the standards of safety, quality, and efficacy.
And how does the TGA go about verifying the accuracy of the data provided by sponsors?
So that would be through our post-market compliance action, and so our work on sunscreens has been ongoing, and so for example, prior to the choice report, which I will acknowledge we have prioritised, and we completely understand the public response and appreciate the public interest, and we have dedicated considerable resources to investigating. But prior to that, we would have ongoing compliance activity. For example, in the case of sunscreen, in 2018, we surveyed 20% of all sunscreens on the market, 175, and checked their SPF data, and all for one could substantiate those claims. And then we've tested sunscreens over the course of the last few years on a range of things like broad spectrum protection or the quality of preservatives against microorganisms. So that is ongoing. In relation to choice specifically, we are investigating those specific sunscreens named in the choice report as a priority. We've tried to be as transparent as possible given the public interest and providing regular updates. I would state in relation to sunscreen, and going back to your statement about how important it is in sun protection, and we acknowledge that sunscreen is very important in protecting Australians from the dangers of ultraviolet radiation, in conjunction with those measures you discussed, wearing a hat, protective clothing, sunglasses, and seeking shade. And within that context, we also appreciate that SPF levels and certain SPF levels can still provide high levels of protection. So an SPF 30, for example, would provide 97% protection from UV rays compared to an SPF 50, which would be 98%. Even an SPF 25 would provide 96% protection from UV radiation. So within that context, we've been taking a risk-based approach and focusing on those sunscreens that have been that may provide significantly less protection that is advertised. You may have seen on the 30th of September.
I did, yes.
Okay. Yeah.
Yes, I did. Thank you, Mr. Clark. I want to just go to the next part of the question, which is a part of that response to Choice's recommendation. Now, one of the recommendations was that the TGA conduct its own testing, and you've said in as part of your response more broadly that you're taking into consideration options that don't include human testing, also known as in vitro testing methods. Now, noting that the TGA sunscreen regulatory role is one that has previously been quite highly trusted by the Australian community, I would argue. The more that we can do in this space to ensure that your capability to provide that assurance and that quality testing, the better. What are the barriers that you see currently sitting between the TGA and actually conducting that in vitro testing?
I'll pass it over to my colleague, Dr. Kerr, but before you go, I just acknowledge that the things you're asking are things we're thinking about, and we are very much using this as an opportunity to see where we can strengthen our regulatory system.
Yep.
And I'll pass to Dr. Kerr.
Thank you for the question, Senator. Lisa Kerr, Assistant Secretary, Medical Devices and Product Quality Division, specifically the Laboratories Branch. Your question was about the barriers for implementing testing. Until December last year, the only internationally recognised test to come up with the SPF value used humans, so that's the in vivo test, ISO 24444. Yes. The TGA does not have the facilities to test on humans, and we don't test on animals, so that's a significant barrier for us. However, in December last year, ISO, the independent body that drafts international standards, published an in vitro standard, which we are capable of implementing, and we are taking steps to implement that standard.
And when will that standard be implemented?
I am hoping in the next few months.
In the next few months?
Yes.
Can I also highlight something, if I might, Senator? And this is clearly an issue that has been a very strong focus for the TGA, as I know it has been for the country. It is actually a particularly strong example of the role of a risk-based regulator. We recognise the challenges in this space. It's also worth pointing out that sunscreens are regulated in a different way in Australia to the way they are regulated in the rest of the world. In many countries, they are regulated as a cosmetic, but we recognise, as you've highlighted, the prevalence and the impact of melanoma and other cancers means that it is an essential therapeutic good in Australia. We need to be both proportionate and balanced in the way we approach it, and they are two different things. The proportionality of the tightness of our regulation needs to be relative to the effectiveness and the quality of the product and the risks they present, but we need to balance both pre-market and post-market. We could be very tight with our regulation, which would mean that no products are authorised, but what we've taken is a risk-based approach, not only in authorising these products, but as Mr Clark and Dr Kerr have highlighted, in monitoring and ensuring their safety and quality.
Yes. Professor Lawler, I 100% agree with you. In Australia, sunscreen is an essential therapeutic good, and it is right that the public expect it's regulated in that way. Is it correct that SPF makeup and SPF foundation and some SPF moisturisers are not in fact regulated by the TGA in the way that other sunscreen products are?
Yes, so there is a differentiation between primary and secondary sunscreen. So primary sunscreen is that which primary purpose is to protect a user from UV radiation, and those are registered. Those need to be registered on the Australian Register of Therapeutic Goods before they can be sold. Also moisturisers that do make claims over SPF 15 need to be registered on the ARTG. However, there are exclusions for what we'd consider to be cosmetic sunscreens. Those could include tinted foundations that have higher SPF ratings, as well as moisturisers that claim an SPF of under 15.
Yes, so to be clear, and looking at your website, which seems to list the excluded sunscreens, such as tinted-based foundations, liquids, paste or powders with an SPF of 4 or more, they're not regulated by the TGA,
yeah,
correct?
They're still so those would still be regulated on the Australian Industrial Chemical Introduction Scheme.
But not by the TGA?
No, they wouldn't be regulated by the TGA.
And the Australian Industrial Regulatory Framework, does that undertake testing as to the accuracy of the SPF claims?
I'm not sure that we can necessarily best answer that. That's probably a question that's best put to the Australian Industrial Chemical Introduction Scheme. We can provide that, though.
Okay, well, because it doesn't appear that it does, from what I can see of their framework.
But again, I would just highlight, what, as Mr Clark has said, that predominantly it goes to the primary intended use of the product and the SPF. So really, when it comes to it, if it's introduced as a cosmetic, there is a strong industrial chemical introduction regulatory approach. If it's a therapeutic good, if it has a certain SPF claim, if its primary use is a sunblock, or indeed if it makes therapeutic claims, we regulate it as a therapeutic good at the TGA.
Yeah. And basically the decider there is whether or not it's included on the excluded products goods list, isn't it?
Whether it features on that excluded.
Yeah, so it's not on that list, it's not in your purview to regulate, somebody else's.
No, if it's not on the excluded list.
Sorry, if it is on the excluded list.
If it is on the excluded list, that's right. And again, it's predominantly because of the claims that are made.
The claims that are made. Okay.
And its constitution and whether it's primarily intended as a sunblock.
Yep. My concern here, and this is both to yourself as a regulator and also to the government, is that many people use SPF makeups and foundations, and the very products that are listed here as things that the TGA does not regulate as sun care and prevention products. Because of the claims that they make, and I've got a number open on my laptop right now that make a very clear SPF 50 plus rating claim on the product branding, and yet putting aside the challenges that have been revealed with the TGA's regulatory process around sunscreen, at least you're doing something in the space and trying to do better. it is unclear to me whether these other regulatory bodies even believe it is within their obligation whatsoever to test for the accuracy of the SPF claim, as opposed to simply listing the ingredients within the substance. So given this, I want to go to the Minister and ask very directly. We are heading into summer. People are out in the sunshine right now. Most days in our country, the UV levels are such in a majority of the community that the Cancer Council recommends you wear UV protection. There are products here that are overwhelmingly marketed towards women, and it is unclear at best, if not definitively able to be determined, that there is no government regulatory function testing as to whether they are actually sun-safe, whether the claims that they are making to protect you are in fact accurate or in any way backed up. Are you considering amending the excluded goods list so that these substances, these products that are basically being marketed as sunscreen with foundation, if you look at the actual marketing, are regulated in the future by the TGA?
Before you answer, Minister, I'm just signalling to you, Senator Steele-John, that I will be shifting the call to share amongst other senators. So I'll wait for the answer of the Minister, but I will be shifting the call once her answer is delivered. Thank you.
Senator Steele-John, I have been listening intently actually with your conversation around this and the details in which the TGA has provided. We have focused very strongly in terms of cancer and the communication and working with the Cancer Council around many issues, not least of which is the treatment of it. So I'll certainly take your question on notice in regards to that specific point that you've raised. So thank you for that. Yep.
Senator Nambajibba Price, you have the call.
My questions relate to the proposed closure of the private maternity services in the Northern Territory and state and territory funding agreements.
Just to be clear, you talked about the private maternity and you also talked about the National Health Reform Agreement funding. So it was the two issues, the closure of maternity and private? Yep.
Thank you. I'm just wanting to understand whether the federal government in its funding agreements with states and territories is considering models that integrate or support private obstetric-led care, given evidence that public maternity care is associated with higher rates of stillbirth and maternity complications.
Sorry, can I get you to... Sorry, I was just chasing up someone.
I can probably... So just, Senator, I'm not sure if you're in the room. I did make a comment to Senator Pocock that as the Commonwealth state negotiations are currently afoot with a view that they go for the next 2 months, there are some things that it's a bit hard for us to discuss. But I think in this case I can say that private maternity services to date have not been rolled into a conversation about the broader National Health Reform Agreement negotiations between the Commonwealth and the states. We obviously do, as the Commonwealth, continue to have conversations with states and territories where there are specific services that will have had financial difficulties. In maternity, Darwin is one. And the other that has been recently an issue has been Hobart's maternity services, all related to Healthscope's access. So without sort of giving too much away, we haven't, the broader Commonwealth state negotiations to date hasn't rolled in private maternity services into that conversation.
To date?
Yeah. Well, I mean, sorry. The reason this is where I'm cautious, because we are still negotiating with states and territories. Mm-hmm. I can't rule out that any state and territory may wish to put another issue on the table at some point in time, which they wish to negotiate, whether they want to negotiate that as part of a kind of multilateral agreement or whether they wish to deal directly with the Commonwealth. I just can't rule out that someone wouldn't make those representations.
Okay. So I suppose with the Northern Territory recording the nation's highest rates of stillbirth, congenital syphilis, rheumatic heart disease and preterm birth, what is being done, I suppose, at a federal level to adapt maternity models to these particular complex needs?
So Celia Street, Acting Deputy Secretary, Strategy and First Nations Group. There's a number of elements to your question there. So I think what I would say in terms of the models of care, we do provide support for birthing on country. As you're aware, we have a number of different models that we support that go to First Nations more broadly. In terms of model of care, specifically, say in the NT, we haven't got a piece of specific work on that at this point in time.
Okay, I mean, I suppose with the proposed closure of the private maternity services, this will impact particularly across those areas. Has there been any consideration given to this impact going forward?
Yes, so we have been in conversations with the Northern Territory Government in terms of the impact of the closure of the Healthscope hospital, and unfortunately I don't have everyone here with me because that's under outcome to the private side of things, but we have been in conversations with the Northern Territory Government about supports that they may seek from government, but there hasn't been any outcomes from that at this stage.
Okay. So why did the government not intervene to sustain the private maternity services in Darwin when studies showed they were more cost effective and I suppose safer for patients?
So can I get you to repeat the question, because I don't think that we have something there in terms of the safety.
So, I mean, health is everybody's responsibility at a state, territory, federal level. I suppose I'm wanting to understand why the federal government has not intervened to sustain the private maternity services.
I think Helen would like to answer, and maybe Mr. Hawkins.
Senator, Professor Alice McMillan, Chief Nursing and Midwifery Officer. Senator, can I confirm, in referring to private maternity services providing particular outcomes, are you referring to the recent published study by Callender et al. that provided a perspective or a view that, in fact, private maternity did provide better outcomes than those of the public sector? Is that the basis of your questioning? Because it would be fair to say that there's been significant response in relation to that publication, and there is significant evidence that is contrary to that in relation to that study, and the belief that that study didn't appropriately adjust for a range of variables before it was published.
Well, no, I suppose my concerns are more to do with well, there was a report. There's a number of reports that I am referring to, which I can have emailed, but specifically we have, which is evidence, the highest rates of stillbirth, congenital syphilis, rheumatic heart disease and preterm birth, as well as the fact that this will now apply pressure to the system given the proposed closure of the private maternity services. And I suppose with that in mind, I'm trying to understand why the federal government hasn't intervened.
So I can perhaps, Ross?
Senator Ross Hawkins, First Assistant Secretary, House and Strategy Division. As Ms Street said, this typically comes up under outcome 2, so we've got our private hospital expert coming this afternoon, but I'll try and answer as much of your question as you can. So, very conscious that the facility they're referring to in Darwin is run by Healthscope. It's a private company, and it's their decision as to how and which and the services are provided within that private hospital. I haven't got the exact date here when they kind of spoke and told us that that was closing, but there's a level of engagement they had with the Northern Territory government, and then a level of conversation, I think it was kind of over a 3 or 4 month period, around what the transfer of those services back into the public would look like and what needs to be done between. And this includes elements of the workforce and the support mechanisms that would typically be in place as they close down their services, and that would be relocated into the public. And I think that's where kind of Ms Street was saying, and these are kind of further kind of conversations as part of kind of future hospital agreements around what the jurisdictions would want to do as part of that. But the closure of the private hospital was a decision for Healthscope that they made at that time.
So, well then, what then, if any, modelling has been conducted as to the knock-on effects of the closure, including paediatric services, litigation risks, and insurance costs, as clinicians have learned?
Senator, we'd probably need to take that on notice, largely because it would be an issue for the Northern Territory Government. So the Northern Territory Government provides the maternity services for the population up there, and they would have looked at what the impact of that would have been with the private work coming back in. So we can take on notice and engage with them on what that, if they've done any modelling, what that might look like.
I'd appreciate that. And how is the federal government addressing the fact that Northern Territory families are now being forced to travel interstate for their private maternity care, and often for a period of up to 12 weeks?
Yes, Senator, as I understand, and again, our expert is here this afternoon, I think there is still going to be a levels of private offering within the public hospital, and that's been an issue that the government have been discussing with health insurers. But again, we might be able to provide a bit more detail on that for you later on this evening.
Yeah, I would appreciate that. While it's claimed that numbers fell from 700 births a year to fewer than 300 in the private system, does the department accept that this oversimplifies the issue given the overwhelming complexity and national worst numbers for maternity outcomes, as I've previously mentioned, in the NT public system, that they have to negotiate?
Senator, there might be one for the kind of Chief Nursing Midwifery Officer to answer, because when you do get to certain levels of birth, and certainly we've seen this in the private system, we find that private operators feel that it's no longer safe to offer a service, largely to keep the necessary staff with the expertise on hand. So that's where we've seen some closures across the country of maternity services historically, because the number of private births has dropped off. But it is an important factor that leads to the kind of delivery or effective delivery of a safe and efficient service. I'm not sure if...
So, yes, Senator, there is obviously a point at which very low numbers of obstetricians in this situation, or paediatricians, you may not be able to sustain a service going forward. What I do understand that has been put in place is that the Northern Territory Government has put in an interim arrangement with a midwifery-led model of care to support local communities with their birthing, so that where possible it can be supported within the public system, and that can be done supported by the public health system in the Northern Territory. So there has been changes made so that the use of private midwives can be sustained in the interim, while further consideration to service provision is made by the Northern Territory Government.
Senator Price, I'm just checking how much more time you need. My understanding was that Senator Blythe was going to share some of the coalition block of questions. So did you...
Look, I've got some questions that I can put on notice. Sure. Yeah, that's fine. Chair, can I just conclude on Senator Price's questions?
Yes, happy for you to do that. Yep.
As well, just in regards to a follow-on in relation to the assistance to the Northern Territory, the Northern Territory Government is set to receive over $550 million in terms of extra support in the Northern Territory for hospitals. So that's about a 30% increase, which is the largest it's ever received in 10 years.
Yep. Is to receive that?
That's right, in 25-26. So that's set to receive it.
Thank you.
Thank you. Senator Black.
Thank you very much, Chair. Now, my questions are to the NHMRC, so we might need to play musical chairs again. Thank you. So, on April 3rd, 2025, the Adelaide Advertiser reported that there were 22 children treated between 2023 and 2024 who were approved for gender transitioning without psychiatric assessment. Were you notified of that formally by SA Health?
Alan Singh, National Health and Medical Research Council. No, Senator, but I might mention that our role in this matter is to produce guidelines, and so there is no obligation for states to inform us of that sort of information.
And just to clarify, there are currently no formal guidelines in terms of...
There are no NHMRC approved guidelines relating to gender dysphoria.
Okay, so if we've got gender clinics that are using standards of care and we've got instances where there have been children, and in this case the youngest was 11, who are being treated without any guidelines existing, do you accept that that is, and we're not expecting to see this review come up with anything until mid next year is my understanding, do you concede that that might be problematic in terms of the care of young people in Australia?
Senator, if I can just comment, we did this quite extensively earlier. There are no national guidelines, but the point that was made by Dr Devlin and others that there are other clinical guidelines from professional bodies and others. So I think maybe Dr Devlin might want to restate some of that evidence.
And I understand if there are no guidelines though, and we've got clinics that aren't even following their own I guess, duties of care that they have by not fulfilling things like psychiatric assessments, there's clearly gaps in the system, and young people are, you know, I guess, receiving treatment that they're not even being assessed for, which is really disturbing.
So, Dr Devlin?
Senator, so the guidelines have evolved from the professional bodies that are providing these expert services. It's not unusual in an area of practice which is evolving, which gender dysphoria services are an evolving service, that these guidelines are developed by the expertise and the professional groups who are providing the services, and now we've been asked that the NHMRC provide that sort of national guidance. In response to the notion of best practice, certainly the guidelines that many of the services which are provided by the states and territories are operating under, there is a sense, they're very clear that multidisciplinary care is particularly important for this. So that might include psychiatric or psychological services, social workers, those sorts of things. So there is a sense that there should be a team wrapped around these children and their families.
I'm not disputing any of that. What I'm saying is these teams clearly aren't working together, and children are being prescribed medications that, you know, we've recently had a federal court decision where Justice Strum basically endorsed the CAS review, and he ruled basically that the risk of harm of puberty blockers was considered unacceptable. So I guess what I'm looking at is there's a whole lot of young people. We're not expecting to have any official guidelines or even interim guidelines in place until next year. What happens to all of the young people between now and then, because they're being harmed currently?
Senator, I wouldn't accept some of the assertions around the children are being harmed. I would point you to the Medical Journal of Australia only 2 days ago released an interesting study which was an Australian perspective on the CAS review, and it did demonstrate that some of the comments in the CAS review are not not relevant in the Australian context in the notion of the services, and it did actually suggest that some of the findings of the CAS review weren't accepted by the sort of expertise in Australia. So that might be an interesting study for us to think about going forward. In terms of what is happening now, the states and territories are offering these services under their clinical governance models, and they are responsible for ensuring the clinical governance of their services and that their health professionals are operating to their appropriate scopes of practice. So it is a matter for the states and territories in terms of the quality and safety of the services that they offer their community.
Okay, and will the, I guess... Okay, so are puberty blockers being considered to be listed on the PBS for under 18-year-olds?
That's the PBS team would need to answer that question for you in terms of what pharmaceutical sponsors may have brought forward those medications.
Are they here now to be able to answer that?
Yes, they are.
While we're waiting, I mean, the Minister has asked the NHMRC to provide interim guidance on puberty blockers by the middle of next year. So that is our intention, and that guidance will be available by that time.
Okay, and my understanding is that was urgent advice that the Minister had requested.
Yeah.
Do you think the timeline meets the definition of urgent, in your view, when we've got young people who are being treated with no formal overarching national guidelines currently?
I think that we need to make sure that we get the answer right, that we look at all evidence, that we look at it in the Australian context, and that we take evidence from a large number of people, including people with lived experience, in order to come up with that answer. And so I think that time actually is the right amount of time, and is actually quite short.
The officer here, with respect to PBS, is not aware of the answer, but we have PBS under our outcome 2, so we'll endeavour to come back with a specific answer to your question then.
Thank you.
Thank you. Senator David Pocock.
Bulk billing.
So, sorry, Chair, with your indulgence, the tricky thing I was just looking at it now, bulk billing and bulk billing rates, except we would say is under outcome 2. But I was just looking at the way the agenda's put forward and the practice incentives, and for example, if you're interested in the ACT clinics, they're kind of primary health funding in the same way PHNs are, and they're under outcome 1. So I acknowledge there's a bit of a split between the two. Well, I think it depends. Sorry, Chair, it's your call, but
the question would be, are the correct officials here to answer the questions? I think. Well,
I've just got questions about the PIP.
About the PIP.
Practice incentive payments.
Which is outcome 2.
Well, I think it's outcome 1, whereas the actual broader
bulk
PBS
billing,
and bulk billing rates, MBS and bulk billing rates is outcome 2.
Yeah. Okay, so if you want to, so you're asking questions about the in outcome.
So can I just say that, just put on notice your officials in relation to this whole package. I'm likely to ask them in outcome 2. So if there's anything that's likely to be an overflow from outcome 1, could you make sure your officials are still here tonight? Thanks.
Thank you.
Thank you. My understanding is that the PIP is due to commence on 1 November, the 12.5% payment. Okay, great. So it's a quarterly payment of 12.5%, split evenly 50-50 between GPs and practices, if the practice bulk bills all eligible services within the quarter.
That's correct, Senator.
Yeah. And when does the first eligible quarter end?
So we're expecting the first payments to be in January, Senator, but the program commences on the 1st of November, so 3 months from then.
And how soon after you get the data do you make the payments? How does that work, or is it a pre-commitment that for the next quarter we're only going to bulk bill?
It's paid in arrears, essentially, Senator. And as I say, we expect the first payments to be in January.
Do you have a timeline from receiving data to making payments in mind? Is that a
well, the payments are made by Services Australia, Senator. I'll just check. Mr. Rocha, do you have anything to add?
Yeah, so we'll make them quarterly in arrears. That first quarter will be a part quarter, so from the 1st of November through to December, and so we'll make the payment in January
Okay.
via Services Australia.
Okay. And do you have a rough indication from Service Australia how long it'll take to release that payment?
I expect that it will be early in January. We don't have that level of detail at this time.
Maybe just on notice if you could provide advice on that. And will you be reporting publicly how many practices were paid the PIP in January?
It depends on how many sign up to the practice incentive program, to the bulk billing practice incentive program. It opens on the 1st of November, and so it really depends on how many sign up.
No, I'm sorry, that was a poorly phrased question. Will you be making it publicly available how many have signed up and received the PIP? Like, what's the public reporting of this data?
So there is a requirement, and I should have said Joe DeRocha, Assistant Secretary, my Medicare and bulk billing clinics. There is a requirement under the program that all bulk billing clinics will need to register on Health Direct, so it will be publicly available.
Each quarter, or?
In order to receive payments, they will have to register on Health Direct to say that they're a bulk billing clinic, and they'll have to display appropriate signage.
And will the department be releasing the number of clinics that are?
We haven't got to that stage, Senator. Our real focus at the moment is on opening on the 1st of November, which we expect to happen, and then we'll go to the reporting arrangements.
Okay, maybe on notice the reporting arrangements, please. How many practices are you expecting to uptake the PIP in November for the first part?
We don't have an estimate, Senator.
No estimate.
Our modelling shows, Senator, that around 4,800 practices will be better off through the program, but we don't have a particular time frame in terms of sign up to the program in that forecast.
How many are you expecting to take up the PIP by 2030? Do you have that figure?
Nothing beyond our modelling that shows that 4,800 practices will be better off, Senator, as I said.
Okay. Do you have anything on the ACT? I think last time we spoke it was 25 fully bulk billed practices. Has that changed?
I'd need to refer to my colleague, Mr McCabe, there.
Maybe while you're coming up, how many have any signed up to date, or you can't sign up yet?
There's an expression of interest process, Senator, and many hundreds of practices have made an expression of interest, but we expect the number of practices to sign up to be well in excess of that.
Okay. Maybe on notice if you could let me know how many in the ACT have expressed interest. Thank you.
Yes, Senator.
Senator Daniel McCabe, the Assistant Secretary, Medicare, Benefits and Digital Health. We haven't had any change in our predictions or modelling since the evidence I gave back earlier in the year. It's still 25. We are, and Mr Rodham might talk to this, doing some other things around grant payments and the like to encourage bulk billing clinics in Canberra as well.
And if the PIP was going to deliver 25 bulk billing practices, why is there a need for direct grants and payments in the ACT?
Well, Senator, the government and the department recognise a particular challenge in the ACT, so there is the initiative for 3 fully bulk billing practices to be established in the ACT with a $10.5 million election commitment, so really recognising the particular challenges here in the ACT.
And was that a recommendation of the department or a decision of government for the election?
That was an election commitment from the government, Senator.
Okay. When will they be opened?
So we expect the funds to flow. So the process is being worked through at the moment in terms of the grants process. We expect a provider or providers plural to be selected this year, and for funding to flow from the primary health network early next year.
And how many years is that for?
That's a 3-year measure, Senator.
And what happens after the 3 years?
Well, that would be a decision of government, Senator, and I imagine examining the success of the program.
Okay, thank you. I've got some questions about the youth specialist care centres. I think there were 20 that were election commitments. Thank you very much for that. Looking at the election commitment, I'm interested where the 20 centres will be located and how far away you are from announcing locations and opening centres.
Okay, so look, Mr. Short probably provided a bit more detail on the implementation of them, but basically it's a new initiative. They're not, the 20 centres that were committed, they will build on the 8 early psychosis youth centres that we already have, so it will expand those into a full youth specialist centre, in addition to open up another 12 additional centres into that, which will take it to the 20 that have been committed. So they are a new service. They'll require a new model to be developed, a model of care to be developed for those services. So that will be the first step. In terms of locations, they haven't been settled yet from the location, so we will be working and doing consultation, obviously, with states and territories and a range of stakeholders around, taking a lot of factors about where they should be located. They're a fairly large, significant, complicated service to establish and run, so there will be a lot of consultation needed to set those up and work them out. They will also, because they're intended to go up into the more moderate and severe range, obviously the connection with the state and territories is also fairly critical to get that right in terms of how it interfaces with those services. So there will take a little bit of implementation time to get right in the time frames for those to do it. So we'll be working that out. First step, the model, then it'll work through into an announcement of the locations, then the commissioning of them, and then there'll be a period of time to stand them up and deliver them. It'll take a few years, but I'll get Mr. Short.
Sorry, it'll take a few years to deliver them, to develop the model? To
deliver all 20 of them will be phased over 3 to 4 years to phase all of those centres in. So some will come in earlier, but they will take some time to get even the first ones up to get through that process.
Do you have an idea on timeline to finalise the model at least, so you can start procuring?
Yes, so we'll be doing that over the next probably 6 to 9 months, but I'll let Mr. Short provide some detail on timeframes.
Yeah, thank you, Senator. Matt Short, Assistant Secretary, Child, Youth and Priority Populations Branch. The model development is happening now and will continue through to early next year. The funding and phasing for the youth specialist care centres starts from 26-27 and is a 3-year implementation phase. So the rebrand of the 8 existing early psychosis centres, and this is public, the first 4 will start in 26-27 and then 2 in 27-28 to 28-29.
Sure.
And the new 12 centres with locations yet to be determined will be in 27-28.
So the 20 centres is actually 8 existing, rebranded 12 new ones. Of those 12 new ones, will every state and territory have at least one youth mental health centre?
If I may, Senator, just to be clear, it's a rebrand, but also it's a new model of care.
Sure.
So it is an expansion of the early psychosis to a trans-diagnostic model of care for young people with severe and complex mental illness.
So there will be a much larger and more intricate service than the existing early psychosis.
Okay, that's good
services.
to know. And so will every state and territory at least have one youth mental health centre?
That decision has not been made yet, Senator. We are providing advice to government now on need. So we're doing our national needs analysis work to provide advice to government on the locations for those 12. That has not been decided.
How could...
Thank you, Senator Pocock. I do need to share the call, to Senator Ruston. Thank you.
Thank you very much, Chair. Just quickly before we move on to the next topic, Secretary, could you provide me with the document that backs up your statement that you made previously in relation to the National Cabinet around the NHRA about the conditionality of...
I'll take that on notice.
Yep, okay, thank you very much. Can I just quickly ask some questions on the National Drug Strategy and smoking? Smoking. Does the department actively monitor illicit tobacco market and its impact on smoking rates?
So the department monitors smoking rates in general. From a health perspective, obviously smoking is and continues to be the number one.
I don't want to be rude. We are on such a tight time frame. I'm just interested. Does the department monitor the illicit tobacco market?
No. we monitor tobacco consumption.
Do you don't differentiate? So, and if you're doing tobacco, you obviously must be able to differentiate between how you would collect statistics on illegal versus the legal market. Would that be correct?
We collect statistics on smoking.
Yes.
In general.
But how do you can't be collecting the data on smoking in general in the same manner. You must collect data in relation to illicit tobacco differently to how you collect, or don't you?
We collect data like, do you smoke? Do you smoke daily? Do you smoke regularly?
Oh, so this is a survey. So this is like part of the National Drug Strategy Household Survey. Is that the only way that you collect that data?
So, Senator Carly Brown, Assistant Secretary in the Population Health Division. We monitor a range of different data sources in relation to smoking prevalence. In relation to the National Drug Strategy Household Survey that you referred to, there are questions that collect at a high level smoking prevalence, so any smoking of any tobacco product. There are also questions in that survey that relate to smoking of unbranded tobacco products, which is used as a proxy for.
Do you do any other collection of data in relation to the use of tobacco or nicotine outside of the survey?
So, Senator, the government has provided investment in a range of different data collection, but those are, as Ms Clancy mentioned, aimed at monitoring prevalence of smoking in the broad. There are a range of data sources that the department monitors in understanding.
External data sources. So you do the survey yourself, but you would be looking at external data sources in terms of what other people are publishing or other agencies are publishing in relation to what they found in their mechanisms of data collection.
That's right, Senator. And if I may just clarify, the National Drug Strategy Household Survey is conducted by the Australian Institute of Health and Welfare.
Yeah, oh, it's still the government department. Yeah. Okay, fine. There was a report that said that it was a Roy Morgan report. It was released in July this year regarding smoking rates increasing since the introduction of vaping restrictions that came into effect, and there was a subsequent article in the Saturday paper with claims that the study was amended following feedback. I'm just wondering, did the department receive any feedback from stakeholders regarding that particular research document?
Yes, Senator, the department did receive feedback from stakeholders regarding the Roy Morgan publication.
Did the department make any representations, either formal or informal, to Roy Morgan or any other stakeholder concerning the findings or the feedback that you'd received?
Senator, the department didn't make any representations to Roy Morgan in relation to the data. The department did engage with Cancer Council Victoria, who had undertaken separate analysis of a similar data set to produce a report under contract with the department. We engaged directly with Cancer Council Victoria to understand the differences between the analysis that they had undertaken under the contract with the department and the publication by Roy Morgan.
Are you aware whether Cancer Council Victoria had any contact with Roy Morgan?
Senator, the Cancer Council Victoria had purchased the data that they used for their analysis from Roy Morgan. So, yes, I understand they engaged with Roy Morgan in relation to that purchase.
In relation to the purchase, but in relation to, because our understanding, according to the Saturday paper, is that an original article said smoking increases among young Australians since vaping sales ban in 2024. That was the headline, so basically saying smoking had increased since a vaping ban came in. Then within days of that being reported, known as, I think it was finding 9936, the link was deleted. So, Minister, do you know whether the Minister's office made any representation to Roy Morgan or any of the other stakeholders in relation to this issue?
I can take that question on notice, Senator.
Okay, thank you very much. So, can I go to, I want to just ask some questions about the proton therapy facility in South Australia. Can I ask what the status of discussions with the South Australian Government or SAMRI is between the Federal Department and either of those two bodies as we sit here today?
Senator, we're in routine discussions with the South Australian government. The former South Australian Treasurer wrote to our Minister in July seeking significant financial support for the project, and so obviously that request is still under consideration.
Okay. So can you confirm the value of the funding that's already... can you confirm, to the best of your understanding, that the South Australian Government is no longer intending to purchase the proton therapy machine from Proton International?
So they did publicly announce that they had terminated the contract with Proton.
Yep. And how much money, to your knowledge, of federal funding has been paid to Proton to date?
Senator, we have paid $68 million, which was the Federation funding agreement amount to the South Australian Government, who were then working with SAMRI and who had contracted Proton. I'll just see if my colleague has any further details on the split of how any of that money has been spent.
Senator, I understand that so the $68 million was provided directly to the South Australian Government. Of that, we understand there's approximately about $11 million that's still retained by the South Australian Government that wasn't provided to SAMRI. I don't have the detail of the funding that SAMRI has provided to Proton International.
So is it the federal government's intended commitment to the development of a proton beam therapy facility in Australia, and in this case in South Australia? Does the government remain committed to the delivery of that, Minister?
Sorry, just repeat the question, please.
I was
Senator.
wondering whether the government still remains committed to the delivery of a proton beam therapy facility in South Australia for the whole of Australia.
Yeah, thank you, Senator. I was just looking for my notes on it and realised I didn't have it in my pack. Could I just say that that we are still working closely, obviously, with the South Australian Government around the future of the project, including recent work undertaken by the South Australian Government to explore alternative technology supplies, Senator.
Alternative technologies to proton beam therapy, or alternative providers of proton beam therapy?
I take it that explore alternative technology supplies could mean both, Senator, but I'll take that question on notice.
So I'm just keen to understand if you could take this on notice. Just want to make sure that you're not telling me that the government is no longer committed to the delivery of proton beam therapy for Australian patients.
I don't believe I'm telling you that, Senator.
No, just seeking clarification, Minister, that's all. Is there any consideration from the government about considering a private pathway to get proton beam therapy operational in this country?
Senator, as you're aware, the Australian Government obviously still supports the Medical Treatment Overseas program, which is how Australians access this therapy at the moment. I recognise...
Sorry, I was actually talking about in Australia. I'll come to that in a minute. So I'm just interested, is the government considering a private pathway to enable proton beam therapy to be able to be delivered or operational in Australia?
Senator, if I think about the number of patients that are likely to benefit from this sort of therapy, which will largely be children, the Cancer Australia strategy on proton suggested that it would be around 372 patients a year. That is a very small patient cohort, which is why you can see, the nature of a public service being required, because it may not be viable for a private operator. However, all partnerships will be explored in this.
Will be or are being?
Well, we're currently considering the South Australian Government's request.
So there's no consideration being given as an alternative pathway, if the South Australian situation falls over, to pursue a private pathway at this stage?
The South Australian Government is obviously pursuing a public provision of service.
Last question, Senator.
Okay. Have any MBS item numbers been approved by MSAC specifically for proton beam therapy?
Senator, I might wait for my colleagues in MBD to respond to that question, but I do know that there are specific MBS items for the purposes of comparative planning, which is looking at the benefits of proton versus photon therapy. Okay.
So I'd be keen to know, when the person turns up, how many and have those item numbers been formally issued?
Senator, we'll be able to cover that better under outcome 2, but not to my knowledge, but we'll confirm that when we have the outcome 2 folk here later this evening.
Okay. And just to finish off on this one, because I know the Chair wants to break, what is the cost to patients and the Commonwealth at the moment of the funding of the overseas treatment program that Dr. Devlin, you were referring to in your previous answer?
That will be another colleague to help you there.
No, sorry, you were just that you raised it.
Thank you very much. Yes, Secretary.
Answer to that question. Just through the MTOP program, an overseas program. In the last 4 years, there's been $31 million allocated to treatments.
Okay, and you've no idea what the cost to patients has been?
I can't tell you how many patients that involved.
Once they've been given funding under the MTOP scheme, there's generally not cost to patients.
I think patients would probably disagree with you. Maybe not for the treatment, but the cost of actually having to go overseas.
The MTOP scheme includes the airfares and accommodation necessary, and also occasionally includes accommodation and fares for the accompanying people. So,
yep, sure, and it's a great program. I'm certainly not saying there's anything wrong with the program, but there is a cost still associated with people having to travel overseas as opposed to being able to get treatment in Australia. But
just conscious of time. Thank you, Senator Ruston. And Secretary.
Just one last thing. I have the Senator Ruston asked for a question on a timeline related to communication activity, and I have papers to table now, which I can table. Great. And they can be distributed so we could discuss it after the break.
Excellent. Thank you very much for that. We will now suspend for a break until 4:15. We are also saying goodbye to the Minister, and we will have a new Minister to welcome when we resume at 4:15, and we will be continuing in Outcome 1. Thank you. will be in continuation. The committee will continue in Outcome 1, Health Policy, Access and Support. I now wish to welcome Senator the Honourable Nita Green, Assistant Minister for Northern Australia, Tourism, Pacific Island Affairs, representing the Minister for Health, Disability and Ageing. Minister, did you wish to make an opening statement?
No, thanks, Chair.
Thank you very much. I will go to Senator Roberts.
Thank you, Chair. I've got several issues here that I'd like to discuss. National Blood Authority about tainted blood, the pelvic mesh, the Lyme disease, ATAGI, following on from Professor Lawler's comments. So I'll start with National Blood Authority, please. And is Dr. John Rowell here? Dr. John Rowell? No?
Senator Adriana Platona, Chief Executive, National Blood Authority.
What's your second name, I'm sorry?
Adriana Platona.
Thank you. Okay. A lot of people are plagued with tainted blood, heavy burden. At CSL's 2024 Annual General Meeting, Chair Brian McNamee stated that prior to its privatisation, the Australian Government was the owner, funder and regulator of the Commonwealth Serum Laboratories. Is that correct?
Senator, the National Blood Authority was formed in 2003 as a statutory legislated agency. I'm very happy to answer questions about the National Blood Authority role and work since 2003.
Yeah, I'm just wanting to know if you could confirm that before the Commonwealth Serum Laboratories was sold off to the public, it was an Australian government was the owner, funder and regulator of the Commonwealth Serum Laboratories.
I believe that is correct, sir.
Thank you. What steps did the Australian government take to regulate the safety of the factor 8 and 9 concentrates manufactured by the Commonwealth Serum Laboratories in the 70s, 80s and 90s?
Senator, as I said in my question, in the first statement, the National Blood Authority was formed in 2003. I'm happy to answer questions about the work of the agency since then. You are referring to matters that precede the formation of the National Blood Authority by several decades.
Could you tell me, and I know it was a long time ago, but a lot of people are suffering now, severely. Whose responsibility was it at the time, Ms. Platona, is it Professor?
Yeah. Ms. Platona is fine.
Ms. Platona, to ensure the safety of the factor 8 and 9 concentrates?
So,
because this has relevance to what you're doing now.
Indeed. So, the National Blood Authority was formed, as I said, as a result of a number of circumstances that some negatively affected people in the 70s, 80s and 90s. My predecessor provided in November 2024, in response to your question on Hansard, a lot of context to the steps that have led to the formation of the National Blood Authority, the apology that, and the formation of what it is now, a National Red Cross Lifeblood organization, the apology that Red Cross Lifeblood made in 2014, a number of actions by states and territories government to deal with really the failings of the blood transfusion in the past. And I do not want you to think at all that I don't think about the lives of the people that Haemophilia Foundation, for example, is working to support. Not at all. I'm the officer that has got the Public Service Medal for making the direct antiviral medicines available, those hepatitis C treatments that are now considered to be best practice and curative. So I do want to acknowledge the hard circumstances of the people affected by the disease.
That's good. That's good. Did you want to say any more on that?
I'm keen to do a good job, Senator.
Okay. How can you do a good job for people with tainted blood? Because it was the government's responsibility.
So, Senator, since the organization was formed in 2003 to date, there is no contaminated blood incident.
Do you not have any legacy responsibilities from your predecessors? The Commonwealth Government is responsible.
So, Senator, prior to 1991, the Commonwealth's role was largely through providing funding to state and territory governments to operate blood services. States and territories regulated the blood supply system in Australia until, as Ms Platona has explained, the National Blood Authority was established in 2003 and provides that now national coordination. I think we also had the Therapeutic Goods Act 1989. After that, there were changes to the way that blood was regulated as well. But before that, largely the regulation would have been occurring through state and territory governments.
But it was overseen by the Commonwealth. Well, let's go through the history, and correct me if I'm wrong, Ms Shakespeare. In March 1953, the World Health Organization released a report that recommended dried plasma should be prepared from small pools of no more than 10 to 20 donors. This was ignored, and by the mid-1980s, factor concentrates were being manufactured using mass pooled plasma from thousands of donors, significantly increasing the risk of hepatitis and HIV. Why were these early recommendations ignored? Now, you weren't around then, but that was federal responsibility?
Senator, we can try and take on notice what if there's anything in the archives about what happened in the 1950s, but it is a little bit difficult for us to talk to you about what happened at that time.
Okay, if you could take these on notice then, please. In the mid-1980s, actually it was, factor concentrates were being manufactured using mass pooled plasma from thousands of donors, which went against the prevailing wisdom. Could you find out, Ms Shakespeare, and I thank you for your attention, was it considered an acceptable risk that there was a high probability of haemophiliacs using factor concentrates that would be infected with hepatitis non-A, non-B, hep C in the 70s, 80s and 90s?
So, Senator, what I can tell you is that the first specific test for hepatitis C became available in late 1989. Australia was one of the first countries to commence using the test in November 1989, with implementation completed by February 1990. Similarly, we were one of the first countries to introduce HIV patient screening in May 1985, when tests had become available to make sure that the blood supply was safe and could be monitored for those particular medical issues. We've implemented that as early as possible.
I'm wondering how to help these people.
So I think Ms Platona has spoken about some of the assistance that has been provided, and I can go through some of the help that has been provided. So first of all, there was a review of the blood arrangements in 2001 that was conducted by a former High Court judge. The recommendations from that review were provided to all Australian health ministers and led to the establishment of the National Blood Authority and the centralised, coordinated arrangements we have to ensure a safe and adequate blood supply that we still have today.
So let me
we have haemovigilance.
Can I interrupt just then?
Of course.
So that would assume that prior to that it wasn't considered to be safe, the blood.
So decisions will have been made based on the state and territory government's delivery of blood products, about the introduction of testing when it became available, when those tests were developed. And as I said, compared to other countries, Australia was one of the first adopters and introduced those tests at a very early stage. But we didn't just stop there. We've been, establishing arrangements to make sure that the blood products that we provide to people today are nationally coordinated, and that we've got consistent arrangements, and that we don't have differences between regulation and provision in different states and territories. The National Haemovigilance Program for Australia has been developed. That's a set of surveillance procedures covering the entire blood transfusion chain, from donation and processing of blood to their provision and transfusion to patients.
We have monitoring, reporting, investigating, the analysis of adverse events related to donation, processing and transfusion, and development and implementation of recommendations to prevent the occurrence or reoccurrence of adverse events. So we've got a whole haemovigilance program that now operates. That's been developed and implemented through the National Blood Arrangements. For people that have acquired hepatitis C, the direct-acting antivirals, which were listed on the PBS in 2016 and at that time was the largest single PBS listing that had ever been made. We have future generation direct antivirals that are now provided through the PBS, and if I can give an example, in 2023-24 we had 9,167 scripts of a drug called gleparopivir and pibrentasavir, which is a current generation of treatment for hepatitis C at a cost to government of $161 million. In the same year, sofosbuvir and velpatasvir, another medicine to treat people with hepatitis C, 10,953 scripts at a cost to government of $131 million. So we're providing access to those treatments. Now, that covers anybody with hepatitis C. It doesn't matter how they acquired it, but it would certainly benefit those who acquired it through the blood system before the testing was available.
So some of these people with tainted blood their lives have been really shot. Perhaps you could look at the camera, and I'm not trying to put pressure on you or Ms. Platona or the Minister, but what do we do for these people? Where do they go for compensation? Britain has compensated their people with tainted blood. Long ago. They've admitted it and gone on with the job. How do these people recover? How do these people get compensation if they can't? I know you've given a list of drugs. What do we do?
Those are curative, in many cases, direct-acting antivirals, which will be of significant benefit to people with hepatitis C. I should also say that the Australian Government contributes to the hepatitis C litigation settlement schemes, which were set up and are managed by the state governments for people that were infected through the blood supply system before we had the National Blood Authority established. So that offers financial settlements for people who contracted hepatitis C between 1985 and 1991. So there has there has been compensation made available, and the Australian Government contributes to that.
Senator Roberts, I'm going to have to share the call.
Thank
we
you
are
for your
tight on
interest,
time.
Ms. Rexby.
You're welcome.
Thank you. Senator Payman.
Thank you, Chair. So my line of questioning is on the medicine shortages. So the Royal Australasian College of Physicians said in March that with over 400 medicines in shortage in Australia, increased production capacity in Australia was paramount. With the current Trump administration looking at implementing tariffs on pharmaceuticals and Big Pharma taking aim at the PBS, the outlook for global supply of medicines is increasingly uncertain, and I'm sure you'd agree with that. I'm just curious to understand what's in the pipeline or what is the government hoping to do to ensure there's enough medicine in Australia for Australians that need it.
So, Senator, thank you for that question. Professor Anthony Lawler, Deputy Secretary for Health Products Regulation. We have responsibility for identifying and mitigating the impacts of shortages. So I might just throw to my colleagues to speak about what we're doing, not only to respond as and when these shortages arise, but what we're doing in a proactive sense to forecast and work with key stakeholders to be prepared and responsive. But then I might ask Mr McIntyre perhaps to talk around some of the work that we're doing in that space as well.
Thank you.
Dr Tali Fenner, Acting Assistant Secretary, Pharmacovigilance Branch, Medicines Regulation Division. So within the TGA, our responsibility, as Professor Lawler said, is to monitor the medicine shortages and the supply of medicines. And we do that with sponsors, so pharmaceutical companies must report to us upcoming shortages or discontinuations for prescription medicines and for a certain range of important non-prescription medicines. And we work with pharmaceutical companies and peak bodies and stakeholder groups to minimise those impacts of shortages and work to ensure equitable supply. We undertook within the TGA a really sort of comprehensive consultation in early 2024. And that included consultation with consumers, health professionals and industry stakeholders to look at where we could improve TGA, our role within the TGA. And we distilled that down to 4 sort of themes that we've been progressing in terms of reforms. So they are, firstly, to look at updating our legislation to better be able to mitigate and take action for medicine shortages. Secondly, to look at improving some of our data and digital capabilities. Also to improve the way we communicate and with health professionals, and to look at how we could better predict shortages. So that work's ongoing. This year we have undertaken some reforms already to improve our legislative framework. We added around 25 medicines to our non-prescription medicines to our list of medicines that must be reported to us. That includes things like IV fluids, which are really important. And we're working through that program, developing some communication frameworks. It's important, I guess, to recognise what TGA can't do. We're a therapeutic products regulator, and we can't compel sponsors or companies to make applications to either register a product on the ARTG or supply an overseas, apply for an overseas alternative to be supplied. So we have got some limitations in that regard within the TGA, but we're certainly progressing reforms within the scope of our remit.
Senator, I mentioned earlier today as well, we've also formed what we call a medicine shortages stakeholder forum with 40 organisations across health professional representative groups, consumer groups, in industry, for example. I did take on notice from Senator Stilldron to provide a list of those organisations as well. So we are looking at where we can continue to make improvements to our processes and communication. So we're really looking to utilise that group ongoing to provide that insight.
That's great to hear. Thank you. Medicines for things like diabetes, menopause, rheumatic fever, and breast cancer are among those that have been affected by the shortages this year. While the Health Minister can approve similar medicines for use during a shortage, a constituent of mine named Joanne told me that these are often difficult to find, as a shortage of one type of medicine can lead to a rush on approved alternatives. So what action is the government taking to hopefully address that problem?
Senator, perhaps I can come in here. I look after the PBS elements of shortages, and there are a range of things associated with the management of medicines that we do to try and help with situations where medicines are in tight supply. So the TGA has a monitoring process, and that includes reporting that can help understand whether things are in acute shortage or whether the supply is tight. But where it's tight, we have a number of mechanisms to try and ensure that the medicines that are available can be distributed as broadly as possible and minimise those knock-on impacts to other therapies. The most important of those is probably the minimum stock holding requirements. So a wide range of the medicines that are on the PBS the sponsors are obliged to maintain a 6-month supply of availability in country. And where they're unable to do that, they have reporting obligations to advise us, and we can then work with them and with other sponsors to communicate the supply tightness and ensure equitable distribution. We also have new arrangements that have been put in place with wholesalers, with an agreement that we signed with pharmaceutical wholesalers last year that oblige them to manage the supply such that there can be equitable distribution when supply is tight. This This is, if you like, the toilet paper shortage problem, where there is enough, but everyone puts a rush on it at the end. And what can happen is the big players, which are often in metropolitan areas, get everything they need, and the little players, who tend to be small pharmacies and remote and rural, they're the ones that miss out. So we work with the pharmaceutical wholesalers to ensure that some supply is held back to be made available to those that might need a smaller amount of supply. We also work closely on particular issues of shortage. IV fluids is an example of where the Minister made announcements last year, and a company that manufactures in Australia has ramped up their production of IV fluids onshore so that we can make sure that the supply tightness there can be met. Onshore production is often not possible, but where it is, it's certainly one of the options that we discuss with wholesalers and potential pharmaceutical sponsors. I'll leave it there, but there's a lot more about all of those items.
Yeah, just on the 6-month supply, does that apply to alternatives as well, or is that just...
So we have what we call designated brands, and they're the ones that have that obligation. So it's not all medicines on the PBS, but it is usually those that are significant and whose shortages would cause concern for patients. Of course, there are situations where at the time of listing supply is very tight for pharmaceuticals, and what we don't want to end up doing is causing a shortage by requiring stockpiling. So we sometimes have to manage that obligation closely with ensuring continuity of supply.
Thank you. Just referring to a report from the Institute for Integrated Economic Research, which found that Australia imports more than 90% of its medicine. The local manufacturing sector is small, but the Royal Australian College of General Practitioners suggests that further investment in domestic medicine production could help to address shortages and, hopefully avoid the toilet paper situation. Will the government invest in domestic production of medicine to help those Australians affected by shortages?
Senator, certainly the Australian government considers all options to address medicine shortages. There are a very wide range of medicines, and one of the unfortunate things about medicine supply chains is they're all quite different from each other. Many medicines have a primary ingredient that is only made in one place in the world. And so Australia, alongside many other countries, have to deal with these supply chains flexibly. While Australian manufacture is sometimes a good solution, it often isn't. IV fluids is an example where that proved a useful solution, but that's partially because the fluids are heavy because they're mainly water, and therefore local production leads to benefits. For many other medicines, the benefits are more modest, and the challenges associated with getting the materials to manufacture here wouldn't necessarily best mitigate the risk and might make the medication much more expensive for Australian patients. So we continue to work with sponsors. It's always going to be a challenging situation, and there are at any one time a number of shortages, but the data shows that over time we tend to resolve some shortages and new ones arise, and that the same things don't remain in shortage for long periods.
Thank you.
Can I give you a
Of course.
answer, just to say that the government does want to grow medical manufacturing, and although it's not part of this portfolio, of course you would be very well aware that the National Reconstruction Fund has a targeted investment towards medical manufacturing. That's part of our Future Made in Australia policy. I think industry might be on today somewhere else. I've lost track of which committee's on which day, but that is part of the work that we're doing in manufacturing, although it's a very nuanced policy, as our officials have explained to you.
I do need to share the call now.
That was all my questions. Thank you so much. Appreciate
very
it.
much. Senator Barbara Pocock.
Thank you, Chair. My questions are in two lines. One is for the Australian Institute for Health and Welfare in relation to homelessness, and the other in relation to LGBTIQA blood donations. So I'm going to be quick. I've got 10 minutes and the iron fist of the chair in charge. So if I can have the homelessness question, I'll start now. And it's a simple, but I'm sure not a simple question to answer in total, but does the Commonwealth know how many people are experiencing homelessness in Australia right now?
Good afternoon. Zoran Bolovic, Chief Executive Officer of the Australian Institute of Health and Welfare. Thank you very much for your question. The Institute does provide regular reporting on homelessness, and we have indeed recently provided reports on the current state of homelessness in Australia. I haven't got the particular number in front of me that you're asking about, but we can certainly provide it to you on notice, and it is available on our website as well.
Okay. Thank you. If you could make available the number. What data do you rely on? How do you determine that figure?
Most of our data is actually collected from the specialist homelessness services. We have actually a very good data collection system that was established a few years ago, where providers of specialist homelessness services regularly on a weekly and monthly basis provide us information on their activity, on the services they provide to people experiencing homelessness right across Australia. And we largely base our reporting on the information that is directly collected from that sector.
So I think of my own state, there are a range of very diverse, sometimes very small, sometimes quite large services that assist people who are without homes. How do you collect that data? You have a system where they complete a form that's comprehensively and consistently applied across the very diverse range of services, including in regional Australia?
Yes, indeed. Obviously the first task for the Institute in that process some years ago was to establish some data standards, which is what we usually do very well, and in consultation with our state and territory colleagues and the sector. And once that standardisation process is completed, there is usually then a phase of developing systems for data collection. This one is fairly well developed now and is supported by a specialised IT agency that actually specialises in working with this sector. Some providers have their own systems that they have adjusted to be able to provide the minimum data set. Others rely on a more generic product, let's say, especially smaller providers, so they just log on to the website provided by this IT organisation and provide us the data that way.
And can you summarise the trend in 30 seconds about what you're seeing over time?
I would prefer to provide you more accurate information based on our reports, as I said earlier, if that's okay.
A 2020. Let me just check then. How does your data line up with the ABS data where we have it? For example, the census 2021 would be the last, I imagine.
I might just check with the Deputy CEO whether she has any insights on...
If you want to take that on notice if it's too tricky.
I can talk to that. Louise Gates, Acting Deputy Chief Executive Officer. So, yeah, as Dr Bolovic outlined, we collect most of the information on the use of homelessness services as opposed to the number of people who are homeless, whereas the ABS, as part of their census, collects the number of people who are homeless.
And how do the figures compare?
So the number of people who receive homelessness services is obviously determined by those people who approach homelessness services as opposed to all of them. I haven't got the two numbers in front of me to explain
Could you provide those on notice over time, say over the last 5 years? If you're, well, you'll only have one census point, but if you could give me the trend and the comparison, I'd appreciate it. A 2024 investigation into Australians experiencing homelessness found that the average age of death for people without housing was 44. That's 30 years younger than the average life expectancy of the broader population. Do we know, or do we have any data on how many people die with a recent experience of homelessness?
We have, in recent months, produced a report based on a linked data set where homelessness, specialist homelessness service data was linked to mortality data in order to produce the estimate that you have just referred to. So again, we'd be very happy to try and provide you that data more accurately.
Thank you. I apologise for not being more familiar with your website. What proportion of those who receive a homelessness response or support through the Commonwealth Specialist Homelessness Services funding remain homeless after they have received that service? Can you tell me that?
Again, we would have to provide that.
You have that data though. You've got evaluations of what happens.
Yeah.
Okay. Thank you. I look forward to getting all of that information, and I appreciate the work that you're doing.
We'd be happy to provide that.
Can I go then to the question of blood donations? It is welcome that the Therapeutic Goods Administration has given Lifeblood the green light to collect plasma and whole blood from gay men and bi men and trans women who have sex with men without an abstinence period. However, the way this is being implemented raises some questions for constituents. First, why has plasma donation been introduced without whole blood donation?
So, Senator, on 14th of July, Lifeblood launched the plasma pathway following the TGA's approval on 25th of May 2023. The deferral, like you said, means that gay and bisexual men, transgender women, and other groups are eligible to donate plasma for fractionation with no wait time by CSL Bearing Into Medicine. Extensive research and modelling have demonstrated that changes could be implemented without compromising the safety of Australia's blood supply. And plasma was the first pathway to be approved and adopted, because plasma for fractionation undergoes pathogen inactivation, a process to eliminate or inactivate viruses and bacteria to ensure the safety of plasma for fractionation. TGA, it's here, they have approved it, may have more technical details.
Thank you. I don't have a great deal to add, Senator. In a sense, the regulation of blood supply mirrors that of therapeutic goods. There is always an appropriate balance between access and risk. We recognise that the introduction of the plasma pathway is a significant step forward, and we've obviously worked with Lifeblood on that. As Ms. Platona has highlighted, the risk can be mitigated in the plasma pathway because there is the pathogen inactivation steps, and that means that because those are not usable in the whole bloodstream, then other risk mitigation measures need to be employed.
So, do you have a time frame for whole blood donation?
That would be a matter for Lifeblood to submit to us to have that considered.
So, have you asked for that? Have you requested any information? Have you got a plan at all working with them?
So, Senator, the process is that Lifeblood makes applications to the Therapeutic Goods Administration. The TGA assesses and makes a decision on whether it is approvable or not. And then it comes really back onto the Lifeblood for proposals on implementation, timelines, and so on.
It would depend, Senator, if I may, on Lifeblood bringing to us a proposal that provides the same risk management assurance that the pathogen inactivation steps does for plasma.
So my next question may be more appropriate for Lifeblood, but I'm sure you'll tell me. Why do the whole blood questions proposed by Lifeblood not meet the standards set in comparable countries like Canada, the UK and the US? In particular, advocates have expressed concern about the proposed question about being monogamous for 6 months. 6 months is, I'm told, an unnecessary long deferral period. The question could create confusion, superfluous, because subsequent questions about anal sex and 3 months monogamy are the ones that matter. The questions asked in Canada, the UK and the US are simple, easy to understand and medically justified. Why are Lifeblood's proposed questions different to these? Are you able to help me with that?
So, Senator, if you would like, we'll take the question and I can raise it in our regular meetings with Lifeblood, and we can come back to you in writing with what their response is and comparison with other countries.
Great, thanks very much. I really appreciate your assistance.
Great, thank you, Senator Pocock. Senator Ruston.
Thank you very much. Just finishing up on the proton therapy, could I just ask if, or maybe to you, Minister, can you guarantee that Australian children who are the predominant beneficiaries of proton therapy will get access to proton therapy treatment in Australia? And if so, when?
Thanks, Senator. As you can see, I've just joined the hearing. I'm not really aware of the questions you were asking before the break. I might ask the officials to answer your question, and if I can get you any further advice, I will.
That would be great.
Thank you, Senator. I think it remains the intention of the Australian Government to establish a proton beam therapy service in Australia. And you are right, I think it is about 2/3 of patients identified for proton are likely to be paediatric patients.
So there's no timeline as far as the federal government's concerned. It's pretty much left in the hands of the South Australian government?
At this stage, we are still in discussions with the South Australian government.
Have you spoken to the South Australian government since the correspondence from Minister Coutts-Antonis in July?
Yes, we have. We are in regular communication with our counterparts in the
Can you
Health Department.
divulge what those communications are leading to? I mean, is the intention of the federal government to work with the South Australian government and provide the additional funding for this to actually occur, or?
Well, that will obviously be a decision for government. The nature of the conversations we've had with our counterparts have been to understand the information they have provided us, the additional analysis and reports that they have done, so that we can inform the Australian government's decision.
Yep. Okay, so can I just move on to the response that you provided me just before the break, Mr Comley, in relation to the website? And I just wanted to clarify part of the department's earlier testimony where it was said, and I quote, "The campaign website was not active during caretaker period. However, you've advised in your communication that the URL was live until August 2025. I just wondered whether you wanted to correct the record.
So where's... Just waiting for Miss Balmano, not sure where she is.
While we're waiting for Ms Balmano, could I ask then, who ultimately makes the decisions about changes to DPA areas?
So DPA areas. I'll get the relevant officers on DPA areas. Yep.
Start. So the 17 new DPA areas, I'm just wondering who made the determination or who decided on the 17 locations?
So, Senator, the Minister agreed with the... So it's a yearly, generally, a yearly process we do with data as we update DPA based on new statistics. And we provide advice to the Minister on where the boundaries have moved or the statistics have moved, and he makes a decision on the application of that.
Okay, and so is it possible for the department to table the advice in relation to the DPA changes? You can take that on notice if you like.
Senator, ordinarily, I don't think we'd provide advice. We can confirm that advice was provided and the dates on which we've provided it, so happy to do that.
Yeah, and if it was at all possible, if you could actually provide the basis of which the determination was made. Were any of the locations that were recommended by the Department for Change rejected by the Minister?
No, the only... so we provided a list of the updated DPA or under the methodology that we use to update DPA, the same methodology we use every year when we update it.
That's fine.
Yes, that's it. So we just provided that, and those were the 17 areas.
So the 17 areas
and those were just the areas that were having upgraded DPA or going from non-DPA or partial DPA to full DPA.
Okay, so it was the 17 areas were recommended by the department. The minister had no idea or understanding as to that. It was just purely based on the statistical analysis that you...
Those 17 areas, yes.
Yep, and were there, so there's no other areas that have been included in DPA that the department didn't recommend?
There is a process where we look at exceptional circumstances, and that's based on recommendations from our distribution working group. There may have been, I'm just trying to recall whether there were, outside of this process, other areas that were made DPA based on that advice. But in terms of that process that you're talking about, it was only those areas that were identified through data that were made DPA status or upgraded from partial to full DPA.
Okay. If you could provide some further information about the processing around how those DPAs, because I mean, distribution priority area had originally had a purpose, and it appears to have been quite significantly eroded by the changes. But thank you for your advice, Ms. Strapp. So, do we have the website, people? Thank you. I asked before you came in that I just wanted to clarify something that I'm not sure, Ms. Balbano, whether it was you that said it, but one of the officials said it, that, and I quote, "The campaign website was not active during caretaker period. However, the piece of advice that the Secretary provided me just before we broke for afternoon tea said quite clearly states that the URL was live until August 2025. I just wondered whether you wanted to correct the record.
So the campaign content on that site was taken down. The URL was still live. So it's all actually on the health.gov site. It's one big website.
You said the campaign website was not live, and it was.
Happy to correct that, to
Thank
say
you.
that the campaign content, which we refer to as a sub-site, that was removed.
Okay. So why wasn't the website taken down in December 24 when you said the campaign advertising ended?
So at that stage, in terms of the actual advertising ended, there were still public relations activities as part of that campaign that went into 2025.
Okay. So I understand from this information you've just given me that the content on the website was reviewed given the election was called, and as a result of the department updating the content. So I'm keen to understand, given that the department content cannot be political, why did the department rename its website to Strengthening Medicare after the election was called, when that was the election slogan of the Labor Party? So I would table this.
Strengthening Medicare was the name of the budget measures that were announced in the budget, the 25-26 budget, that were the content of the campaign. So in the post-budget update to the site, that's when it was labelled to Strengthening Medicare.
Okay. So you really expect people to believe that you had a name on your website up until caretaker mode that came into effect that was different, and then on the day the election was called, you changed the name of your website to Strengthening Medicare, and I table this, Chair, it is exactly the same as the campaign slogan of the Labor Party's election campaign.
So Strengthening Medicare appears throughout the budget materials that were released some weeks prior.
Thank you. Okay, well, I've struggled to accept the fact that that was so unbelievably coincidental. That was the day you chose to change your website to have that as the banner on it. So, thank you. Could I quickly ask some questions around mental health and particularly suicide prevention research?
Hi, Senator.
Hey, how are you? Good. So what's the status of the National Suicide Prevention Research Fund as we sit here today? Is it receiving ongoing funding?
So the National Suicide Research Fund, I think so, funding of $4 million over 2 years was announced. I forget the date, it was probably about a month or so ago. Price might know the exact date for that. So that that will give the funding for the next the next 2 year period. We'll be working through with Suicide Prevention Australia to put the agreement in place to cover the arrangements for that funding for the 2 year period.
Okay, so why only for 2 years?
So the 2 years really just gives enough certainty for the research, and the aim there is also there was a small allocation of funding to do a fairly rapid review of the research function that will inform then the longer consideration of how that research then might be set up as a longer term piece of work. That will obviously be informed by the broader suicide prevention strategy that's there, as well as the future directions of the National Suicide Prevention and Leadership Support Program as well.
Okay, so you contend that this additional funding that came very, very late, in fact after the original funding had expired, is sufficient to maintain the continuity of that research project, given the incredibly high incidence of suicide in Australia. I mean, maybe that's one for the Minister. Do you think it's adequate, Minister?
Sorry, I didn't get the first part of your question, Senator.
We can just ask the last part if you like.
Could you repeat the question? Thank you.
I'm just saying, do you believe that the $4 million that was very belatedly provided to support the National Suicide Research Fund is adequate to maintain the continuity of research that is needed for this very, very important project that has been ongoing? Funding was uncertain, and now we've had a sort of an ad hoc top-up of $4 million over 2 years. I'm just wondering whether you think that is adequate.
Oh, look, it's a really important program, and that's why we funded it. It's why we're delivering $361 million over 4 years for our new mental health services in a stronger Medicare package, a number of different measures that we're taking in regards to mental health. Of course, as you know, with any measure that does have an end date, we'll consider those fundings through regular budget processes.
I would note, Senator, I think the amount that it's funded at 2 years $2 million per year is also consistent with the funding it was funded before that level as well.
Yeah, for 5 years.
Yep.
5 years gives some sort of certainty and runway. 2 years is
yeah, but
a much shorter period of time.
The intention is to provide enough certainty for the research to continue while there is a rapid review done to look at how it might be set up longer term and how does that relate to broader research effort through the MRFF and those wider research efforts as well, so that we sort of can have a look at it a little bit long term and make sure it is fit for purpose over the long term.
Okay. So the Minister, recent data from the Productivity Commission showed that the number of Medicare clients for Medicare subsidised mental health services was at its lowest level in a decade. So I'm just interested to understand whether your government still stands by its decision that cutting in half the number of Medicare subsidised mental health sessions would increase the number of people who were able to get access to these sessions.
Well, Senator, I can get officials to talk you through that decision. I'm sure you've ventilated it in many sessions in these estimates before, but we can talk about the reasoning behind that decision again if you like. What I would say is that we are investing $361 million in mental health over a number of different programs, and the drop in that number might not necessarily relate to that decision, but I'm sure officials can clear that up for you. Of course, we've also opened 40 Medicare mental health centres where you don't need anything other than a Medicare card to see the mental health professionals that you need.
So I'm just keen to understand around this Better Access program. We heard on Tuesday morning from the RSCGP Health of the Nation report that found that 71% of GPs said that mental health is the top reason for patient visits. And so we still have this sort of legacy of the sector calling out for the reinstatement of Medicare subsidised mental health sessions. So I'm just keen to understand, is the government doing any work, or is the department doing any work to ascertain the effectiveness of its decision to reduce or cut those services in half?
Yeah, look, Senator, I will let officials answer about the work that we're doing. Obviously, the Better Access evaluation found that providing additional services to existing customers limited the capacity of providers to offer treatment to new users, with many people from lower socioeconomic backgrounds and regional and rural areas missing out. But I can let officials give you a more fulsome answer.
So it's probably been covered in estimates, I think, a few times previously, but the number of people probably claiming, say, 20 sessions was quite low. I think the number that up to 20 was only about 1.5% or so.
So, Mr Matthews, I didn't ask you about that. I actually asked you if you were researching the effectiveness of the decision.
Yes, we're watching. So we'll be monitoring the data, trying to answer. So the data we obviously will be watching. I mean, what we do know is from the point of, say, comparison back to 2022, that from the, because the debate is obviously there's a capacity there of the service to provide it. So the thing is that if people are having more sessions from that, then that restricts the number of people that can come into that capacity. So what we have seen is in 2023 there were 45,000 additional people compared to 2022 that had taken up some component of the initial 10 sessions, and that in 2024 there was 54,000 additional people compared to the 2022 who had taken up some component of that initial 10 sessions. So we have seen an increase in people that have accessed into the 10 sessions under the Better Access scheme from the point of that decision.
So you're saying that the Medicare figures that say that people accessing the Medicare subsidised mental health services are at the lowest level in the decade is incorrect?
No, I'm not saying that at all. So the data around, obviously the broader in totality for the MBS data for Better Access, it is a demand-driven program. It's a range of factors in there. So I'm not saying that that's increased. I think the data shows it probably has gone up through COVID, and then it is lower, then dropped down a little bit, and I think it might be up a little bit in the last year. But there has been some sort of reduction in that. But that it was also comparing it to through the COVID period. It's not necessarily isn't clear whether that's associated with the with the additional 10 sessions in any way. In fact, we have seen those increases in the initial 10 sessions, and of course the Better Access scheme sits in the totality of mental health, and of course there has been the increase in the other schemes through both the Headspace centres and the Medicare mental health clinics and other channels to come in for mental health, and then we'll soon have the National Early Intervention Service as another pathway in there. So it isn't the only pathway through for people from a mental health point of view either.
Okay, well, I look forward to seeing that information and data. I'm assuming it'll be publicly available. Have I got 1 second to ask APRA, or have they gone? Scott's still here? If it's gone, I'll put it on notice.
They're still here?
I don't think
Yes,
they've been dismissed yet, Senator, so I think that's in your hands.
Yeah, I wasn't sure, maybe I had said it. Yeah, yeah, 2.
Thank you.
Hey. Look, thank you. Just quickly wanted to touch on influences on social media in relation to cosmetic procedures.
Correct.
It was interesting, both the TGA and the government expressed concern at this rising issue. Do you share those concerns?
So Justin Ornsteiner, CEO of APRA. Yes, I do. We've seen, both in terms of cosmetic surgery and cosmetic procedures, we have seen a rise in the use of social media for advertising and the use of influencers. We have now provided an updated guidance both for cosmetic surgery and for cosmetic procedures, which prohibits certain types of advertising, particularly when it relates to influencers. We have been now undertaking audits, social media audits, to identify breaches of the advertising guidelines. And in fact, we have been launching new technology which better identifies earlier those sorts of breaches.
So do you have any data from those searches you've done? Any data that you could make available?
I can certainly get that for you, Senator.
Yep.
I don't have it on me, but I'm
That's
happy
fine.
to take it on notice.
Okey-doke. And so do you consider that the current regulations for the advertisement of cosmetic procedures is fit for purpose in the modern context of social media?
I do. I think we only, when it comes to, again, if I draw a distinction between cosmetic procedures, and cosmetic surgery, we've only just released our guidance on cosmetic procedures very recently. In fact, it only came into force in September. So it's still relatively new, but again, we believe it's immediately having an impact. And again, from a risk management perspective, we've done a lot of work to advertise that new guidance and to try and encourage compliance with the guidance, but as we move forward now, we're taking firmer action.
Yeah. So it'd be really interesting, and I understand it's only been in for a very short period of time, and maybe for next time, just be really interested to understand, like, after you've got an understanding of the impact of the new measures, what actions you're proposing to take in order to make sure that the regulations are enforced. Thank you,
Happy
Chair.
to do that.
For me.
Thank you.
Thank you very much, Senator Ruston. We will now be moving to outcome 3, ageing and aged care, under program 3.1, 3.2 and 3.3. So I welcome officers of the Department of Health, Disability and Ageing, and also extend that to the Aged Care Quality and Safety Commission and the Independent Health and Aged Care Pricing Authority and Inspector General of Aged Care. For the purposes of Hansard, we will be releasing the following agencies from Outcome 1. The Australian Health Practitioner Regulation Agency, Australian Institute of Health and Welfare, Australian Radiation and Nuclear Protection Agency, the National Blood Authority, the National Health Funding Body, National Health and Medical Research Council, the Office of the Gene Technology Regulator and Organ and Tissue Authority. I am going to kick off. I don't know if we've got outcome 3 people here yet. They possibly are still in the waiting area.
They're getting past the excited crowd leaving after outcome 1.
We'll just temporarily suspend broadcasting if we can till we get everyone in the room. broadcasting. Thank you very much. And welcome to Outcome 3, Ageing and Aged Care. I'm going to start the questions if I can. Earlier on today, the department tabled some data to the committee. Based on that data, can somebody tell me how many individuals are on the national priority system?
Thank you, Senator, for the question. Greg Pugh, First Assistant Secretary of the Access and Home Support Division. As at the 30th of September 2025, there were 121,909 people on the national priority system waiting for a package at their approved level.
Great, thank you, Mr. Pugh. I understand there are some caveats to this data. Can you please explain those to me?
Yep, happy to. So I mentioned this at the Aged Care Service Delivery Inquiry as well. So we have an aged care data warehouse. Out of that data warehouse, we're able to pull data at any point in time. However, we go through a series of verification, validation and quality assurance processes before that data is published. It was quite clear through that inquiry process and also at previous estimates we have formed for providing that data as recently as we can. So although that data has been provided, those caveats remain attached.
Great, thank you. Why is the demand for in-home care so high currently?
Thank you, Senator. So the demand for in-home aged care is so high at the moment for a couple of reasons. One is we obviously have an ageing population and we know that people want to get into care and receive access to the services that match the level of need that they have. So that's what we are aiming to do through the Home Care Packages program and as well through the Support at Home program, which will commence from 1 November 2025.
Great. As at 30th of September's data, how many older Australians have access to a home care package? And presumably that number is equally as high.
Sorry, can you repeat the first part of that question?
Yeah,
sorry,
as of the 30th of September data, how many older Australians have access to a home care package?
Oh, yeah, thank you. So as at 30th of September 2025, there were 310,363 people who had been allocated a home care package. Of those, 296,852 people were in an actual home care package receiving care.
Great, thank you. And on the 3rd of September, Minister Butler and Minister Ray announced an additional 20,000 home care packages that they would be released prior to the 31st of October 2025. How many packages have been released so far?
As of today, 10,001, Senator. They've been released in almost equal tranches over the last 3 weeks, and there are 3 weeks to go before commencement, so we will continue with that cadence.
Great. And what happens post November 1? And how many packages will be rolled out between now and the 30th of June 2026?
Thank you, Senator. So between the 1st of November and the 31st of December 2025, there will be an additional 20,000 packages rolled out as part of the Support at Home program. From the 1st of January to the 30th of June 2026, there will be an additional 43,000 packages rolled out under the Support at Home program.
Great, thank you. I'm going to hand the call to the Deputy Chair.
Thanks very much, Chair. What is the current timeline and milestone plan for CHSP integration into supported home, and what risk assessment has been done to ensure continuity of meals, transport and social supports?
So thank you, Senator. The government has announced that the Commonwealth Home Support Program will not roll into the Support at Home program any earlier than the 1st of July 2027. So between now and then, all current services remain operational, and so access to those services remain they're operational, as I said. In terms of the milestone plan, that's currently something that we are working through. We would do that through advice to government, but also with a deep level of consultation with the sector and with other affected parties.
Do you have a time frame for that milestone plan to be completed by?
Not at this stage.
Okay. Has the department modelled the impact of closing CHSP on demand for support at home in 2027? I did ask this question on notice at the inquiry and didn't get a...
So, not specifically, no, at this
Okay.
stage. That will form part of the milestone plan that we just talked about as well.
Okay. What consideration has been given to the expected closure of the CHSP in 2027? Is it confirmed that the program will be closing then?
So, back to my previous statement, government has announced that it will not roll into the support at home program any earlier than the 1st of July 2027.
I guess the question is that providers and older people need certainty. We heard at the inquiry that we've already got providers who are exiting CHSP because they've said there is no certainty. I think you'd have to agree that saying it won't close before a date is not clear. So has the department made a recommendation to the minister or the government around whether funding will continue past 1 July 2027?
No, Senator.
Okay. Is the intention...
Senator, sorry, I could add an addendum to that. Julia Atkinson, an Acting Assistant Secretary, Access and Home Support Division. The funding will continue. The form in which it will continue, the government has not made an announcement on beyond that it will not roll into support at home until sooner than 2027.
Okay. So is the intention, once CHSP is rolled into support at home, that everyone who is currently supported through CHSP will go onto a support at home package? So that's all 800,000 people that currently are on CHSP?
The details of exactly how that will work, Senator, are to be determined and will be considered by government.
Okay. In the budget, it looks like there's no additional funding for additional support at home packages beyond the 83,000 coming in the financial year to the middle of next year. Is that correct?
That is not correct. In the MyFO context last year, I forget the exact figures, but there was a $4.2 billion announcement around the funding for the support at home program over the forward estimates period.
Okay, so how many packages in total would that cover? And so roughly how many per year?
So that will cover, I'll give you the answer for the first year of the operation of the support at home program, that will cover the 320-odd thousand people who will transition from the home care packages program into the support at home program.
So that's, sorry, is that people who are currently on a home care package that transition across?
Will be by the 31st of October, so that's the 320-odd thousand, plus the additional 63,000, which is the 83,000 that I mentioned before, minus the 20,000 that are already being rolled out.
Yep. So my question is there any additional funding provided for beyond the additional 83,000 and the people who already have a package and who are coming across?
Yes, we have an appropriation for the forward estimates period.
Yeah, and roughly how many packages will that cover?
Over the next 10 years, we'll be funding an additional 300,000 places, so by 2034-35.
So it's roughly 30,000 a year?
Roughly 30,000 a year.
Okay, but we currently have a wait list of 200,000.
No, we have a wait list of 121,000 on the NPS.
And the 100 or so thousand who are waiting for an assessment.
Yes. Well, Ms Blackwood might like to provide some additional context around those data points when she comes to the table. I'm sure she will come to the table later on in this session.
Okay.
Yeah.
Noting your evidence that it's roughly 30,000 packages a year for the next decade, Professor Cathy Eager, who was a former advisor to the Royal Commission, has forecast that the demand for support at home and she said that without more packages, so more than 30,000 a year, the majority of seniors will be denied home care support in 5 years. Is she right?
That is not my understanding. So what we have modelled and what we have funded is that number of packages entering the system, and that's predicated on an average 3-month wait time to receive access to services by the end of the second year of the Support at Home program.
So your modelling shows that everybody who's applying for a package will only wait 3 months by the end of that period in a decade?
No, by the end of the second year
Yep.
of the Support at Home program. That is the government's commitment at this time.
Okay. So what is the plan to get the wait time down to 3 months?
Well, we'll be rolling out those additional packages. And to your earlier point, there will be some improvements made, and we're already seeing positive trends in terms of assessment data. So those volumes being pushed through the system at a more rapid pace.
Does that account then for the 800,000 or so people who are currently on CHSP who would also have to transition across to Support at Home? And the reason I ask that question is because Professor Kathy Eager has also said that it's not going to be possible to hit your waitlist target while also closing CHSP and transporting those 800,000 across. And I note that you said you haven't done any modelling on closing it, so I'm wondering how the department is sure it's going to hit their target if those 800,000 people are transitioning across.
So we model based on the assumption that they would all be in the program from that point in time.
So it's modelled on 800,000 people on CHSP coming into the program in 2027?
That is my understanding, yes.
It's Sonia Stewart, a Deputy Secretary of the Aged Care and Aged Care Group. I just wanted to add something in terms of Mr Pugh's response, and I completely understand that we're focused on an aspect here which is the wait list, but I think it's also important to give the context in terms of the overall reforms. So of course the packages and the rollout and the Support at Home is one aspect of that, and a very important aspect of that. I think it's also important to note that the government's made a commitment around strengthening Medicare and access for older people into GPs and when they need that sort of assistance. There's also a complete change in terms of the way that people get assessed into the system and a single point of assessment, and also changes to the tool that's used and changes and improvements in terms of the workforce and standards and quality. So I just think it's important in terms of that overall context that what we're seeing is huge reform across the whole system, and we have done that modelling, and it is about meeting that commitment 2 years after the Support at Home program starts on the 1st of November.
Okay. I'm somewhat confused by the fact that when we asked the question in the OPD about have you done modelling on Support at Home closing, the answer was no. But now I'm hearing that there's modelling that's been done taking into account the support at all those CHSP 800,000 coming into the other program. So that's why I'm confused. So if you can unconfuse me, that'd be helpful.
Yeah, and sorry, I probably can correct the record there. So we've obviously done a lot of modelling around a lot of different options. Government hasn't made a decision around what that final roll out, so what the final transition of the CHSP into Support at Home will look like.
Okay,
and at what date.
So if you've modelled a range of scenarios, so I'm just trying to make sure I understand because I don't want to be going off on the wrong information. So if you're telling me you've modelled a range of scenarios, but the government hasn't decided yet what's happening with Support at Home, how does the answer you gave me earlier about 300 current packages that are already out there plus 30,000 a year accounting for everybody, including the 800,000 who would be coming from CHSP to Support at Home?
I think there's a sequencing, an opportunity to talk about the sequencing here. So the commitment that has been made around the average time to wait is around the Support at Home program 2 years after it starts. And then the other commitment is around the CHSP program, which is a bulk of older people living in Australia, and that they would start to transition and move into that program at that date. So I think that there's a sequencing thing, and yes. Mr Pugh is correct in terms of we haven't done the modelling of that. We've got to be doing the planning for that. The focus of this is the Support at Home program that starts on the 1st of November this year.
So just so I'm fully clear, they're two separate things, and right now the modelling that you have done on getting down to your wait times, etc., is only on the 300,000 who are currently going to transition across to support at home, who currently have home care packages and they're transferring across, plus the additional 30,000 that are going to roll out every year for a decade. And in terms of those 800,000 who are currently sitting on CHSP, there hasn't been any modelling done yet, and so it wouldn't be possible to answer a question around how will that impact wait times for support at home if they are all rolled into support at home, because that hasn't been done yet.
Correct. The modelling hasn't been done, although, and there might be others in the room that might be able to speak to this. There is an assumption and understanding that cohort that they tend to be sort of lower level users, so in terms of where they might go into that system in terms of those packages.
Although we did hear at the inquiry that there are large numbers of CHSP providers who are supporting people with much higher needs because they're waiting for their home care package. Okay, I think I understand where that's at now. Just coming to one final question. Do you have any specific initiatives that are funded to recruit and retain CHSP staff in rural and regional areas, including travel or training incentives?
I might get Miss Pond.
And if it's long and lengthy, I'm very happy to take on notice the broader detail, but keen to know if you have some, and then if you do, maybe if you want to give me more detail on notice.
Senator. Be helpful.
Thanks very much, Senator, for your question. Emily Harper, First Assistant Secretary of the Market and Workforce Division. Senator, it actually is probably likely to be quite a long and lengthy response, which we are more than happy to provide extensive detail on.
Okay.
I might ask my colleague Ms Milful to talk in a moment about some of the focus on rural and remote areas in particular, but we do have broad-reaching initiatives that really do target access not only to training, but also to recruitment and retention in rural and remote areas. We do have a continued sort of focus on encouraging, where possible as well, direct employment of workforce in those areas. We are seeing really positive trends in terms of direct employment more generally, which is fantastic because obviously it reduces those expenses for providers and really importantly ensures that connection to older people and the continuity of that relationship. We do note that in those, particularly those very rural and remote areas, there are real challenges, so we see that proportion of direct employment really drop off. So it's a consistent focus of sort of training, incentivising and encouraging local community members to take on board, you know, a role in aged care, and whether or not that's starting in a more junior position to advancing to a more sort of senior position, really ensuring that there's a pathway within communities. The other comment I would just make, Senator, and very happy to step this out for you in quite some detail because there's a lot of programs that cover off.
As I said, I'm happy to get, if you can give me on notice what they are, rather than to take up time now. Is there anything that you wanted to add, Ms Milfield, sort of in a summary before I take the rest on notice, or you take the rest on notice?
Kathy Milfield, Acting Assistant Secretary, Thin Market Senator. Look, we're very happy to give you a detailed list. I think I would just add, the government is continuing to invest in heavily to support service delivery in rural and remote, including workforce supports. I wouldn't say necessarily, specific CHSP initiatives, but we have very specific programs. For example, the Regional Rural Remote Home Care Workforce Support Program to attract 4,000 more home care workers. We've got the Rural Lap Assistance Program, Indigenous Employment Initiative. So there's a number of things that go to the workforce measures that Ms Harper was talking about. But also, I guess, just say alongside the broader support at home reform work, as part of Thin Markets branch, we're also doing a lot of work looking at longer term, what are the policy settings that will actually, identify any remaining gaps in regional rural and remote aged care policy, particularly as the changes come in on 1 November. So you might be aware we're reviewing, for example, the MMM, the Remoteness Classification System, and we're actually now working to develop a regional rural and remote aged care framework and work plan. So if Senator, we feel that there's gaps that still need to be addressed to make sure those supports are targeted. We've got a plan to move forward with that.
Great, thank you. And just in the response on notice, if there are any programs that specifically target CHSP or include CHSP, could you make that clear in that response? Thank you, I appreciate that. Are you happy for me to keep going, or do you want to turn?
I don't mind, whenever.
Are you fine for me to keep going?
5 minutes if you
All right.
can.
Yep. Yeah, and then I'll share and I'll come back. Just want to go to issues around co-payments with support at home and the safety net. So I'm interested to know, first of all, how were the percentages for co-contributions for those co-payments calculated? I'm particularly interested to know who did the work. My understanding is that it wasn't the task force. So was it Treasury or was it Cabinet? Who did that work?
Senator Susan Traynor, Acting First Assistant Secretary, Residential Care Division. So the Aged Care Task Force made recommendations at a higher level about conceptual recommendations around what services classifications. They made the specific recommendation around clinical care being fully funded by government, which was accepted in the co-contribution model that we have. And they made recommendations about the three levels in terms of how that translated to the actual specific 5 to 50% and 17.5 to 80%. That was work that the department did. Worked up a range of scenarios for government consideration, and then it was a decision of government as to how that was turned into the rates that we have now.
Okay, so was the government given a range of options for percentages?
I couldn't talk to sort of the details of what options those would be, but over the period we considered, we modelled up what those would look like and what impacts those would have on people and on providers, as well as on the fiscal impact.
Okay, so was modelling done to determine the impact on full pensioners, part pensioners and self-funded retirees as cohorts?
So we have done prepared a range of case studies that are now publicly available, as well as considered what that looked like at those different levels for people based on what we expect average package consumption to look like in terms of how a person uses the clinical, the independence and everyday living at different stages of their time in the supported home program.
So you're saying the case studies that have been made public, that formed part of the modelling that was given to the Minister to help make the decision?
It's probably more accurate to say that those case studies are based off the model, and that model is what's built into the Services Australia system for completing means assessments for people ongoing as well.
Okay. Has the government done any modelling, or the department I should say, done any modelling on what will happen to hourly rates now that providers can no longer charge management or administration fees, and what will be the likely increase in hourly rates?
Grabbing one of my colleagues up at the table, thanks.
Apologies, Senator, I caught the second half of the question.
Yeah, sorry, Ms Snow. So the question was, has the department done any modelling on what is going to happen or likely to happen to hourly rates now that providers can no longer charge management or administration fees? And if you have you come to a view of what will be the likely increase in hourly rates?
Thank you. So Jasmine Snow, Acting Assistant Secretary, Access and Support Division. We've obviously done some internal modelling to think about what the settings could do to the market. That has been informed by a survey we did earlier this year where we asked providers to provide advice about indicative prices. But as the committee would be aware, it's obviously up to providers to set their prices as they do today under the Home Care Packages program. And we see a variance of about 4% in prices across that program today. So obviously some settings are changing, but it is similar in terms of the price setting that does occur under the current program.
When you say 4%, do you mean a variance in 4% between the highest increase that a provider has said they might make versus the lowest increase, or that you think they will increase by 4%?
Apologies, my 4% was about what happens today under the Home Care Packages program. We see on average a variance of 4% when people are setting their prices under the current program.
But my question is that when you say 4% and you say variance, as in a variance of 4% between the lowest and the highest fee charged,
Yes.
or 4% increase?
4% between the lowest and the highest.
Okay. Share the call. Can I just finish this question? So have you got, based on the survey of providers, have you got information on what the likely increase will be?
We have done some internal planning, but we are reluctant to say that that is what will happen because providers are still obviously working on service agreements with participants.
Okay, has the government considered the impact that it will have on older people in having to pay those higher fees?
Of course, and I might invite Ms Traynor to provide some information about the hardship arrangements that will be in place under supported home.
I'll leave it there because I will come back to hardship and I know I need to share the call.
Thank you. Senator Ruston.
Thank you. I asked you earlier this morning in relation to the person on the DSOA, so I'm just wondering if I could just ask some questions here. I have the permission, but I won't use his name. But if there is a point at which you wish, I mean, I'm more than happy to show you the permission, but I won't use his name so that you don't...
As discussed, we can't work on the basis that we can talk about an actual individual unless we would have consent, and even then we'd be concerned about doing in public forum the discussion of an individual. If you're effectively putting forward a cameo or a case study and asking us to respond to how that would be dealt with, then that's fine, but we obviously can't talk about
Okay, well, I'm just hoping that maybe after I give you the story that you might feel that he's been hardly done by and you might action it, because so far, after, when you hear what I've got to say, you'll see he has been put through hell. So I'm now going to appeal to you, Mr Comley, to take action to sort this out for him. So the person who I'm talking about became an incomplete quadriplegic in 2010. He was under the age of 65 when this occurred to him. As we sit here, and at the time when, because by the time the NDIS came into place, he had aged out of being able to go into the NDIS. He remained on the Disability Services for Older Australians program, which we are now talking about. Last year, he applied for respite with the department through the DSOA, and was told that because of some problem with a computer system error over 3 months, he was told that he wasn't able to obtain respite through this. He was told that he needed to obtain respite through ACAT. So the gentleman, the reason he needed the respite at the time was that his wife had been diagnosed with cancer and was undertaking in-hospital cancer treatment and was unable to continue with his care because she was his carer. The gentleman went to get the ACAS assessment for respite. However, he was unaware at the time that if you get an ACAT assessment in totality for a home care package, your DSOA package is capped. He was not seeking that. He was merely seeking temporary respite while his wife was undergoing her in-hospital treatment. However, for some reason and without his consent, the ACAT assessor assessed and made application to the department for a home care package. He was then informed that his DSOA was now capped, and there was nothing that he could do about it. He made application through a number of means, including seeking for a judgment in relation to this with the Aged Care Quality and Safety Commissioner. He went initially to the NDIS Complaints Commission. They told him the issue didn't fall within their jurisdiction. He then made a complaint to the Commonwealth Ombudsman, who completed an investigation, and the Ombudsman recommended the capping be revoked, but the department refused again. A second attempt was made to the NDIS Complaints Commission, which they eventually accepted was their responsibility, and so the complaint was lodged with the ACAT Tribunal. Was advised that it was lodged with the ACAT Tribunal. To our understanding, there's no such thing as the ACAT Tribunal. And so as we sit here today, the person concerned has made representation to the Minister, Minister Shorten, Minister Butler, Minister Cook in South Australia, and these were all, but were all sent back to you as the department.
Today, as we're sitting here, the person concerned is moving to become a complete quadriplegic because of the deterioration of his condition. He has been assessed by the people who are providing his care as requiring significantly increased care because of the deterioration of his condition. It appears as if nobody is arguing with the fact that he did not consent to having an ACAT assessment done for a full home care package, but for some reason the department and everybody else that he's contacted has refused to overturn that decision to enable him to continue to get the care that he is requiring and would otherwise have been receiving had it not been for the failure of the department in the first instance to tell him that he couldn't get an assessment for respite under DSOA, which we believe he could have, made him go to an ACAT assessment. The ACAT assessment was wrongly applied and wrongly administered, and as we sit here today, the gentleman has his condition significantly deteriorated, and quite frankly, it is totally unacceptable that he has not had any remedy for what quite apparently appear to be failures that were not of his own making. So I won't use his name today, but I plead with you, could somebody actually please take this seriously?
Thank you very much for sharing that, and I'm genuinely sorry to hear of his deterioration. I would be very willing to meet with you and him privately to discuss his matter. So I give that invitation with sincerity and would be interested in following that up with you.
Well, just an immediate internal review. I'll provide you off camera. I'll provide you with the gentleman's details.
Thank you.
And if we could get this resolved as quickly as possible, because the gentleman doesn't have a lot of time. Okay, so can I go to the packages? So today you provided me with information on questions that I asked you, and you provided me with information about how many people were on the National Priority System wait list. And can I confirm that since you last gave me information, which was at the end of July 2025, that we have seen an increase of nearly 13,000 additional people have gone onto the National Priority System in that time?
Yes, that's correct. I do think it's important, though, and I wonder if Ms Snow is there, I think it's important to express the delineation between the NPS and the wait list. Are you able to do that?
Yeah, very, very happy to do so.
The NPS and what?
So obviously the National Priority System is the queue, as we've discussed before, but that people may be seeking services through other programs whilst they are sitting.
Did you say sneaking services?
Seeking
services. But they're on... I was happy you didn't say that. But they're on the National Priority System, and you've provided me with this. So we've gone from March to September from 87,000 to 122,000. We seem to have a fairly static amount of people that are still waiting to get assessment, of around 120,000 people. So how many packages were released by the 30th of September 2025 from the 1st of July to the 30th of September 2025?
Through till the 30th of September, we had 3,665 by the 30th of September.
Of the package, of the 20,000 packages that were legislated.
Yeah.
Could you explain to me the Aged Care Accommodation Payment Security Levy Amendment Bill that was passed on the same day as the ACOLA Bill received royal assent on the 5th of September, whereas the Aged Care and Other Legislation Amendment Bill didn't receive royal assent until the 19th of September, some 15 days after the other bill. Why didn't they occur on the same day?
Good afternoon, Senator. I'm Robert Day, Assistant Secretary in the Quality and Assurance Division. The process of royal assent is something that's managed by the Office of Parliamentary Counsel. I don't have a great deal of visibility about what happened between those two events, other than the levy bill got assent on the 5th of September, and other legislation that was then passed on the 5th. Sorry, I might have me and my date slightly mixed up.
15th, the 19th of September, 15 days later.
The two pieces of legislation that were passed on that Thursday of the last sitting week both received assent on the same day, on the 19th. So there wasn't anything different about the treatment of the ACOLA bill, but that was the time that assent process took.
So you said there wasn't any difference. I mean, the accommodation payment security levy bill was received royal assent on the 5th, and the ACOLA bill received on the 19th of September. I'm just keen to understand why.
Yeah. So I think what I was trying to articulate for you is the levy bill passed both houses a day earlier than ACOLA, and it then got assent the following day. The ACOLA bill and another bill, the Treasury Laws Amendment Bill that was passed on the Thursday of that sitting week, both didn't get assent until the 19th.
So there was no Executive Council in the intervening week?
As I say, the process is managed by the Office of Parliamentary Counsel. There wasn't an intervention one way or the other from the department.
I'm not sure the department can answer that question for you because it's not managed by them.
Well, maybe you can answer.
We're happy to take it on notice, Senator. I mean, but as you know, with your experience, that Executive Council doesn't meet every day, so we'll take on notice whether it got to the first available Executive Council.
It would be an unusual thing for Executive Council not to meet every week.
Well, let's take that on notice. My experience, Executive Council meets infrequently.
One of the provisions, one of the amendments, and I think it's actually, it was my amendment or Senator Ormond's Payne amendment, actually required the packages to be immediately released on royal assent. Now, Mr Pugh I think it was Mr Pugh just told me, of the 20,000 packages, only 3,665 had been released on the 30th of September, which is some 11 days after it received royal assent. So we've still got, 16,500 packages hadn't been released by the end of the month. It's really quite interesting that, one bill gets royal assent and the other bill doesn't get it for another 2 weeks later, despite the fact that that provision was put into the bill and the government voted against that provision.
Senator, perhaps I can just add some explanation for you. So Amy Laffin, First Assistant Secretary, Quality and Assurance Division. So the levy bill didn't have any amendments made, but the ACOLA bill did. And because of that, it needed to be approved by both the President of the Senate and the Speaker of the House before transmission to the Governor-General. And the Speaker's approval, I think, took a little bit longer than is usual. And OPC, as Mr Day suggested, was handling that process.
Okay. All right. Well, given the importance of this bill, I would have thought that every effort would have been made to have got the thing through, but I also would suggest that every effort might have been made for the 20,000 packages to have been released by now. I mean, the fact as we sit here today, we've just advised so few by the 30th of September, and you've still not released half of them to date, and you're obviously saying you'll get them done by the end of October, but you were required to release them at royal assent, which you haven't done. So could I ask you then, how do you decide where to...
Just to clarify that, Senator. Yep. So the intention behind those 20,000 was to have them released between the date of royal assent and before the commencement of the Support at Home program. And so we took the approach of literally dividing 20,000 by 6, and you get an uneven number with the decimal place and a few bits after it. So we just literally rounded to the closest whole figure, and that informed the rollout cadence. We also have some system limitations where you can only release 3,000 packages per day, and don't forget that we are also releasing, I promise, that is a system limitation. We are also releasing the additional 2,000 plus recycled packages per week as well. So on a midnight on a Tuesday and a midnight on a Wednesday, these packages go out. Yeah.
But your maths would tell you that 3,000 a day, you could have had them all out in a couple of weeks, and you haven't. But so can I just actually ask you, Minister, if you could maybe find out why there was a unusual delay with the Speaker in terms of him providing the necessary sign-off on this.
Yeah, we can take on. I mean, I don't think it's relevant to this committee. I think it's a question around EXCO, but we'll find an answer for you.
Well, it is relevant to this committee because of the impact.
No, I mean
its delay.
who might hold the answer, and that can be.
Yeah, sure. But if you could find out that, we'll take it on notice.
Sure.
Thank you. How do you decide where a package is released?
So we have the national prioritisation system, and where the package is released, we don't do that on a geographical basis. The package is allocated to the next person in the queue, and that is based on the length of time they've been waiting and their assessment outcomes, so their priorities. So we talk about high priority people getting access to their package within 1 month, so those people will get something that's been assessed at a lower level, and it's literally the next person who falls due for their package gets it. We do not discriminate based on where you are across the country.
No, I wasn't suggesting you were discriminating. I'm just keen to understand. So you've got 120-odd thousand people that are lined up on a list here. I mean, I understand priority one, but they're not very many of them in comparison to the number of people that are on the medium list. So how do you make that decision? I mean, are you prioritised within the medium range in terms of length of time and the level of need?
Is literally when you get to the top of the queue based on your priority order. You have waited your set amount of time, you're at the top of the queue, you get your package.
Yeah. Are people on lower packages than assessed included in these figures?
In the numbers that we gave you on in advance, they are, yes, I think.
The 121 or 121,909 people who are waiting for a package they've been assessed as needing, does that include the 16,000 people who are on a package that's actually lower than they've been assessed as needing?
Yeah, it does, yes.
Yeah, so they're included in those numbers. Yeah, okay. So how many people on the MPS are in hospital?
Do we have that done? I'll have to have that one on notice. I can get back to you in this session if I possibly can. I don't have that in front of me, sorry.
So, Minister, do you know how many people on the MPS have passed away between the 1st of July this year and the 30th of September?
Thank you for the question. Obviously, it's really heartbreaking to hear that people pass away on waiting for care. That's exactly why we're trying to deliver these changes. I've got a figure for you around people who've passed away on the national priority system in this financial year. I can confirm that for you. Sadly, 4,812 Australians have passed away on the national priority system in 2024-25.
Sorry, so you said 24-25, it was 4,000?
Yeah, is that the...
No, I was asking how many people had passed away between the 1st of July this year and the 30th of September this year.
Oh, I'm sorry, I don't have that breakdown, but I do have the full financial year for you, the previous financial year, and of course, it's, awful to hear that that's happened. We certainly want to bring about these changes to try to prevent that as much as possible.
I'm keen to understand if there's been any budgetary implication. Sorry, up to the department. I'm just keen to understand if there has been any budgetary implication when the budgets would have been set for funding to a home care or supported home or care that's delivered in the home. They would have been set on the basis that you were going to start the supported home program on the 1st of July 2025. We have seen basically the withholding of all new packages, with the exception of the few that you've just mentioned, Mr Pugh, for a period between the 1st of July and the 30th of September. So that means that these packages haven't been funded for anyone because the care has not been provided, because the packages haven't been released. Just keen to understand if there are any budgetary implications for the withholding of this care, basically for 3 months.
So I know that you've used the words withholding care. In terms of the 83,000 packages, they have been budgeted, and any changes to the sequencing of those will be addressed in the forward budget processes that will be announced by government.
So, as we sit here today, Ms.
I'm
Stewart...
sorry, but I can't hear you. I'm not sure if it's me. I'm sorry, Senator Ruston. I can't...
sorry, I can yell. I just
might
try.
be me.
I just don't want you to think I'm yelling at you.
No.
Yeah. So I'm just interested to understand, Ms. Stewart, on the basis of what you've just said. What was the trajectory of release of packages for 25-26 that was anticipated when you were believing that you were moving to support at home on the 1st of July? Because at the time you said there was going to be 83,000 packages. We've subsequently now had to legislate for that to happen. But when you were intending to start this program on the 1st of July, you must have had a rollout plan as to when these packages were going to be released.
Mr Pugh can answer that, yeah.
I'm happy to take that question. I don't have the numbers specifically in front of me, but it might be helpful to revisit the way that the system governor and the legislative basis provides for the allocation of packages. So the Aged Care Act 2024 prescribes the method by which those places will be allocated, and that doesn't require the minister to prescribe how many places, but just the method about how those number of places will be allocated. So
excuse me, Mr Pugh, in order to be able to have put a funding allocation against 25-26, you must have known what the profiling of those packages. Otherwise, you couldn't have come up with a number. So clearly, you must have profiled those packages, and I'm just keen to understand what the profiling. I get the Act doesn't say that you have to, but for budgetary purposes, you must have done it.
Yes, but that modelling would be subject to cabinet deliberations, and I don't think I'm at liberty to advise either in this forum or on notice. Sorry, Senator.
Okay, so when will we see the savings that has occurred because no new packages have been released in this 3-month period?
Senator, the Treasurer came out as part of the deferral announcement and announced that there were no savings attached to the deferral period. In fact, there was a cost attached to it. That's been out in the public domain. Okay, so could you explain to me how that cost would have occurred? What was the cost of the delay? Well, the Treasurer has announced that the cost of the delay was around the $900 million mark, and there were a range of factors that are incorporated into that. The two main drivers would be the loss of co-contributions under the Support at Home program, but also the cost of maintaining people in a home care package, which is around $5,000 more expensive than an equivalent Support at Home package. There are other cost drivers. These will all be published in the MyEFO context. So can you just unpack that for me? You just said that somebody who's on a home care package, when they got a Support at Home package, would be $5,000 less. At an equivalent level. But I thought the majority of people were grandfathered.
Sorry, I think we're talking about the structure of moving from 4 home care packages to 8, so by having more granular funding tiers within the new
But you're not going to take somebody who's been assessed as needing this level of care and then tell them they can have $5,000. Yes.
Grandfathered people retain their current.
So I contest, Mr Pugh, that your argument around the $5,000 is irrelevant. It doesn't make any sense. Well, the allocation of funding on the Support Home is more efficient, and we have seen some inefficiencies in the home care package program, and that is shown by the public data on utilisation rates and the like. So, and yet, in your funding envelope, in terms of the profiling of the funding for the changes to the Aged Care Act, you actually run for the first few years at a loss. So you're saying by not bringing it in, it's cost you, and yet by bringing it in, it was going to cost you. That doesn't make any sense either.
The officials have said, and I think this is a matter of public record, that there wasn't any savings in terms of deferring and actually what the costs will be.
No, that's exactly what they said. That's exactly what they said, and that's my question is about that.
That's exactly, and I'm clearing that up for you, and that'll be in MyEFO, what the costs were.
Senator Ross, I'm just seeking some clarity on how much more time you needed as we head rapidly to the, and I had tried to be fair between allocating the call. If I can temporarily allocate the call to Senator Nandaraja before we head off to dinner. I mean, I would like some more time. We'd all like more time. But I'm not getting a lot of it. I'm happy to change topics if that's what you'd like me to do. How much time would you need?
well, it's 7 minutes to go. I'm quite happy to... But we're coming back after dinner.
If you can hold off until after dinner, we'd be grateful. That would help very much so. So I'll allocate the call to Senator Anandaraja.
Thank you, Chair. I'm interested in First Nations and our approach to aged care in this community. It's a priority for the government. I'm just concerned we're not going to be discussing it in this session, and I think it's important to raise it in this session earlier rather than later.
Thanks, Senator.
Thank you for your question. I might start off and then ask Ms Harper and Mr Payne to go into some details. So I think the first thing to focus on is the Act. And for the first time, the Act is going to be older person-centric, and particularly for Aboriginal and Torres Strait Islander people in terms of culture and trauma-informed, which I think is very important. I think there's other key aspects in terms of the whole system with the piloting of an assessment pathway for Aboriginal and Torres Strait Islander older people, our elders. There's also expectations of the providers in terms of quality and standards. And I think the other thing I would say before I'm handing on is that the voice of our, as an Aboriginal woman, the voice of our elders is very important in terms of listening to them through the Council of Elders, and as well as an evaluation and ensuring that Aboriginal and Torres Strait Islander people access to the levels that they represent in the population. And I'll hand over to Ms Harper to go into some more detail.
Could you also talk a little bit about culturally appropriate care and how it will be provided through this system? I think that's really important.
Thank you very much, Senator, for your question. Emily Harper, First Assistant Secretary of the Market and Workforce Division. I will hand to Ms Tati-Pater very shortly to take you through in a little more detail. As pointed out and reflected on, that focus on putting the older person at the centre of everything that we do is really key, and obviously no more so than in the First Nations aged care space. And the importance of culturally appropriate care and ensuring that we equip all providers, whether or not they are, whether or not we are drawing and learning from our Aboriginal community-controlled organisations in this process, or we are looking to uplift and upskill all providers across Australia who are providing care to older First Nations Australians is a real focus of government at this stage. There are a range of initiatives that we have in place.
Please describe some of those. That would be great.
Thank you for the question, Senator. My name's Chanel Tati-Pater from Market and Workforce Division. Some of the initiatives that are existing, as well as there's been further investment in, is around the Elder Care Support Program, which is work that we've undertaken with NATO and partnering with our Aboriginal community-controlled organisations as well. The focus of this workforce is to work directly with the older Aboriginal and Torres Strait Islander people as well as elders to navigate, ready them for the aged care system, but also support them through their aged care service experience as well. We also have the Indigenous Employment Initiative, which my colleague mentioned earlier, around the rural and remote, which is really focused on increasing Aboriginal and Torres Strait Islander people working in aged care through entry-level employment and non-clinical type support. Additionally, we also have our National Aboriginal and Torres Strait Islander Flexible Aged Care Program, which is also really focused on working, in a culturally safe way with our elders as well, and meeting their changing needs as they navigate the aged care system as well.
And has the Indigenous Workforce Initiative started? Has that kicked off?
Yeah,
that pathway?
that's been a program that's
Do you know how many people are going through the training program, or could you take it on notice?
In terms of the Indigenous Employment Initiative, we have currently employed 1,016 Aboriginal and Torres Strait Islander people working currently.
And are you seeing a lot of interest in that program?
Yes.
Okay. How do people find out about it if they're interested?
Oh, so that is a grant opportunity that we work with our aged care service providers and identify where need is, particularly in remote areas.
Okay. And with respect to the quality and standards you mentioned, Deputy Secretary, perhaps you could just elaborate. Are they any different to the broader quality and standards that we're implementing throughout the whole sector? there's been a huge change, obviously.
Yeah.
Are there any nuances to First Nations communities?
Hello, Senator. My name is Ingrid Leonard, Assistant Secretary, Quality and Assurance Division. So the strengthened quality standards certainly, which will take effect from 1 November this year, include requirements to deliver specifically culturally safe and appropriate care for Aboriginal and Torres Strait Islander people. And there are a number of the standards which have quite specific requirements. In particular, Standard 1, which deals with person-centred care, requires providers to demonstrate that they understand individuals, including their identity, their background, their culture and their diversity. And also of relevance is Standard 3, relating to the delivery of funded aged care services, that providers must demonstrate that aged care services are delivered in a way that is culturally safe and culturally appropriate for individuals. So those changes to the strengthened standards represent a significant uplift and focus on culturally appropriate care.
Okay, and my last question, and you've only got a minute, is can you just describe to us the engagement you had with stakeholders in formulating this approach and the government? Yeah.
Strengthened aged care quality standards? Certainly. So there was a review of the standards following the Aged Care Royal Commission, which involved a significant number of consultations with a variety of stakeholders, including First Nations people, aged care providers, older Australians, families and representatives. And that really identified the need for specific mention of culturally safe and appropriate care.
Thank you. I think
that's it. Thank you very much. Thank you. And the committee will suspend now for the dinner break and return at 7 p.m. Thank you.